It wouldn't let me join us from, so,
Well, is the Zoom link?
oh, no, it's,
Oh, it's Kelly's.
yeah,
Okay, so that's fine.
yeah.
Okay, good. Perfect.
Yes.
There's Mike here.
Yeah, so, let's see, can unmute, and then it should work. Like, just-
Thank you.
So good morning, everybody. It's really good to see everybody here this morning. The air conditioning, I'm told, will kick on in earnest soon. It's New York, right? So that's gonna happen. So thanks for coming. I'm Eric Schmidt, president of the OGS. Really glad to see everybody. We're just super happy to be able to host this program. This fits in one of our missions to kind of help, give back some of our intellectual knowledge base that we possess in the OGS and pass on, and hopefully y'all can pass that on too. When Mark puts this program together, he always talks about this is going to be a great program. It's going to be a great program. This is really going to be a great program. This is we have really truly some of the best glaucoma lines in the world live and on the street. We're also broadcast this, but we're taping this. People are going to be watching virtually in their jammies from home to perhaps too. But the good thing about this is we're going to have a lot of time for dialogue today. We want to provide quality, but we want to be able to use this quality and hopefully we can take it back and so we can pass it on to the next generation. So thanks for being here. It's really great to see everybody. We'll have time to chat later during the day. I'm going to turn it over to Murray, who's this is his passion and this is his program. And thank you, man, and honored to be here. Thanks.
Thank you, Eric. Good morning, everybody. So we had started this. Kelly's is like the 7th. Kelly's is the 6th. So we had started this, and the idea was always to educate the educators, because being in optometry schools, we have a host of optometry schools, and we have some people that have been lecturing and seasoned speakers who are very familiar with glaucoma, and there are other new faculty that we want to try to help any way we can. And the idea is just to get everybody into the family. Because optometry is very involved in glaucoma, and we want to do everything we can. I try to put a program together that goes into where new ideas, and that's what you're going to hear about today, whether it's, Tony being our first talking about SLT and how that's evolving into, perhaps the main primary therapy down the road, or we have Gus Desmarais here, who has done other meetings with us, who is local, and we have Don Hood, and as well as Simon John this afternoon. So we always, we try to bring new things. And my challenge is that I don't want to hold a meeting that's no different in the topics than CE programs you can attend anywhere. It's really that simple. So I thank everybody for coming. Next year we will. So if you're with us last year in Florida at Baskin Palmer, what my mission is to try to alternate between optometry schools and departments of ophthalmology, just because I think that's a good cross-pollination. And next year we will be in San Diego. Bob Weinrab will be hosting us, University of California, San Diego. and we look forward to seeing everybody there using the faculty from UCSD. I mean, this year, aside from Tony, most of the faculty is Columbia, and I was joking with Jack Giappi that this really is a large part Columbia faculty. But right now, it's just going to test. Columbia is a little bit of an upheaval as they're building. I mean, they've been moved out of their building and they're around the campus as they're building a new site. I would like to mention we have a guest, Elena Sturman, the CEO of the Glaucoma Foundation. Elena is in the back. I've been on the board of the Glaucoma Foundation for more than 30 years. It's an organization. Mission is to really reduce the burden of glaucoma on the patients we take care of. In terms of an organization who has that it's very friendly and will work with optometry. The Glaucoma Foundation is in fact we even considered holding our main meeting right in this space. I mean, so please, if you have a chance to take a moment to say hi to Elaine as she's still learning more about optometry. I thank everybody for coming. Thank all the sponsors because this is a program we could not do without the companies involved because it takes a mountain. We will have the last hour will be a discussion. Danica last night came up. We used to run a resident program in addition to the educators. Ran into compliance issues when we went to different sites. We'd like to talk to everybody because we would like to bring that back. And with that, our first moderator is Danica.
Thank you, Larry. I want to also add my welcome to everybody, but I really want to get started because I want to give Dr. Riolini time to talk to us about SLT. Many of us have heard him before we presented at our annual meeting. When I think about Dr. Riolini, there are two things I think about. One is obviously SLT, but the other one is challenging dogma. When I hear his name, that's what I think about. And I think as educators, that's really what we need to do is challenge dogma, not perpetuate it. And I think that you were one of the people that sort of first opened my eyes to that. So I think it's really an interesting thing. Dr. Riolini is a professor of ophthalmology, director of the Glaucoma Fellowship, and vice chair of clinical research at West Virginia University School of Medicine. And what he's going to talk to us about today is his work in the SPI in the COAST trial and where SLT is now and where it's headed. So thank you for joining us this morning.
Awesome, great. Well, thanks everybody. I appreciate the opportunity to be here. It's a pleasure and a privilege to be in front of this august body. Marie was telling me that the goal here is to educate the educators, and I think that's the most important thing that we do. So let's get started. Thank you so much for those kind words. Challenging dogma. The first day of my fellowship with Rob Fechner in Louisville, Kentucky, and Tom Zimmerman, I'd worked with Rob Fechner for maybe 18 minutes when he sort of reared back a little bit like this and looked at me and said, "You're the guy who walks up and rubs the cat the wrong way just to see what'll happen, aren't you?" And that sort of set the tone for a very interesting year. Because Rob really likes things to go smoothly, and I refuse to play by those rules. Let's see. Murray gave me an hour and a half. I mean, what kind of a sadistic bastard are you? I mean, these are poor people. I'm the biggest fan of the sound of my own voice, and I don't want to hear me for an hour and a half. So along the way here, if at any point you want to, raise your hand, ask a question, make a comment, argue with me, throw something, just make a funny noise to break up the tedium, that's fine. Let's make this fun and interactive. I really have lost all will to play the role of this dodgy professor. Okay, let's see. There's a thing here. It is good. So let's get started. Cool. So the important thing in my disclosures is that I have no relationships at all with any laser manufacturers. It's not that they want nothing to do with me. It's actually the other way around. I find that if I'm going to travel around the world and talk about laser, and if I'm going to actually be engaged in laser research, it's just easier and cleaner to have absolutely no real, perceived, or even conceivable biases. I did, however, serve as the medical monitor for the pivotal FDA registry trial of the Glorious study for direct SLT that we'll talk about. Over the course of 4 years, I reviewed adverse events and made sure that I agreed with the investigators' decisions about whether or not they were related to the treatment. And over those 4 years, I think they paid me $887. So you can decide whether I'm now biased or not, but I can tell you that I'm easy, but I'm not cheap, and that doesn't get me. All right, so when Murray told me that I had to talk for an hour and a half, I thought, okay, what kinds of things can I stick in the talk to just kind of, keep everyone even moderately engaged. In 2019, my husband and I bought a little cabin in the woods with the thought that we might use it 5 or 6 weekends a year just to get away from the hustle and bustle of the city. And I say that to a bunch of New Yorkers, and I have to laugh because Morgantown has a population of 27,000 people, and the hustle and bustle of the city is what we're trying to escape. So Gibbon Glade, Pennsylvania has a population of 37, now 39 unless you count the cat, which would push us up to 40. We bought this little place. It was built in 1952 as a fishing camp, gutted it. We really wanted to buy a turnkey place, but when we walked out back and saw that the stream there, the Little Sandy Creek, was our backyard, and we had 2 acres on either side of the stream, so we had some built-in protection. We thought, you know what, let's just buy the place and put some effort in. So we did, and we remodeled it in 2019, and it was a really nice little place, and we still were only using it like 1 weekend every month or 2. And then in March of 2020, I looked at it and said, let's just get out of town. The Eye Institute had closed down with no foreseeable reopening date. If you weren't needing retina injections, you weren't getting seen. I mean, no one's going to go blind from glaucoma if we don't see you for a couple of weeks. So we went up for a whole week in March. This was big for us. We packed the car up with, we were here for 3 days. We had to take 2 vehicles to get all the stuff. No, I'm kidding. Shoes. But so we went up for a week. That was in March. We went back home in October. And that was how we discovered that we actually had a summer place. It's 35 minutes from the Eye Institute, but it feels like it's 100 miles away. And that's where we live now. I'm just going to be... The wildlife there's amazing. So I'm just going to show you pictures throughout the talk day. Every time you see a picture of an animal, you know that we're going to be switching topics and moving on to something different. And I'll just show you some of the creatures that have graced our presence over the last 5 years since we had the place. All right, anybody know what this is? Just shout it out, not you, Gus. Oh wait, does Gus know it? Gus, what do you think this is? No, I'm kidding. Remember, professor just means glorified school teacher. I will call on you. No. This is the Calabar bean. Calabar bean, from which we get what? Who knows their pharmacology? I had to look it up too. Physostigmine, Eastern. This was the start of medical therapy for glaucoma in 1867, 100 years to the year before I was born. God, I'm old. And for the last 150 years, we haven't moved off of first-line medical therapy for glaucoma. We start with medications, and then in the 70s, when ALT was described and commercialized, we added laser as the next step when we got to maximal medical therapy and still weren't controlled. And if laser didn't work, which it usually didn't, we moved on to surgery, which at the time was limited pretty much to the trabeculectomy. And that was in the 70s. And this paradigm is still very much alive and well, much to the consternation of many of us who would like to be disruptors and switch those first 2 around a little bit. Maybe even move all of them around a little bit, but I don't want to preview the last slide of the talk too soon. This approach, it's great. The approach here is, let's put safety first, let's do no harm. And there is a perhaps mistaken belief that the least invasive treatment is by definition the safest. That's not necessarily true. I can tell you that I have harmed far more people writing prescriptions than I have by performing laser treatment. And it emerged, and we talked about that. You know, there are new treatments coming, and laser evolved from ALT to SLT 20 years ago. The medications that were used in the 70s and the 80s, many of them aren't even in play anymore. I mean, when's the last time anybody prescribed pilocarpine? Don't actually answer that. You know, I find myself not even really reaching for beta blockers all that often anymore. They're not my first choice. They're not my second choice. They are my third choice. But by that point, we've already had laser a couple of times, and now we're on our third medicine. And you know, if you get to lasers plus 3 meds, you're probably one of those people who is really difficult to control, and we're probably going to go all the way to the right side of that slide at some point in your life, unless you get hit by a bus or something between now and then. So let's not badmouth medicines too much, because they are effective and they are safe. I mean, phase 3 clinical trials ensure that each medication's safety and efficacy are well characterized, and they meet the thresholds to get approved and commercialized in the US and in other global markets. And then major landmark clinical trials show their effectiveness in disease control, which the phase 3 trials never do. The phase 3 trials are all about IOP reduction, and the NIH trials are all about disease control. The OATS trial showed us that medications can prevent or delay the development of glaucoma over time. The collaborative initial glaucoma treatment study showed us that medications can prevent progression in established glaucoma. So they are effective. And once we know their safety profiles, we can generally avoid the safety concerns. I was writing an article recently, and I found a paper published in the early 80s documenting 32 deaths reported to the FDA directly attributable to the prescription of topical timolol therapy. You know, that doesn't happen so much anymore because we know now, but we didn't know then. Side effects that show up in the real world after clinical trials sometimes don't show up in the clinical trials. I mean, you enroll 500, 800, 1,000 people in a clinical trial. So if you've got a rare event that occurs less than 1 in 1,000 times, it's not going to show up in a clinical trial. But when you start prescribing it to millions of people, it will. The anti-VEGF therapies are a great example. There are some, sorry, not anti-VEGF. Right now, it's the new medications for geographic atrophy. There are all sorts of interesting vasculitis, retinal vasculitis issues that are popping up with some of these drugs that are uncommon, didn't show up in any of the phase 2 or 3 trials, but are starting to show up now in real-world post-marketing surveillance. So, you know, it's an ongoing process figuring out the safety profiles of medications. Although medical therapy is effective, it does have limitations. Adherence is an issue, so is adherence. Adherence is a problem. Getting people to take their meds is a real problem, and adherence is an issue. There are some other things I put up on the slide here, but they're all still adherence related, right? Side effects and tolerability. Well, side effects are bad, but tolerability is all about adherence, because if people don't like the way their eyes look or feel when they take their drop, they don't take their drop. And if it costs too much and they can't afford it, they don't take their drop. And the need for multiple drugs in many patients, there's all sorts of interesting evidence we'll look at showing how that affects adherence as well. So what was it C. Everett Koop said? Drugs don't work in people who don't take them. The former Surgeon General during the Reagan, no, 80s. Reagan administration.
Koop, right?
Koop. Who did I say?
Reagan.
Koop. Yeah, Koop during the Reagan administration, right? Yeah. Any of you here were any of you born during the Reagan administration? Anybody here who wasn't? Anybody here born after 1988? I'm going to feed you to one of the creatures that I'm going to show you later. God, Murray's meetings are always so much fun. The American Academy of Ophthalmology is never this much fun. Huh? It's not. Adherence. 30 to 80% of people don't take their drops. 30 to 80%. And I'll tell you what, we can't figure out who they are. Studies have shown that if you ask doctors to, identify the people in their practices who do and don't take their drops, we suck at it. So it's never the ones you think. And it worsens over time. The longer that you are treated with therapy, the less likely you are to actually take your drops over time. One study, I think, showed like a 40% non-adherence rate at 1 year and closer to 8% at year 4. There is an incentive issue. I mean, let's face it. I mean, if you had chronic migraines and you had a medicine that made you not get that killer headache every day, you'd take it, right? Right. If you had kidney failure, you were on the kidney transplant list, and miraculously a donor came available and you got your kidney, you would take your anti-rejection medicine every day without fail, right? Yeah, 40% of people don't. The problem is that most people being treated with medicines for glaucoma have absolutely no symptoms of glaucoma at all. They came in to see you for, I can't see up close anymore, or whatever. Or I used to be able to see fine and now I can't because I have cataracts up. And you diagnosed glaucoma because you're a diligent eye care professional and you did a full 8-part eye exam and saw their 0.85 cup with the notch and blah, 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 blah. And now you're trying to convince them that they have a blinding disease that they absolutely have no sense of whatsoever. Oh, and by the way, here's this drop you need to take every day for the rest of your life. And the side effects include, red eyes, itching, your pee is going to smell like asparagus every day for the rest of it. It's not really, but all of these things. There are no upsides to taking the medicine. There's no symptom that it relieves. I wish glaucoma caused pain or redness or blurry vision or bad smelling pee or something that the drops would actually make better and give the patient a tangible, perceptible benefit to encourage them taking it. No, it's the other way around. The drops are the source of all the symptoms of glaucoma. Yeah.
So if so many people are not taking.
Murray doesn't understand the comment because he doesn't have the gene that smells the asparagus.
So how come we don't see more progression?
In what?
Glaucoma. If most people are not being treated.
We got that coming.
Okay.
I think we do. And I think that we just assume that these are people who are progressing despite therapy because we don't know they're not taking it. Every patient who progresses on therapy, presumably you've continued to add meds because you wanted to get their pressure under control. But people under control progress all the time. That's because they're probably only under control because they took their med the day before they came in to see you. Oh yeah. The only symptom that a well-controlled glaucoma patient will ever experience are the side effects of therapy. It's no wonder people don't take their meds. There's all kinds of non-adherence. There's intentional non-adherence, which is really problematic, multifactorial and very common. It might be the desire to avoid side effects or a belief that we really don't need this therapy. I don't have this disease. I came in for glasses. I can see better now. There's nothing wrong with my eyes, blah, blah, blah. I also tell people when I'm trying to help them decide between primary meds or primary laser that 30 to 70% of patients receiving chronic medical therapy will develop dry eye over the course of therapy, and we'll have to treat that at some point too. Which is significantly higher than in the general population. And it's likely related to excipient ingredients in the eye drops, particularly benzalkonium chloride, which is well known to be cytotoxic to ocular surface cells. It's present in about 70% of ophthalmic formulations. It's nearly ubiquitous. And we know that adherence is lower in drugs that have BAK in them than drugs that are not, because there's less discomfort and less of a disincentive to be adherent. And we talked about it can be hard to detect in people thinking that they're doing the right thing by taking their drops only when they come in because they want to make the doctor happy. They're not my eyes, lady. I say that twice a week to patients. The other thing patients do that drives me crazy is they don't take their drops on the day of the visit. Well, I figured you want to know what my pressure really is. No, I know you have glaucoma and have high pressures. You're here to see if your therapy's still working. God. And every time somebody does that, I'm like, wow, I failed again at my job to help them understand what we're doing here. This is all about me. It's an entirely rational, reasonable thing for people to think that. And I just keep thinking about how I have, screwed up yet again. Just so much to help them. Talk to them. That means being in a room with them. Anyway. Then there's unintentional non-adherence. There are cognitive limitations like Alzheimer's. Alzheimer's is interesting because there's some epidemiologic evidence that there may be some shared features of pathophysiology, because glaucoma is more common in people with Alzheimer's and Alzheimer's is more common in people with glaucoma. some of the early cases, they haven't been diagnosed, you don't know it, they're not remembering stuff, and you don't know it, and they're not taking their drops, and you don't know it. There are all sorts of physical limitations like arthritis. Osteoarthritis affects 40% of Americans over 80, which is a lot of Americans these days, and preferentially affects the joints of the hand. The prostaglandin bottles are hard enough to get a drop out of, if you've got a perfectly functional hand. This spring, my hand's almost back to functional. Tremor can be a problem, Parkinson's disease, all of these things that just make it hard for people to put drops in, even if they want to. And then there are all of the fantastical mistakes. I tried to find the video clip that Alan Robin put together. He's got this wonderful video clip, you've probably all seen it, of a lady who's been asked to demonstrate how she puts a drop in. And she leans back and she puts the drop in, and then she sits up and goes, "Where the hell did it go?" It's one of my all-time favorite videos that doesn't have a cat in it. And I mean, depending on the study and how experienced the patients are and how you define failure, the failure rates are all over the map, but can be as high as 9 out of 10 attempts to put a drop in fail one way or another. There's an awful lot of contamination by touching the bottle to the eyelid. That's a really particularly scary thing in post-op trab patients. Missing the eye completely, difficulty squeezing the bottle or aiming, dispensing more than one drop at a time, which doesn't sound like a big deal, except that with prostaglandins, there's a very narrow therapeutic window. And there is compelling evidence that putting in 2 drops a day will raise pressure rather than lower it. That very narrow therapeutic window is actually one of the reasons why it took so long to develop a topical prostaglandin. I mean, they were being looked at in the 60s and 70s, and no one thought to go down to 0.005%. You know how when you get, sometimes when you get uveitis, you get secondary IOP rises because the inflammatory process generates high concentrations of prostaglandins in the eye, among other things. But at very low concentrations, they have the effect of lowering pressure. Failure to close the eye after installation, excessive blinking after installation, things that, even if you get the drop in right, you still minimize its impact. These are all problematic issues. How many of you actually teach or have someone in your office teach patients how to put drops in when you first prescribed it? Yeah, you guys do a whole lot better job at that than we do. I will tell you. I give this lecture and I still don't do it. So you just go figure it out. Okay. Other things that contribute to non-adherence: cost, which, we live in an interesting society where if you have a procedure, we'll pay for it, but if you need drops, we don't necessarily. Your medicines, we won't prevent your need for interventions, but we'll cover them when you get there. Side effects: red eyes, dry eye, ocular surface disease symptoms, and glaucoma is one of the things known to decrease quality of life. Prostaglandin-associated periorbitopathy, which I showed here. I think we're on the cusp of an epidemic of this. This is a patient using unilateral prostaglandin therapy in the left eye. And you can see the sunken eye. You can see the deepened upper sulcus. These F2 alpha agonists are all, they trigger fat lysis in the orbit. And the orbital volume shrinks and the eye sinks into the orbit. And it's cosmetically an issue, less so if it happens in both eyes because people don't notice it as much. I think we've grossly underestimated the frequency of this early on because we tend to use it bilaterally. It becomes a real problem later on when you want to do cataract surgery on these people because their eyes are so sunken into their heads that you need the neurosurgical instruments to get down in there to get stuff. Multi-drug regimens are a problem. Most patients, many, maybe not most, but many patients, most studies show about 40, 50% will eventually need at least 2 medications to control their pressure and prevent progression. And adding more drugs decreases adherence to all of the drugs that are being used. And this is aggravated by systemic medical use. The average glaucoma patient's on 5 pills. And even if well-intentioned, sometimes we don't tell patients to wait 5 minutes between drops, and they're just putting one in right after the other at night and washing the second one out with the first one out with the second, and the second one out with the third. So the only one working is the one they're using third, which, if by chance happens to be the least effective of them, that's the only one they're really on at night. And the consequences of non-adherence have been well documented. This is in patients who are non-adherent. The more non-adherent you are, the more likely you are to have visual field progression over time. And I think, Murray, these are the patients that you're talking about. I mean, we all see progression, but mostly, if I think back to the last 10 patients I saw who were progressing, I think they all progressed at pressures that I would have thought were okay. Most of them. Yeah, we all have patients who have pressures that are running high, but we don't sit on those. We do things. We get their pressures down. We do lasers. We do surgery. We add meds. So the people who come in and have a pressure that's their target's 18 and they're at 26, we don't see them for every 2 or 3 months for 3 years at 26 and do nothing. Those aren't the people who progress. We do things to those people. Most of the people who progress are progressing at lower pressures, or at least lower pressures on the day we see them. So here's a sneaky little raccoon. He's like, I can't reach the bird feeder. Oh wait, yes I can. The sunflower seeds. This is actually the raccoon feeder, not the bird feeder. We put this one up and put stuff in it that we know they like, and put it far away from all the other bird feeders in hopes that they would leave all the other ones alone. Yeah, that worked. On any given, the cabin's name is actually Raccoon Lagoon, and on any given night, we have anywhere from 4 to 8 raccoons there at a time. There's a little feeding stump over in the backyard where all of the leftovers go. And every night they come by to see, oh, tonight's blackened scallops night. This is good. Ooh, they had leftover Chinese. I think sometimes the neighbors come over and check out the feeding stump after we go to bed. Yeah, I love to cook. So every night I want to cook something new. I never go back and use any of the leftovers that go in the fridge. So we've just started dumping all the leftovers over to the feeding stump, which gets Yelp reviews on Critter Yelp. I saw a hand back there. Yep.
What's the space that you recommend?
5 minutes. 5 minutes. I mean, I've heard people go 10. I'm not sure I've ever seen a randomized study comparing 5 to 10. I think there was a study with pilocarpine 100 million years ago, and 5 minutes was perfectly adequate. So we've embraced topical medical therapy now for 155 years, largely because even though it's got lots and lots of limitations, it was still the only game in town. It was better than all the other alternatives. Kind of like, was it? Democracy is a terrible form of government, except for all the others. So I'm not really sure. Does that thing go away? I guess that screen sharing thing doesn't go away, does it? That's okay. Over time, we've tried to get away from meds first. There was a movement back in the 80s and 90s to look at surgery first, with the rationale being that if we get people's pressure down as best we know how early on, maybe we can nip progression in the bud and keep people stable for quite some time. And the Moorfield's primary treatment trial, which compared meds to ALT to trabeculectomy in newly diagnosed untreated patients, showed lower IOP and lower progression rates in the surgery group. But it didn't quite catch on because on the heels of that, the collaborative initial glaucoma treatment study, which was meds versus trabeculectomy, showed that while there was a significantly 2 to 3 point greater IOP reduction with surgery than with meds, the progression rates were similar between the two. Now, these were people who were on an average of 2 or 3 medications. They were pretty aggressively treated. And it would appear that once you get your pressure down by a certain threshold, the majority of people are going to be stable, and there isn't necessarily an advantage to gaining those extra 2 or 3 points after you've gotten them down below their progression target. So this didn't quite lead to the paradigm shift I think that everyone was thinking that it might. Harry Quigley, I think it was, published an editorial, God, it had to have been 20 years ago, about the time, I guess, that the Sigits was reading out. And he pointed out that at the time, if you take into account the number of years that patients have to live with glaucoma and what we knew about progression rates to functional blindness from glaucoma at that time, and also take into account the rate of vision-threatening complications of trabeculectomy, he said that you would actually blind more people by operating on everyone than you would by operating on no one, given the natural history of the disease. I'm not sure that that's still true. Life expectancy has changed since then, and surgery has gotten a lot. We've learned a lot about how to do surgery more safely. But nevertheless, the role of surgery was not moved. The needle was not moved by either of these two trials. Now, the laser first approach is more interesting. In the era of SLT, it makes a lot more sense than in the ALT era. Laser trabeculoplasty obviates the issue of adherence, and there's no ongoing tolerability issue with daily drop therapy. And as we said, procedures are usually covered, even when medications may not be. So it may overcome the cost issue as well. I mean, it ticks all of the boxes in terms of all of the things that might limit effective treatment of glaucoma. There have been a number of studies that have tried to position laser as the preferred first-line therapy. One was the glaucoma laser trial back in the 70s and 80s. I guess it was the early 80s. It was right after Weisenhutter described ALT. And this was an NIH-funded trial that compared ALT first versus medications first. Now, keep in mind that this was in the era where the medications that we had available to us were timolol and pilocarpine and epinephrine, the holy trio that we use every day. Two of those drugs I'm not sure I've prescribed. I don't think I've ever prescribed epinephrine. Maybe as a resident in the 90s. I said something about, one of the fellows asked me, when did you finish fellowship? And I said 1998. He goes, oh, the late 1900s. Needless to say, he's now unemployed. The late 1900s. Jeez. Anyway, in the GLT, ALT actually lowered pressure better and prevented progression, visual field, and optic nerve changes better than medications over the 7 years of the study, and the original study and its extension. There was no paradigm shift, I think in part because ALT was kind of challenging to do right. I mean, it's a teeny tiny little spot size. And also because it had very limited repeatability. I mean, with ALT, you were frying the meshwork. And yeah, you're putting a spot here, skipping 4 spot sizes, putting one here, doing the same thing all the way around. But when you go back and do it again, and you position them in between the old spots, now you're blading the meshwork with every spot. And there's a point at which you've now fried the meshwork to the point where it no longer functions and pressures go up. And there were a number of case reports of markedly elevated IOP spikes after repeat SLT. In fact, repeat SLT was not built into the GLT study because of that risk. So it was a one and done, kind of like Durista. And as a result, it's not a big paradigm changer because it's really just a time. It's just a stopgap measure. It's a way of buying some time before the next thing is needed. Yeah, the SLT med study was conducted roughly 10 years ago. And it was SLT versus PGAs in newly diagnosed patients. And even though the IOP reductions were similar between the two groups, it was stopped very early due to poor enrollment, and so was underpowered. They only enrolled about 10% of the patients they sought to enroll. And the reason for that was that the study just came 10 years too early. We weren't ready to actually start doing primary SLT. All of the investigators who signed up said, yeah, I want to be part of this study. When the rubber met the road, they weren't willing to randomize any of their patients to actually potentially getting primary SLT because they were more comfortable still just prescribing medications. And so the study languished and never, again, really moved the needle. But then along came the LIGHT study, which I'm sure you all know by heart, and I'm not going to belabor, yes I am, because I have 90 minutes to fill. And this was the game changer we've all been waiting for. So we keep the back door open, and I mean open, like propped open, because the cat likes to go outside. She thinks she does. She thinks she's brave. And then she goes outside, and a butterfly goes by, and she comes tearing back into the house. She's old and dumb. Gosh, she's dumb. But one of the downsides to keeping the door and the windows open, single pane windows, hand crank, okay, that open. I mean, these are 1952 original windows, and we just can't bring ourselves to replace them because nobody makes them like that anymore. And hummingbirds come in all the time. And the first thing they do is they go straight up to the skylights because they think that's the way out. And there are 16-foot ceilings in this thing. And once they're up there, I mean, I'm not going to go get a ladder and a broom and a net and all the things that you would need to catch a hummingbird. So they just stay up there until they finally just exhaust themselves of their fuel supplies, and you just watch them down, and hit the floor. And then if I get to him before the cat doesn't even, the cat's not even. We just go pick them up and take them over to the feeder and prop them on the little feeder with their little beaks down in the sugar stuff. And eventually they drink enough and get their strength back and fly away. This is my life. This is not what I thought my life would be like 10 years ago. Hummingbird rescuer, should put that on my CV. Anyway, so that's the hummingbird. Let's talk about the light trial. Light trial was conducted in the UK in the National Health Service, which is great because you can tell people what to do because it's a National Health Service, and if you want free care, you will submit. No, it's not quite that bad. These were newly diagnosed patients with mild to moderate POAG or high-risk ocular hypertension who were treatment naive. There were 718 of them randomized either to primary SLT or to primary medical therapy, starting with prostaglandin, moving on to adding, there's a whole list of add them in this order unless there's a contraindication, in which case you add them in this order. And there was a target pressure established at the time of study entry that was based on both diagnosis, whether you have POAG or ocular hypertension, and also the severity, whether you have mild or moderate POAG. So obviously, moderate POAG had a lower target than high-risk ocular hypertension. Whenever your target was exceeded on 2 or more visits by a certain threshold, then you were advanced to the next treatment strategy. And the outcomes, which were initially set for 3 years, were the primary one was quality of life, which seems obvious, very counterintuitive. And I asked Gus Gazzard about that. And he goes, yeah, the funding source insisted on that. And so if we didn't make that the primary outcome, there would have been no light study. I would have changed that too. And then the secondary were glaucoma outcomes. Quality of life at 3 years was similar in people who got SLT versus medications. Anyone know why? Anyone have a guess as to why? I mean, it's utterly non-intuitive, right? I mean, one group of people had to put drops in, and many of them needed multiple drops a day. The others sat still for 5 minutes and were just happy as clams and never had to put another drop in. Yeah. When we measure quality of life, we have to use a validated questionnaire that covers a number of questions that relate to what we're interested in measuring the impact of on quality of life. And all of the quality of life instruments that we have for glaucoma focus on the impact of glaucoma on quality of life, not glaucoma treatment on quality of life. And all of these patients had glaucoma. So we're using an instrument that measures something that they all have in common in both groups. So it's absolutely not surprising that there was no difference in quality of life when we were looking at glaucoma-related quality of life. There is a tremendous unmet need for an instrument that can measure the impact of glaucoma treatment on quality of life and differences in glaucoma treatment modalities on quality of life. There's one that's been under development. Are you involved in that one that Caldev has been working on with FDA for MIGS? No. Caldev Singh has been working on one now for at least 5 or 6 years with FDA, trying to get it approved as an official accepted clinical trial endpoint, a patient-reported outcome, looking at the impact of glaucoma treatment on quality of life. It's looking specifically, though, at MIGS versus meds to show that one of the benefits of MIGS in people who are, say, well-controlled on medical therapy, they're going to go have cataract surgery, and if we can do a MIGS at the same time and get them off their drops, their quality of life will improve. I think that the instrument, if and when it's finally validated and ready for prime time, should be very effective for SLT because, let's face it, SLT is the ultimate MIGS. So we will wait. Yeah.
Actually, it's important to say here that Wiley Chambers and the FDA, although they're willing to accept PROs, report outcomes as endpoints, they always claim that the existing instruments are all very poor and not specific for glaucoma.
Right.
So I think that tells why we're failing to see that, not that it's not happening.
Right. I mean, and there are some that purport to be glaucoma specific, but interestingly enough, the primary instrument used in the light study was the EDS-5, I think, which is a general quality of life. I mean, it asks things like, how you feeling today, and are you feeling lucky? No, I'm kidding. But things that have nothing to do with ocular status, much less glaucoma-related status. It's something that can be used equally effectively or ineffectively in a study of rheumatoid arthritis or aspirin for headaches. Anyway, it's not surprising that quality of life was not different between the two, given the instruments that were used. And it is a major significant issue, because if we want to get payers to cover, say, sustained release drug delivery, more than they do now, when those come along, the biggest effect that those have is going to be on quality of life, getting people off drops. And we don't really have a way of measuring that. Now, intuitively, sustained release drug delivery should provide us with better long-term IOP control and less progression, but there's no drug company in the world that's going to do a 5-year study showing that their sustained release drug delivery version of drug X has lower progression rates over time than topical drug X. It's never going to happen. So you end up with drugs that are approved but have really limited market access. So it's a significant unmet need. I don't have any sort of a background in psychometrics, so I can't solve this problem, so one of you is going to have to. Anyway, the glaucoma outcomes are different. At 3 years, 78% of the patients who got SLT first were still at target without needing medications or surgery. That's 4 out of 5. And 4 out of 5 of those, well, 3 out of 4 of those anyway, needed only a single SLT in order to achieve that. So the majority of patients got 1 SLT and were still doing great at 3 years. You were more likely to progress if you were on meds than laser. You were more likely to need cataract surgery if you were on meds versus got laser. You were more likely to need glaucoma surgery if you were on meds versus you got laser. So by virtually every metric, SLT is at least as effective as, and possibly more effective than medications in controlling glaucoma in the least impactful way possible. And SLT is also more cost effective than medications.
Something on that last part.
Yeah.
Is that because it's the UK, was that out of pocket cost for the patient?
So glad you asked that, because who cares? Somebody's got to pay it, right? I was just about to say that I was at Arvo presenting this a couple of years ago, and somebody from a European country stood up and said, "You should not say that it is more cost effective, because in my country, patients don't have to pay for their meds or for their SLTs." I said, "That's true, but your government does, right? I mean, everybody pays for them through their taxes, so don't you want your taxes to not go up to pay for more meds?" Somebody pays for it.
Like 300 pounds or 300 euros.
That sounds about right.
But I don't know if that was the cost to government.
Yeah, I mean, I don't think people pay. Do people pay anything for NHS care? So it's probably the cost to deliver the care rather than the cost of paying for the care. Yeah, but I mean, the costs are still real. They still occur, whether the patient pays them or the government pays them through tax collection, or the insurance company pays them through premium gouging. Excuse me. And so safety-wise, this is really important. There are no sight-threatening complications of SLT in the 776 procedures that were performed through 3 years. Interestingly, there was only one post-op IOP spike that required treatment. One. In all of the studies of SLT, we have found that the rate is generally somewhere between 4 and 7%, which in this case would have been, with 700 and 800, somewhere between like 30 and 50 spikes. The difference is all those studies were done with SLT as adjunctive therapy. And people have been getting chronic medical therapy for a long time. And it may well be that medications do something. We know they affect the ocular surface epithelial cells. Are they affecting the trabecular meshwork cells? Are they doing something to the long-term health and safety of the outflow system that makes it less able to deal with the acute trauma of SLT that non-medically treated eyes still possess that ability to compensate and keep the pressure from going up? That's a really interesting question.
Or was it the protocol, the NHS study, incapable of finding all the spikes?
I mean, they looked for them. They had a 1-hour IOP check for everybody, and I think they treated anybody who had an IOP spike of more than 10. That's also a little bit liberal or conservative, depending on your perspective, I guess. But some of us treat when it goes up by 5, some by 8. I mean, 10's a lot, but at the same time, I don't know of any studies that have ever sat on pressure spikes and just watched them like for the next 8 hours or so. I mean, they're probably all transient and they all come back down. and they probably all come back down at about the same time that the drops that we put in are going to kick in. So, you know, I don't know whether we're chasing our tails with that. There's an awful lot we don't know. The 6-year data just recently came out, and not surprisingly, it looked just like the 3-year data. 70% of the SLTIs were still medication-free and at target at 6 years. 70%. That's 70% of the patients who haven't had to put a drop in 6 years. There's less glaucoma progression with SLT, statistically less progression, statistically lower trabeculectomy rates, statistically lower cataract surgery rates, and still no serious laser-related adverse events through 6 years of follow-up with SLT being repeated as needed. This is a game changer. Now the trick is to try to figure out how to get people to actually start doing more SLT, because the barrier to SLT first as a paradigm shift now rests on the shoulders of ophthalmologists, and in nine states, optometrists. Yeah.
Question for you, in your teaching, and I know this because I think when light trial first came out, I said, I would remind my technician, I said, remind me about SLT, that attention.
Yep.
As an alternative. You know, we can go with drops route, this route, and now really get planned over trying to push the SLT ahead. How does this discussion go as far as your teaching with residents? Get them to get this paradigm shift, because I know it was tough on me.
Yeah. So when SLT first came out, I started using it in people who were poorly controlled on medical therapy. And then I started using it in people who were well controlled on one drop, and I wanted to try to get them off of it. But getting to that threshold of doing it on a newly diagnosed patient who had never been treated before, starting with laser, was really tough for me. And early on, I found that when I offered it to patients, about 5% of them said, yes, please. And a light bulb went off, I guess the light bulb went off a while ago, but I have recently started giving fewer talks on SLT, the evidence, and more talks on SLT, talking to our patients about SLT. Because now I walk into a room like this, and we'll do it, it's fun. How many of you diagnosed with glaucoma today, early POAG, pressure 26, how many of you would prefer to have SLT first as opposed to medical therapy? Right. And all the hands go up in the ophthalmology rooms too. And then I ask how many people are doing it in the majority of their newly diagnosed glaucoma patients, and almost none of the hands go up. And I was doing a talk at the Minnesota State Academy of Ophthalmology meeting recently, and I said, why is that? This is why is that? And there was a lot of hemming and hawing, and a resident in the back of the room said, patients don't want laser. I said, you're right. Let me rephrase that. The treatment that you would want, the treatment you're responsible for explaining to your patients, the treatment that you believe is the best treatment for them, you can't convince your patient that it's the right thing for them. That's not a patient problem. That's an us problem. That's a we're not talking to our patients about SLT correctly problem. And I used a word a few minutes ago. When I offered it to patients, blah, 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 you don't offer it. That's the problem. We offer it like we're cocktail waitresses. Would you like a drink? We don't. It's like it's optional. Like it's optional. When we talk to patients, we're still communicating the paradigm shift because we're still working it out in our heads. We say things like, "Okay, so you have glaucoma, Mrs. Slobodnik, and we need to lower your pressure." Traditionally, we start with medicines. They're very effective. They're very safe. We've used them for 150 years. Now there's this laser, and you might as well stop right there, because what you've said is there's a standard of care, and I would now like to deviate from it with you. That's when I had about a 5% uptake rate with that presentation. Then I changed my approach, and I said, okay, there's medicines, there's lasers, here's the pros and cons of this one, here's the pros and cons of this one. Which would you like? Oh, I think I just like it. I mean, maybe 30% of patients would opt for the laser first at that point, but still most wouldn't. And then I realized, okay, let's say I have stomach pain and I go to my primary care doc who orders some imaging test, I don't know, one of those things with letters, and they find a big Goomba in my liver. Okay. And I go see the oncologist, the liver oncologist, who says, well, okay, so we have this drug and this drug and this drug. Which would you like? Which one's better? Well, this one does this one does it. Which one's better? Which one would you, I would actually ask him, which one would you have if this were your liver, right? I think that if we believe that there's a treatment that's better than the other and we don't communicate that to the patient, we've abdicated our responsibility as providers. And Bob Weinreb and I will disagree on this for all of eternity. I mean, I said this once at a meeting where he was in the audience, and he interrupted me and said, "Oh, so you're playing God?" Okay, I'm in front of all of my peers, and the God of glaucoma has just absolutely challenged me. And what do I do? How do I get out of this now? Because he's still going. So how does it feel to play God? And so I just said, okay, everybody note the date and time. What? Bob Weinreb just likened me to God. And everybody laughed. He goes, that's not what I said. That's what we all heard. Shut up. And I moved on. But we do live in an era now where there's this shift away from the paternalistic approach to patient care. And that's all well and good. I don't tell them they need to have laser. But what I do now is I say, okay, Mr. Schlabodnik, you have glaucoma. We need to lower your pressure. There are two ways to do that. There's a laser treatment that takes 5 minutes here in the office. It doesn't hurt. It's very safe. And most people who have it don't need to use drops. It will wear off over time, but we can do it again. There are also eye drops, which are also very effective, but you have to put them in every day, sometimes several times a day, and you might need more than one, and they're going to make your eyes red and itchy, and at 30 to 70% of the time, you're going to get dry eyes. You'll have to treat that too. Personally, if those were my eyes, I would have the laser first. What questions can I answer for you to help you decide what's best for you? 98% of my patients now opt for laser, because what idiot would want a treatment different from what the doctor would have for himself or herself? Yeah.
How do you handle the financial part of it? I think patients who, let's say, haven't met their medical stuff. I have an environment where there's a lot of low-income patients. Cost is going to be a big concern.
Paying for their drops is going to be a big concern for them too, and they're going to have to do that every month. I mean, I'm fortunate that I work in an academic center where we have billing specialists and financial advisors and things, and we can send them over to talk to people to set up payment plans if that's the case. But I mean, the vast majority of these patients are in there. Yeah, I mean, we have indigent programs for patients who flat out can't afford it, but there's no easy answer to that, except the cost is all up front, so it's harder. As opposed to amortized month after month after month over time. They do come out ahead in the long run. But no, you're right, it's a challenge. I don't know the answer to that, given that I don't know the financial operations of your practice. But I haven't had many people who have declined. I don't think I've had anybody who's declined on the basis of cost. Mostly because, unlike UAMS, I don't know if you guys saw that in the New York Times yesterday or this morning. University of Arkansas for Medical Sciences, which is where I was before I came to West Virginia University, has just sued like 8,000 patients for unpaid medical bills, and some of them in the order of $30 to $100. And many of the people that they're suing are their own employees, some of whom were featured prominently in their PR for our compassionate approach to COVID. We worked through COVID, we were here for you, and commercials with these people who they're now suing, who still work for them, talk about awkward. Yeah, the employee appreciation picnic there should be fun this year. Yeah.
So you work in the adherence part in discussing this with your patients, because in the back of my head, that's one of my main reasons for recommending SLC first. And I find it difficult to tell my patients, like, you won't be taking your medication every day. But I know that. Right. But they don't. And so I just didn't know if you have any sort of angle there to work that in.
I don't bring that up as the first thing. I mean, usually when they ask questions like, something, I'll usually say, and another thing, everyone has the best of intentions, but the reality is that nobody gets all their medications in, and every day your pressure goes up, your glaucoma gets a little bit worse. And that's cumulative over time. It's not like speeding on the highway where if you speed for 10 minutes and don't get caught and then slow back down again, all risk is gone. In glaucoma, if you speed for 10 minutes, you're going to get 10 minutes worth of optic nerve damage. It's going to be there even when you slow down, you know? And I also tell patients, the people who go blind from glaucoma are the people who don't come in until it's too late and the people who don't adhere to their therapy. But if you do all of the things that we discuss and keep coming in so that when things aren't working, we can adjust, the likelihood of blindness is almost nil. I mean, we're going to just keep, doing whatever. We're not going to, like I said earlier, we're not going to follow people who are out of control and not do anything. We're going to keep doing stuff till we get them under control. Yeah.
So I have two questions.
Okay.
The first one is, if you're living in a state where lasers are not within your scope,
Yep.
and you're sending patients out for a laser because we've had this discussion, how does it affect? Ophthalmology is still, half-half. And you send them to an ophthalmologist who might say, "Oh, don't listen to that idiot," right? Medication is the way to start. It affects adherence at the end of the day. That patient now has doubt.
Right.
Who's right and who's wrong? It decreases adherence, in my opinion.
Sure.
So how do you change that narrative?
So first of all, I am well aware that I'm standing in a room full of people, most of whom cannot perform SLT, recommending that you now send out your well-paying patients to somebody else to do something that's going to cost you money in the long run. Second of all, I think it's critically important that if you're going to send someone out of your practice for a treatment that you can't provide, you have to send them to somebody who can and will and is interested in providing that treatment. When I have a retinal detachment in my office, I don't send it to the medical retina specialist. I send it to the surgical retina specialist. You're going to just have to do the homework and figure out who in your area has drank the Kool-Aid, if you will, and has already accepted that the paradigm shift is legitimate in basis and in fact, and is now doing a lot of primary SLT. There's no way around that. I mean, if you find somebody who has an ocular tumor, you're going to figure out who the ocular tumor specialist is. You're not going to just randomly send them to somebody. This is the same thing, just maybe on a less grand scale.
Yeah, that also depends on the insurance.
I understand.
And so on. But
Yeah.
the second question I had was on adherence to follow-up. And so, we've done SLT procedures on patients who then believe that we've cured their glaucoma.
I have never had that happen. Just like I've never had a patient who's had a trabeculectomy suddenly believe they're cured and never come back again. Or a patient on prescribed medications who now believes the medications cured them and they don't come back again. That really surprises me because I hear that as an argument all the time by people who are stuck in the inertia of meds first and are just throwing up whatever excuse they can think of not to adapt with the times. But I don't think that happens. I mean, we do all sorts of other things that lower the pressure. We do MIGS procedures on patients to get them off meds after cataract surgery. They still come back. They come back. Again, it's a communication thing. It's like me not talking to the patient about taking their drops when they come in to see me. We just need to make sure they understand that this is a treatment for the disease. You still have the disease. The laser is going to wear off over time. You won't know it. Keep coming to see me. Let me see it so that if when it does, we can do it again.
So you haven't seen a decrease in
I have not. No. I'm very clear to frame all of the glaucoma therapies as treatments for a chronic, non-curable disease, rather than as something that's going to make the problem go away. I mean, it makes the need for drops go away, but it doesn't make the disease go away. And that's a really important. This is the conversation I have with all of my patients when we first get diagnosed. I say, look, you have this disease. I know you have no symptoms. You'll be the last to know. They ask me, what should I be looking for? I don't know if my glaucoma is getting worse. Nothing. You will be the last to know. By the time you can detect the symptoms of glaucoma, it's almost too late. You need to come in and let me look because I will see changes before you can perceive them, and we can do stuff to nip it in the bud before it becomes a problem for you. And they get that. But that's probably the more important conversation to have up front, rather than what treatment would you like to have.
But I also think that patients who start medications on it don't come back because they don't like the eye drops and they're not compliant, or the same type of patient who are not coming back after SLT.
Well, they're not going to come back no matter what you do.
Exactly.
Right.
I think that's
Right.
my point.
Right.
I agree. Not a higher number of patients, so percentage of patients who have SLT.
As the old educator, but we're very successful and profitable glaucoma clinic. This is part of the, in my opinion, this is part of the education process. You gotta teach patients psychology, you gotta teach patients progression, but you gotta teach your students how to talk to people and human beings. And most, I treat glaucoma 100% of my day. I spend 4 minutes looking at OCTs, the fields and the photos, and I spend 10 minutes talking, or 5 in my 10 minutes with, right? So that, to me, that's part of the education process, and something we should probably talk about maybe this last hour, because I take students and I find them to be very, very, very poor communicators. And I'm not dissing anybody in the room. I'm just saying that's a big, to your question, that's part of education. I think that's part of taking care of a patient with glaucoma. In my opinion, as much as deciding which drop to take, it's talking about.
That I think that's a really good point. We don't teach our residents and our students how to talk to patients about things. I stand outside the room sometimes and listen to my residents explaining something to the patient, and I'm just cringing.
Yeah.
Yeah. Well, your cytochrome P4, we had a crotchety old curmudgeonly cornea specialist at WVU until 2 years ago when he retired. And he was notoriously in and out of the room in 12 seconds because he really just didn't like people. He loved taking care of corneas. He hated taking care of the people attached to them. And he was very, very good. And he was an excellent teacher out in the hall. He would spend time talking to to residents. He'd give lectures to the techs. But I remember one day, there was a patient who just would not let him out of the room. She had question after question after question. Said, I understand my diagnosis, Dr. Wiley, but why can't I see? And he reached the limits of his tolerance. He said, ma'am, you have a PAX2 homeobox deficiency. And he got up and left the room. Yeah. Anyway, so let's see. We must be switching gears. And this one's blurry because as I was taking it, I realized I'm standing 15 feet away from a tree with a big black bear in it. What the hell am I doing? Right? And it was, yeah. Anyway, so there was that. This is we had 3 bears in the backyard. Yes.
You still keep the back door properly?
Only during the day. I was on a Zoom call with it was our monthly Zoom call with all of the site PIs for the Coast trial that we're going to talk about in a minute. When my office at our cabin is on the open but roofed, non-screened, open back porch. And I heard this sound. I turned around behind me. There's a bear coming up on the porch with me about 15 feet from where I am. And I'm like, I've got my earbuds and like, I'll be right back. And I took off. And I'd had one of those virtual backgrounds on, but when I finally chased it off and came back and sat down, I turned that off and said, can you guys not pay attention to me, but just kind of look over my shoulders and let me know if a bear shows up behind me? Oh, God, there's never a dull moment at Raccoon Lagoon.
I don't know if you're going to go into this, but there's a big percentage of patients, or a significant percent of patients who require 2 SLTs to reach target.
Yep.
How long do you wait to do, let's say, a second SLT if they haven't reached target, or does that vary? And also, there is a Q&A question for you as well on the Zoom, just as a heads up as well.
Oh,
It's on
okay.
the screen.
Do I have to work that?
Yeah, we'll work it for you.
Okay, that's good, because I don't even have a
We'll
mouse
get the
here.
questions at the end.
Okay, that's fine. We're going to save the questions for the end. Those 2 of you who have done stuff on Zoom that I don't really understand. I'm a Luddite. Anyway, my general approach is I do the laser, I bring them back in a month and check the pressure. If I haven't seen a meaningful change, I'll bring them back in another month because I've had so many patients who don't manifest it the first time. I spent the first part of my career studying the monocular drug trial. And the bottom line with it, which you guys are not being taught, right? You guys don't know what that is, right? You're not using the monocular drug trial. It's dead now, right? It's good. Okay, my work here is done. The problem with it is there is nothing that you can do to someone that you can assess the effectiveness of with 1 pre-treatment and 1 on-treatment IOP measurement, because IOP fluctuates 5 to 8 points a day, and it can go up or down and mask or mimic a true effect. And so it's entirely possible that you do SLT on somebody whose pressures are 26, and you drop them down to 18, but on the day that you see them a month later, they were going to be 8 points higher no matter what, and they would have been 32 if you hadn't done SLT, but now they're still 26, and just give it another month. It's a chronic disease. It's slowly progressive. You don't have to make decisions based on a single IOP check. Give patients the benefit of at least 2 checks before you move on to what's next. Most people will show a meaningful reduction a month later. Those who don't, if they're motivated to get off medications, I will offer them a second treatment at that time, the 2-month mark.
Safety-wise, no issues.
Absolutely none.
Any issues in second?
I have never seen a complication of repeat SLT that was any different in nature or frequency than a primary SLT. And I do 360 every time. The only exception is in heavily pigmented angles. I will stage that into 2 180s about 2 weeks apart. And I will do the second 180 even if there's been a meaningful pressure reduction, because I just think that get everything you can. There's no reason not to. And I would say I want to go back and look at this. I haven't yet. Albert Corey has published on this and a few others. There's a 50 to 75% pickup rate on repeating SLT if the first one didn't work. And I don't know why that is. Maybe some meshworks need more energy, or maybe I was asleep with a switch that day and I was lasering the ciliary body band instead of the meshwork, or the the Sampolisi line or something. I don't know. But never say that out loud. I just did. Yeah, I saw a hand in the back. Save me, rescue me. It's cost effective even in models where you assume perfect adherence, but it becomes much more cost effective when you factor non-adherence in. Even though the cost of medicines goes down, the cost of subsequent treatments, because you're not taking your medicines, goes up, and so laser becomes more effective when you factor non-adherence into the models. Okay, let's move on from the bear because I'm getting creeped out here. Okay, so is there a wait a minute? Oops. Oh wait, is this a touch screen?
Yeah, you can click on
More and oh, that one. Cool. Oh, look at that. Yay. Cool. Thank you. Okay, so there have been other important studies of SLT, and then there was also this one. I spent almost a decade in the Caribbean looking at the effect of SLT in Afro-Caribbeans with glaucoma. And this was the paper we published not too long ago that combined our original St. Lucia study with the West Indies glaucoma laser study, and which were 2 identically designed studies that harmonized well, and the databases were merged for greater power of analysis. Conducted from 2010 to 2018 in St. Lucia and Dominica, not to be confused with the Dominican Republic. Every time Dominica gets wiped out by a hurricane, all of the relief supplies get shipped to the Dominican Republic. This is not untrue. This was an analysis that included almost 250 eyes with open-angle glaucoma who were washed out of topical. These were not treatment naive. To do that in this setting would have required a massive screening effort to find undiagnosed patients that was beyond the scope of what we were trying to do. So we took already previously diagnosed patients and washed them out of their medicines, did bilateral 360-degree SLT, and then followed them for up to 7 years, almost 8 years.
Put the mouse again.
There we go. Thank you. And this was so with SLT repeated as needed when the pressure went up and was up on 2 consecutive visits. These were the IOP reductions that were seen through 7 years of follow-up, generally averaging from like 6 to 8 millimeters of mercury. These were pressure reductions that would reasonably be expected to alter the natural history of the disease very meaningfully. When we look at the survival curve, the bottom curve is the survival of a single SLT. The middle one is 1 or 2 SLTs and those who needed it repeated. And the top one is 1, 2, or 3 SLTs. The 1, 3, 5, and 7 year survival, that is well controlled on no medications through 7 years. 76% of patients at 7 years were still well controlled with SLT repeated as needed. This is big. I think the really important point of this slide, though, is the bottom graph, the single SLT. If you did where up to 80% of patients in sub-Saharan Africa who are diagnosed with glaucoma never come back again after the initial visit. 80% never come back after the initial diagnostic visit. And that's why glaucoma blindness is such a problem in sub-Saharan Africa. Imagine a world in which we did SLT on the day of diagnosis before we let them leave. According to these data and the light data and one 10-year retrospective study of SLT at a single center, 50% of the patients were still doing well at 7 years after a single SLT. They never, even if they never came back to get their second or their third. Now, that's not ideal, but when you're looking at the statistics that we're looking at in sub-Saharan Africa, you know, this isn't a win. This is a blowout victory. If we could kick the can down the road 7 years for half of the people, that would change things dramatically. People have said to me, but this seems like unrealistic data. The median time to retreatment was about 6.5, 7 years in the West Indies glaucoma laser study. In the light study, 54% of patients randomized to laser were still controlled with a single laser at 6 years. So the median time to retreatment hadn't come yet at 6 years. So it's more than 6 years in the light study. The median time to first repeat SLT, more than 6 years. And it was 6.5 years in the 10-year retrospective study I talked about. So you got 3 studies, only 3 so far of this duration. And all 3 suggest that it's a 6 to 7 year median survival time or median time to retreatment for SLT. This is not something that we talk about. This is not something we tell our patients. I mean, up until I realized this about 6 months ago when I was putting another talk like this together, I was telling people, yeah, you know, we'll do the laser. It does wear off. Most people get a year or 2 or 3 out of it. But now I'm starting to tell people most people get 5 or 6 years out of it before they need to be retreated, because that's what the data show. When you use it as primary therapy. If you're using it as adjunctive therapy, all bets are off. It doesn't last nearly as long in somebody that you're doing it to try to get them under control when their 3 medicines aren't working.
Looking at, you know, just changes.
This was IOP at target, just like the light study. IOP at target without medications.
One of the questions you said, you felt that there were people who were compliant and did whatever they need to do, whether it was laser or surgery. You felt that no one would go blind. Americans, we see a lot of where I am, and in Caribbeans, it seems to be just so aggressive, even on compliant patients. So I didn't know. You think I'm missing something?
No.
You know, when you say none of them go legally
Well,
blind, and I'm thinking.
Let me first of all back up and say very few of them. I won't say none. I hate absolutes. I absolutely hate absolutes. No. One of the things about Afro-Caribbeans in particular is that much of the glaucoma in the Caribbean is normal tension glaucoma. In the St. Lucia eye study that was done back in the 80s, with Roy Wilson going and the Harvard team going down to St. Lucia and doing a population screening, the average pressure of newly diagnosed incident glaucoma was prevalent glaucoma was 21 millimeters of mercury. When they went back 10 years later to see how they were doing, the average pressure of the patients who had progressed to blindness was 21 millimeters of mercury. In the Barbados eye study, the average pressure of prevalent and incident cases of glaucoma was between 20 and 21. So I think we've just got to make sure that we understand that these are not people who need a pressure of 17 or 18 to do well. These are people who need a pressure of 13, 14 to do well. And it's really important to make sure that we are achieving the IOP goals that we need to achieve for them. You know, I tend to be a little bit more aggressive with normal tension glaucoma than with POAG, matched for severity of disease. Excuse me. the collaborative normal tension glaucoma study showed that a 30% reduction in IOP provided good protection. Most of the PUAG studies have looked at 25% IOP reduction. OATS was 20% to prevent the development of glaucoma. So I think the more the different diagnoses require different approaches to treatment. And I think it's under-recognized that a lot of glaucoma in people of African descent is normal tension. It was, so the average pressure, even in the Baltimore Eye Survey, of Black patients newly diagnosed with glaucoma was 21. So that's the case even in African Americans. So yeah, I certainly they're at higher risk of developing glaucoma. They're at higher risk of progressing glaucoma, and whether that's due to the nature of the disease itself or to socioeconomic issues that limit access to care is really not clear. Certainly, they all play a role. But I think your point is well taken. And I think we just have to make sure that for each patient we are, being aggressive. And if we see progression, we've got to advance therapy, and we've got to get the pressures lower than where they're progressing. Yeah.
Do you include that in your, I mean, I know most of your patients now choose SLT. Did you include residents that it's important to tell the patients that now, prior to starting medical therapy, it's more effective. We wait, but therapy that fails, and then we do this, it's not going to be quite as cost effective as long term. That's
I don't generally, because trying to talk about second and third level treatment when patients are trying to figure out what to do today, I think is really difficult. I think one of the reasons that I have evolved the way I talk to patients, and actually I tell them that this is what I would do if it were me, is because, here's the scenario. They came in because their vision was blurry, and the blurry vision was because they have cataracts or because they need glasses. It's not because of the glaucoma. And so now you've hit them with glaucoma, which they don't know what it is. And you've talked to them about a laser that they have no earthly idea what a laser is. And you're telling them that they're not going to like eye drops, which they've never put in before. So they have no idea what the pain in the ass factor is for eye drops. And they're at the point where they're not even hearing you anymore. And they're just listening for a recommendation. What should I do? What do you recommend that I do? And that may be different here than in West Virginia. Jeff Liebman pointed out to me that my patients' willingness to accept what the doctor tells them might be different than in his practice, where most of his patients are there for their sixth opinion. In West Virginia, that is not the case. So I am also aware that I may have a patient population that is more amenable to receiving recommendations from the healthcare provider. Skip that. Oh, no. So we, in the West Indies glaucoma laser study, we kicked out all of the patients who had advanced disease. The eligibility criteria didn't allow them in. We didn't let in monocular patients. We didn't let in people who were progressing on multiple medications. We didn't want to wash out people who were at risk of getting significantly worse during the washout and who may not benefit from laser. But it was these patients over and over again, as we told them that they didn't qualify. Remember, there's no exaggeration. We were treated as the white knights coming in and offering glaucoma treatment to this small island of 230,000 people. And we had lines out the door every day that we were screening for the Wiggles study. And people were so hopeful. And to tell them that, I'm sorry, your glaucoma is too severe, you can't be in the program. Over and over again, we heard, but we're the ones who need it the most. We can't afford our drops. We're getting worse. We're going blind. We've already gone blind in one eye. So we negotiated with NIH to, at no additional cost to them, add another study arm, the high-risk group, the patients who could benefit from this, but in whom we're not going to wash them out. We're going to do adjunctive SLT. We're going to add SLT to whatever they're doing, and we're just going to see how well it works. And these were people who, the primary goal of treatment in some cases was IOP reduction. In other cases, it was medication reduction, because we had some patients who were just the only medication they could afford was timolol, but they had systemic problems that would preclude the use of timolol, or they were getting significant dry eye, they had BAK allergies, things like that, people who needed to get off drops. And we established at the time of treatment whether the primary goal of treatment was medication reduction or IOP reduction. And that's something that's almost never done in any of the studies, because when you pool all of those, half of the people you're doing it to get them off meds and their pressure's not going to change, right? In the ideal scenario, they are using one less medication, but their pressure is the same because they were well controlled on drops, you want them well controlled off drops. Then in the other case, you're trying to get their pressures down, but you're not necessarily expecting to be able to take them off of any of their drops. You're trying to get them down so that the drops they're on are actually sufficient to control their pressure. And when you add all of those people together and do the IOP reductions and the medication reductions, you're dividing both by half. So you're greatly underestimating the patient-specific goals of therapy. So we pre-specified the patient-specific goals for therapy. And so in the patients who underwent SLT with advanced uncontrolled glaucoma for IOP control, we did get a meaningful IOP reduction with no significant reduction in medications, exactly like you'd expect. And the IOP reduction of about 4.5 points is a 20+% IOP reduction that is exactly what is generally recommended for people when you're adding an adjunctive therapy, a 15 to 20% additional IOP reduction. In the medication reduction cohort, we had no change in IOP, as you'd expect, but we did have a meaningful reduction in medication use. Not a huge one, but some, in some direction. So in this small add-on study that was mostly a compassionate care study that we decided to extract some useful information from, we did show that SLT, even in patients on maximal medical therapy or with advanced disease or intolerance to medications, could still provide patient-specific outcomes. One of the problems with running a wilderness wildlife refugee center is that people call you and say, do you take so-and-so? The cat that I have actually came to me when my secretary at the time, my administrative assistant, said, you take cats, right? Oh, hell no, no. We do not take cats. No, I don't want to be known as that person because that's how you end up with 14 cats. We took the cat. But my lead technician came in one Monday morning and said, so do you take possums? Oh, do you take possums? What? Do I take Venmo? Do I take Apple Pay? Do you take possums? Because we had two little possums that their mom was hit by a car, and they're living under my hot tub right now. I'm like, fine, bring them over. So she brought them over, and we named this one after the fact. We named this one. I actually picked the thing up. I don't know what possessed me to pick this thing up, right? I mean, in my hand, with no glove or anything. Absolutely docile little thing. I mean, it opened up its little mouth, but I belong to so many possum friends of possum groups on Facebook that I have learned that opening their mouths is not a threat position. It's just they're nervous thing. The things I know about possums. Anyway, I set the little thing down, and it immediately beelined for the creek and swam across the creek and up the hill on the other side. We never saw it again. So we named him Michael Phelps. So this is Michael Phelps. But yeah, we take possums. Isn't that an adorable little thing? Yeah. Tell me this is a possum question, please. No, darn. I don't have the patience for it. We have a really good fishmonger down the street. There's no ahi in the creek. Without tipping my hand, I will tell you that I am writing that grant now. That exact question. If we go to SLT first, what does that mean for what we do next? Yeah. And I don't want to say any more about that than that right now. Ask me back in 7 years and I'll tell you the answer. So what is the impact of the LIGHT study? Have we actually changed the paradigm at all? In Europe, the EGS, European Glaucoma Society guidelines for treatment glaucoma in 2014 listed the indication of SLT as it's great when IOP is not effectively controlled with medications, or secondarily as an initial therapy. Secondarily as an initial therapy, you know what I mean? By 2020, in the post-LIGHT era, note that initial treatment is now the primary indication for SLT, and that as an add-on or replacement therapy is now the secondary recommendation. So there's been a significant practice evolution in Europe. And the National Institute for Health and Care Excellence, which is a think tank that does all of the evidence-based medicine for the NHS and then tells them what they ought to do, has subsequently recommended that SLT be the preferred first-line therapy for newly diagnosed patients with glaucoma. And this has been adopted by the NHS, sorry. And we are working diligently to get Moorfields Eye Hospital active as a coast site because they will be a high recruiting center once we get the lawyers on both sides to agree to certain language. Excuse me, what about the US? Well, the American Academy of Ophthalmology's preferred practice pattern for POAG in 2005 listed trabeculoplasty as an alternative for patients who cannot or will not use their meds. By 2010 and 2015, it could be considered in selected patients as initial therapy. And by 2020, it can be used as initial or adjunctive therapy. So it's evolving here too. The problem is, hang on one second. My allergies are horrible lately. Smog apparently is one of the things I'm allergic to. So I brought lifesavers. Yay. Okay. The problem is that we don't have an NHS. We don't have a national governing body. So we have nobody who will tell all of the ophthalmologists and optometrists in the US to start doing it this way. We've got to wait for every individual provider to embrace the paradigm shift herself or himself and start doing it in their practices. And we have very little information right now on SLT utilization pre and post light, so we don't really know what its impact is in the US. Time will tell. Meanwhile, we live with the paradoxes of doctors who would want SLT for themselves but don't routinely do it for their patients. And we talked about that already, why that is. It's not because they don't want to, and it's not because they don't believe in it. It's because they just haven't figured out how to talk to their patients about SLT. So that's my new mission. This was a cool night. We had some leftover fried rice from Lee's Chinese and threw it out there, and the 3 babies were eating it while Mom stood guard as the skunk approached. I mean, there's 5 critters in that one at least. And then I realized I was standing out there taking a picture of a skunk, and I was on the wrong end of the skunk, so I went back inside. So what's next for SLT? I want to wrap this up real quick because we're running out of time. Can we make SLT easier? And the answer is yes. Direct SLT, you guys have all heard of this, right? This is the Belkin laser system, the Eagle system that's being developed in Israel. This is the technology that I was the medical monitor for their big study. This is direct application of SLT to the limbus without a contact lens, without any coupling agent. Just fire it at the limbus and it goes all the way through the conj and the sclera to get to the TM directly. So it obviates the need for good gonioscopy skills, except that I guess you probably want to know that they have POAG and not angle closure glaucoma before doing it. Except that the company is now doing an angle closure study in primarily in Asia, with the hypothesis that, well, even in eyes with anatomically narrow angles, anatomic angle closure, when you look at them with gonioscopy, there may still be some aqueous getting to the meshwork. And if we could enhance how well the meshwork works, could we actually lower the pressure even in those eyes? And if it does work in angle closure glaucoma, then you wouldn't need gonioscopy to differentiate the diagnoses because they would both be indications for glaucoma, and that would go a long way. It's an automated system that auto-focuses and auto-aligns. You literally put your chin in the chin rest, your forehead against the forehead thingy, and push a button, and the machine starts saying, all right, look at the thing in the looky thing. And when it focuses on the eye and determines your white-to-white distance and figures out where your limbus is automatically, it automatically fires the spots. And it puts in 120 treatment spots in just under 2 seconds. It's so easy that I can do it. Oh, it even has gaze. This is the coolest. It even has gaze tracking. So if you look away, it stops, so you don't end up SLT in the cornea, which would suck. And in a 12-month study comparing SLT in one eye to DSLT in the other, the results were basically superimposable. It works just as well as SLT and with no significant safety issues that have been identified so far. It's easier than SLT. It's much faster. There's a much better patient experience. There's no goop running down their face. There's no blurred vision from that goop afterwards. And it has significant potential in low resource areas where the disease burden is high, like in sub-Saharan Africa, because it's portable, it's small. There's no need for gonioscopy skills to perform it, and possibly even to identify candidates, depending on how the ankle closure study goes. And not only does it not necessarily require an ophthalmologist or an optometrist, it's very likely that my cat could do this. In low resource areas, it's going to be critically important to have an intervention that is not patient administered, because in the best of scenarios, in the US, we can't get people to take their meds. In a place where 80% of people are living on $5.50 US a day or less, buying their latanoprost is not going to be a priority, and adherence is never going to be good. And a physician-administered therapy is never going to work, because there will never be enough healthcare providers, eye care providers, to address the burden of glaucoma in Africa. What we really need is something that community health nurses can administer, and this may be it. Like I said, my cat can do it. I mean, this is my cat. This is her reading To Kill a Mockingbird and realizing that you cannot judge a book by its cover. There's nothing useful in this book for her. What? Oh, no, sorry. Somebody's going to say something clever. Can we make SLT work better? That's a really good question. The responsiveness to SLT, yeah, what?
Yeah, can I just mention, so the Belkin Eagle Vision, it does have a PDUFA date of what, October 28th to 26th.
Okay.
So it may be, approved by the FDA.
Next month.
Yeah, very shortly. And in terms of cost, they cost it out to be comparable to what an SLT laser would cost.
Yeah, the downside is that it's a single-use laser. And most of us have now moved on to the 2-platform or 3-platform lasers, so that with one space footprint in our office, we can do 3 different lasers.
So, I mean, it was interesting that Gus sort of made the point that at Moorfields, this has replaced almost all SLT.
Well, especially since they're doing so much of it.
Exactly.
Primary.
That's the reason why.
Right, exactly.
The throughput.
And they've now, I mean, optometrists are performing most of the SLT now, I think, at Moorfields. All right, let me keep going.
Is there any data on repeat measures?
No, not that I'm aware of. Yeah, and that would be useful to have, because it may potentially have different, I don't know, the overlap of the efficacy on the efficacy slide there is really quite impressive, I think, suggesting, that great promise, great promise, still early times. So the current approach to SLT is we do it, and when it wears off, we do it again. When it wears off, we do it again. So PRN repeat as needed. And over time, we just stop responding to SLT. Most will get 2 or 3 treatments out of the way before we, the third one maybe doesn't work, the 4th one maybe doesn't work. And this may be due to, time has passed, the patient's gotten older, the meshwork stops working with age. They've had glaucoma for longer now, so they've had longer exposure of the TM to glaucoma. They've also had a couple of SLTs, and SLT, even though far less damaging to the meshwork than ALT, is not benign to the meshwork. I mean, you're still doing stuff to the tissue and causing tissue changes, both to the TM cells and to the extracellular matrix that support them. And all of these things together probably lead to an eventual state of non-responsiveness in the angle where the meshwork just stops responding. Thank you. So Stefano Gandolfi at the University of Parma in Italy, in 2018, presented this study in which blue line, standard SLT repeated as needed. He also had a group of people who underwent low energy SLT that he did annually as sort of a booster to keep the trabecular meshwork healthy and happy, rather than waiting for it to become re-impaired and then doing rescue therapy, which is what PRN therapy really is. It's rescue therapy once the meshwork is quit working. And look at the difference. I mean, there's like a 65% medication-free survival rate at 10 years in the low energy annually, compared to about, 28% in the PRN group. It looks like if we do low energy SLT once a year and keep meshwork healthy and happy, we can keep people off medications for a lot longer. This got me interested. So I went and read the literature after I got home from Arvo. And it turns out that while standard energy SLT does produce iatrogenic TM damage, low energy SLT does far less damage. And it also, in a handful of very small studies, low energy SLT lowers IOP comparably to standard energy SLT. We talked about PRN SLT being basically rescue therapy. Annual retreatment, irrespective of IOP. Same way we tell people, tomorrow I want you to take your next latanoprost drop, even though your pressure's still good. Don't wait for it to wear off before you take your next one. Let's do that with laser as well. Let's see if we can maintain TM health and function and keep it healthy and happy, because we know from so many different aspects of medicine that there's only so many cycles of rescue and repair you can go through before things just, the wheels fall off the bus and you start, the law of diminishing returns kicks in. And this is how the COAST study was born. And if you want to read through this exhaustive literature review that I did to convince NIH to fund COAST, it's there. COAST is clarifying the optimal application of SLT therapy. I really blew it on that name. It should have been light energy reduced. It should have been the lighter study, light and lighter, right? I mean, Gus is even part of the study. He would have totally signed off on that. I really blew it. That's all right. Anyway, so COAST is a prospective multi-center randomized trial to compare low energy and standard energy SLT as primary therapy for newly diagnosed glaucoma. I'm the study chair. Mike Cass, who ran the OAT study forever, came on board to help me with logistics because he knows more about keeping people motivated and in line than anyone on the planet in terms of glaucoma specialists. And Gus Gazzard came on board because he was interested in what this might show. And we even got Mark Latina, who invented SLT, to sign on, which was helpful because that forestalled any questions that the study section might have had about whether the research questions were even valid. I mean, if the guy who invented it thinks that this is an interesting thing to ask, then it must be a good thing to ask. Yeah.
In terms of low energy, so are we talking like 0.2, 0.3, or are you going to like standard energy with the champagne bubbles, take it back a bit, cut it in half? Like, what's your definition of low energy?
Give me a half a slide and I'll get there.
Oh, sorry.
It's all right. COAST asks two questions. One, can we get similar IOP reduction with low energy SLT as we can with standard energy SLT? And can we extend medication-free IOP control with annual low energy SLT compared to PRN standard? So we designed two consecutive randomized trials in newly diagnosed patients with mild to moderate POAG or high-risk ocular hypertension. We changed the protocol recently to allow people who've been on medical therapy for 6 months or less to wash out and get in, because a lot of these are happening at academic centers where the patients are seen by the community eye care provider, put on latanoprost and sent in for their definitive evaluation and treatment. And they've been on it for 2 weeks when they get there and they weren't eligible, and that was dumb. So this is what happens when you sit on the back porch and write a protocol out of the back, just off the top of your head. You don't think of everything. So the first randomization is at study entry is to one of two treatment groups. Either standard energy SLT, which is starting at 0.8 and titrating to champagne bubbles the way we all do it now, or 0.4 millijoules per spot, all the way around 360. You can go down to 0.3 if there are excessive bubbles or pain, but you can't go above 0.4. And the reason we picked 0.4 is because I looked at like 25 SLT studies and the average energy used was 0.8, so 0.4 was half of that. At the primary outcome there is survival without the need for retreatment at 12 months. At month 12, you're re-randomized to either PRN retreatment with whatever energy you were randomized at the start, or to annual low energy boosters to keep the meshwork healthy and happy. And we'll look then at 4-year medication-free survival to see whether we've gotten more people to stay SLT responsive and medication-free by doing it once a year. And to Murray's point, the DSLT would help a great deal with that. If we're going to be doing SLT on people once a year, it would be great to have something that only takes 2 seconds rather than the 7 minutes that I have for bilateral 360-degree chair time. 30 sites in the US, the UK, and Canada. We're about 40% enrolled so far. We have worked with NEI, National Eye Institute, to develop a referral program. And anyone who sees newly diagnosed glaucoma patients in an area where there's a COAST site can send eligible patients to a COAST study site. And if you send one patient in that gets randomized, you get a really cool certificate identifying you and your practice as an NEI referral center, clinical trial referral center. and you get a nice plaque if you can find 5 patients who get randomized. This is where the sites are.
You sent an email to certain OGS sites, members.
Yeah. Yeah, but
Yeah,
some of the OGS members got that. Yeah.
some in here, but we based it by location in terms of geographic region for ODS members and educators. If you're near a referral site.
That's an invitation-only event to people within the geographic proximity of coast sites. So if you practice anywhere near any of these places here, and you are interested in picking up a really cool line item on your CV identifying you as an NEI referring partner, reach out to me or reach out to the site to find out how they can facilitate you getting your patients in. I can tell you it's a lot easier if they're a research patient than if they're a clinic patient, because the study coordinator will give you an appointment and they'll come in as a VIP within a week or two, rather than the 3-month wait that you might have to go through to get patients in for routine clinical care.
Is that nature in the Bronx?
It is. It is.
But they can't be on meds already. Is that what you
They
said?
can be on medications as long as they have had no more than 6 months of medical therapy in the past 5 years. So if they've just recently been diagnosed and started treatment, they would still be eligible. Had a Fox the other night. This was actually just last week. So the new glaucoma paradigm. We know that SLT is at least as effective as medications with less progression and lower rates of surgery. It's arguably the safest therapy available for glaucoma, with low rates of transient side effects and sight-threatening complications being exceedingly rare. There's not a single documented case of SLT non-adherence to date. It's cheaper than meds in the long run, and even more so when non-adherence is factored in. And we've talked about the quality of life issues, and the only reason that we haven't documented an improved quality of life with SLT is because we don't have a way to measure that. When it does wear off, it is eminently repeatable. Study after study after study has shown that. And so I think it's time for us to start thinking about a new glaucoma treatment paradigm that starts with SLT, and maybe with low energy SLT once a year, depending on how COAST turns out. And when you finally stop responding to SLT, maybe then we start thinking about sustained release drug delivery. At that point, we should have multiple options, hopefully ones that can be repeated over time. And again, so now we've gone to a non-topical eye drop approach to a non-topical eye drop approach. Maybe when you've extracted all the benefit you can get out of sustained release drug delivery, you go to MIGS. And after MIGS, now if the only thing left is filtering surgery, now is the time to put those terrible poisons on the eye in an effort to avoid having a bleb or a tube shunt. But I see this as a potential drop-free lifetime for the majority of our patients who will never get past the MIGS stage, the first 3 steps on this new treatment paradigm. Yeah?
Would you say the cost effectiveness of SLT if it's annually done is still be?
That's a really good question, and I don't know the answer to that, but I think a lot of it's going to have to do with how long it extends medication-free survival. Because if you can make it, if right now the average patient is making it 4 years med-free before SLT stops working, and we can go to 10 years, then I'm not stealing peanuts out of the flying squirrel's feeder. I don't know what you're talking about. So just the last couple of slides, because we have to talk about this a little bit. Optometrists perform 85% of all the primary care in the US, and you guys are the ones identifying and diagnosing the glaucoma in the US. And you can only do SLT in 9 states. I think that's correct. This was based on what I found online yesterday. Yes. Is that correct? Yes. And only 3 of those states have an optometry school. So only 1/3 of optometry students even have the opportunity to learn to do SLT during their training. So you guys should put schools in those other states. Do we know, are lasers being taught
Yes.
in the schools where, okay, but only in the schools in the states where it's allowed, right? No? Okay. But then if you want to do them, you have to go to one of the 9 states, at least for now, right?
Yeah.
Okay, cool. All right, good. How many of you have done an SLT? Okay, cool. It's as safe and effective when you do it as when I do it. We did a study, actually, we did very.
know we're recording this.
This is data. I can cite the study that this came from. In fact, I probably should have put that on the slide. I've been very, very careful about what I've said so far, because I don't want my AAO card taken away. Studies have shown that SLT performed by optometrists is as safe and effective in lowering IOP as SLT performed by ophthalmologists. The learning curve is not that steep. Mark Latina ran the multi-center clinical trial to establish SLT when it was first invented. And I asked him, I said, were there any sight differences? He goes, no, everybody picked it up really quickly. Okay. So then I started tracking resident and fellow SLTs versus my SLTs. I would do one eye, the resident would do the other. On some patients, I would do one, the fellow would do the other. And getting rid of all of the intra-patient variability. We never published this, it was really just informal, but the IOP reductions and the IOP spikes, everything was completely identical. People who were doing their first SLT, people who were new in the glaucoma training process, and me who've done thousands of them. And it's going to be a lot easier with the Belkin DSLT, where my cat could do it. There's possibly a higher repeat SLT rate with optometry performed SLT compared to ophthalmologists, but in that study, more optometrists were doing 180 as opposed to 360, and it may just be a dose response effect. The development and rollout of an optometrist-delivered SLT service seems an important step toward addressing the current and expected demand for SLT, wrote the Light study team. But they did add, careful design of a standardized transferable training scheme and robust governance are necessary for the national rollout of optometrist-delivered SLT. That was one of the 5 babies we had this year. Thank you. I know we've answered a million questions, and you guys probably need to move on to what's next now.
We have a 30-minute break. I would like to see if I can look at the questions in
sure.
the chat box.
Yep.
While I'm trying to figure that out. Take that paper clip off, please. I have a question. So there are some predictive models of who's going to be, successful with SLT. If your highest pressure is this, but you're starting at this once you get SLT. When you're talking about primary therapy as SLT, do we have evidence that lower starting intraocular pressure is less successful? And would you still consider SLT as primary therapy in those patients who have lower IOP? You talked a little bit about it with the Afro-Caribbean patients, but in general terms, do you have any reservation about that?
So Light published a study on predictive factors for successful IOP, and across all of the different studies that have looked at that as primary or adjunctive, the only one that stands out is that the higher your pressure, the more likely you are to have a successful SLT. The higher your pressure, the more likely you are to have a successful start with latanoprost or Rescula, or undergo any of the many minimally effective invasive glaucoma surgeries. Higher, whenever there's a bigger therapeutic window, there's going to be a bigger effect. That doesn't mean that people with a lower starting IOP won't have a meaningful reduction either. In our West Indies glaucoma laser study that I showed you, those really cool results from, the average starting pressure was 21, which means that half of the patients had a pressure below 20. I generally, in my own practice, I don't laser people whose pressures are below 15, usually below 16. We didn't put an IOP criterion on the COAST study eligibility, specifically because I didn't want to say, if I said 21 or greater than 21, there are a lot of people with pressure of 21 that would benefit. If I said 21, there were a lot of people 20 who would benefit, and it became a slippery slope of where do you draw the line? So we decided not to draw the line, we left it to the PI's discretion. I get this question a lot. I've got a patient with a pressure of 12. Are they eligible for COAST? The answer is yes, but if you weren't being paid $8,000 to enroll this patient in COAST, would you really do SLT on this patient in your clinical practice? Probably not, because there's very little evidence that a patient with a pressure of 12 is going to have a meaningful IOP response to anything that you do short of surgery, or maybe natarsadil, which can have some effect on episcleral venous pressure and maybe help you get a lower target pressure. So I don't tell the investigators who ask those questions not to enroll the patient, but I do say, look, they need to have a 25% IOP reduction. Unless you are confident that you think that SLT could get them down to 9, then all you're doing is enrolling a patient who's going to fail early, take up a coast spot, and not contribute any meaningful data to the study. So please act accordingly.
Thank you. I think we have a couple more questions, but I don't know how tied we are to this break, Murray.
Well, I mean.
I'd
we
like
need
to.
Be close to the time, so if we can go like till 10 after, then we need to wrap it
Okay,
up.
John was next in the back.
Three items.
All right,
Not
you
fair.
get one.
Pick
You get
one.
one, John.
Steroids, yes or no?
No.
Two bad candidates.
Angle closure. I will keep lasering them until they no longer respond. Now, I said earlier, I think it was to you, that I would repeat it if it doesn't respond very quickly. But if you've had good response and then a good response and then you don't respond, I don't flog those by going, oh, let's try it again. Once you've stopped responding, you don't respond. Steroids are pointless. Yes, I'm aware of the SALT trial. Go back and look at the SALT trial. It's a great design, randomized clinical trial. They made one fatal flaw. They left it up to the investigator to decide whether to do 180 or 360. And there were far more 360s in the prednisone group and far more 180s in the control group. And all of the different responses to SLT can be ascribed completely to dose response effect and not to the presence of anti-inflammatory therapy. I haven't used anti-inflammatory therapy in 15 years. Not a single patient in our Wiggles study, hundreds of patients, got steroid drops. 2 came in with symptomatic inflammation, and we were able to treat the 2 who needed it rather than the hundreds who didn't. People with angle closure glaucoma. People with uveitic glaucoma, I don't generally do it, but if we've exhausted medical therapy and the next step is surgery, then the fear of precipitating a little bit of extra inflammation is a really low risk compared to the risk of having surgery. So I will try it in those eyes, absolutely. It's just a matter of only when everything short of surgery has failed.
Last question right here.
Well, toast doesn't let anybody in with a pressure above 35. And that's largely because I just think it's unlikely that anyone with a pressure of 36 is going to achieve whatever their target pressure is with SLT alone. So I think if you're an ocular hypertensive with pool fields and 0.1 cups and a pressure of 35, I would very much likely laser you with the hopes of getting a 20% IOP reduction, which is what the OATS study suggests is protected. That's only 7 points. That seems entirely reasonable. You'll probably get more because the higher you start, the more you're going to get. But I mean, if a patient comes in with a pressure of 50 or 60, I'm not going to laser them. They're going to go to the OR probably.
So where do you go, but a patient that has moderate diabetes, glaucoma, you have pressure 30s, for example, you go out.
I usually go straight. I will usually put that patient on triple medical therapy and have them follow up in a couple of weeks with the understanding that if they're not where they need to be, we're going to be scheduling surgery. Were there any online that we needed to get to?
They were simply practical
cool.
matters.
Cool.
Yes.
Well, thank
yes.
you all.
Thank you very much. We're going to take a break.
There is a reception tonight, 5:30, a couple of blocks. And Tony will show you more photos this afternoon after he's laid out.
Oh.
Well, so I go see.
All right, we got a break now.
Good.
So I think one of the issues is that the people
Right.
So here's a mobile.
part of the problem. We have is-
Oh, do you want something to plug in here? Oh, okay.
I'm just trying to charge my phone.
The questions that came in were about the.
I know, so that's the
Okay.
logistics,
All
and
right.
and I'll tell you.
Okay, yeah, I could, you know what, I tried to open up my computer and realized it was completely dead and I don't have my charger, so I
No,
couldn't get to
we're good.
those. Okay, all
So-
right, thanks, Murray.
No, so and then Don, we'll just, that, I know, we'll just have to.
Hey,
make
Dr.
that-
E.
Thank you.
And then, the participants have just asked. This one,
Okay, welcome back, everyone. We're gonna go ahead and get started with our second session here with Don Hood, who is returning for a follow-up to his presentation in 2017. Who was, can I show of hands, who was here in 2017? And so, this was the infamous, the educators are getting back together. Actually, we had a couple meetings in 2008, 2009, 2010, then a gap. And then we were able to constitute the educators meeting. Murray and Don doing a lot of work in New York, and Murray reaching out to Don saying, I'd love to have you come and talk to the optometric educators about interpreting and using OCTs. And so Don said, sure, right? And then well, how much do you want me to do? And Murray goes, well, we've got 7 hours, And so I was like, whoa. But, all of you, I hope, we've shared with you the videos of that 2017 meeting, where Don is just really, I'd say, turn things on its head on how we use OCT, how we interpret OCT. And over the past 6 years, he's continued to do more and more work in that area. I've had some really good fortune to be able to work with him on some projects. And so Don wanted to come back. We wanted to have Don back to follow up on what he's been working on in terms of OCT interpretation, making it easier for optometrists and ophthalmologists to use the device, and also how we teach our students to better understand OCT, better understand the foibles of OCT, and make it just easier for us. So I'm really pleased to have Don back here. His bio is in the program guide. For those of you who were here in 2017, it's a welcome back. For those of you who are not, you're going to really enjoy this treat. So thank you, Don. Good to have you back.
Thank you.
Okay, so, first of all, well, let's get rid of the, financial disclosures first. So I have equipment and grants from both Don and Heidelberg. So I did not make this title up. This is Murray's title, but it's actually a good one. In fact, I think it's better than the one I had. But I do object to the first sentence. In the first educators meeting, Dr. Hood discussed how OCT may be used and discussed. It was 8 hours, not 7. And it was 8 separate, 30-minute lectures followed by drilling. And then, the way you go in there, 6 years later, I'm coming back to update. When I was talking to my wife a couple of weeks ago, she said, we always talk about the other person's working, so I know the detail of talks that she's working on, and vice versa. I said, well, I'm doing that talk for Murray. And she said, oh, really? I said, yeah, you know, I think we give you an hour and 40 minutes, and maybe another 20 minutes, you know? And she said, oh, wasn't he the one who gave him 8 hours? And I said, that was, you know, really hard. She said, a little punitive. So, but then she, you know, it's not usually a style, but then she turned and became very positive. She said, you know, you always enjoy working with Murray. And besides that, isn't that an educator's meeting? So shouldn't that be fun for you? And I thought, you know, I didn't think about that. I mean, you sold me on this because if you want to change the field, you want to educate the educators. But I didn't think about that would be fun. Because what we have in common, many of us, is we teach as part of our living. And I've been teaching for 55 years. And if I've learned anything, is you can always make a lecture better. In fact, the moment you think the lecture can't be better, you probably should stop giving it and do something else for a living, or write a new lecture or something. So I'm open to ideas about how to teach this better. Okay, with that, so this is an outline. One of the ways I'm going to try to make this bearable is split it up into at least 3 Q&A sessions. I may sneak in a bonus Q&A along the way. And I already told you about that. All right, so we're going to start with basics. And one of the things that mistake people often make when they lecture is they know they have to figure out what they want to talk about. Right? And they know they need a lecture. What the mistake they often make is the second step is to understand what's in the student or the audience head. Then you design the lecture to get the first to the third. So in that same spirit, I usually start my lectures with some basic material that you may well know, but I want to make sure it's fresh in your mind because we're going to make use of it. Okay, so already we've got a problem. We've turned my fundus photos into eggs. Okay, anyway, to understand the patterns of glaucomatous damage that you see on OCT, to understand OCT, you have to keep in mind the following. Glaucoma kills ganglion cells in their axons, which means that you need to review the surface anatomy of the retina, that is the route the axons take from the cell bodies into the optic nerve. And this schematic also depicted as an egg. You've seen in lots of different textbooks. It's meant to capture the following aspects of the anatomy. The ganglion cell bodies on the disc side of the nasal side or disc side of the fovea send their axons more or less straight in, while the ganglion cells on the opposite side during development arc around the fovea. This is only a small part here of the back of the eye. So you've got lots of other axons coming into the inferior and superior quadrants. And this is a region that has particularly dense axons and is particularly vulnerable to glaucoma. Same thing occurs up above. I didn't draw all of them in. All right, so these two regions, these black arcuates, are regions that are particularly vulnerable to damage from glaucoma. All right, the other thing you have to remember is it's pretty much accepted that if not all damage due to glaucoma, certainly the overwhelming majority of the damage occurs either at the edge of the disc or inside the disc of the lamina tuberosa. So because of that, you're going to have characteristic arcuates. And to understand those characteristic arcuates, I've superimposed tracings from bundles from a young eye that was published years ago by Jansonius et al. And what I want to remind you of is that damage here will produce a characteristic arcuate pattern, as will damage up there, as well as local damage, as well as local damage there. So you can choose your spot for damage, but you're going to get characteristic arcuate. That is what you're looking for. We're not going to be looking, so we're looking for patterns that are characteristic of glaucoma. We're not going to be looking at pie charts. Glaucoma doesn't turn a pie chart different colors in the back of your eye. Glaucoma is killing ganglion cells and producing arcuate defects. forget the pie charts. Okay. All right, now, I don't think I have to tell you about OCT. I think the only thing you really may want to tell my students so they get oriented, you have to give them all the details of the physics, but I know how you do it, Mike. But I tend to say, you know how ultrasound works. You pick up a little lump in the breast. Well, light has a shorter wavelength. We're able to see layers that are 10, 5, 10 microns rather than 2 with the OCT. Okay, so this is a line scan through the fovea of a healthy eye. The ganglion cell body sits there. There's the axon. So we're going to be talking about the ganglion cell plus in a flexible layer thickness. Most of the things I'll be showing you are actually from lines that I'm just going to call that ganglion cell. And we're going to be talking about the retinal nerve fiber layer, which is made up of the axons. Okay. So this is a new part of the new ways to evaluate OCT. I started lecturing on OCT over 10 years ago. We developed the Hood report, which I'm going to tell you about, in 2014, a couple of years after we started lecturing on this. And I lectured, and more recently, we developed with my colleagues, I'll tell you more about that, a new simplified method that we'll be teaching you about. So this is new for us. So we're calling it the Columbia University method because it was actually developed with my colleagues at Columbia. Jeff Levin is director of glaucoma and vice chair of the Department of Ophthalmology. And he got together those of us who were interested in glaucoma at the time. And I guess we have at least one person in the audience. Gus is a third author on that paper there. And the challenge he posed for us is, how can you teach this with simple steps, the way we try to teach photos and the way we try to teach visual fields and things like that. Okay. So it makes use of the report that an undergraduate, a research person, actually he was staying on with for me, this was a couple of years after he finished his degree. He and I developed this report in 2014, and it was designed to help people like yourselves quickly diagnose and understand the damage. All right, so for these purposes, we're not going to use the pie chart. If I have time, I could probably tell you a little bit something about this en face. I think that is useful, but we're not going to use it as part of the formal method. So this is what we're going to use. All right, so now the method makes use of reports like this. It involves 3 questions for the clinician to answer. The first 2 questions involve the retinal ganglion cell and the retinal nerve fiber layer probability maps. So it involves these 2 probability maps. Okay, you can find these reports not only on a TopCon, the TopCon machines available in the States have a Hood report in them with a ganglion cell map and a retinal nerve fiber layer map. Heidelberg also has these maps in the international. In the US, these are just thickness maps, but you can use it sort of the same way. And I'll say more about Zeiss because I know some of you talk about Zeiss. I use Zeiss. And Zeiss also has a ganglion cell probability or a deviation map, same thing, and a retinal nerve fiber layer, but they combine. Okay, so you can find these on the machine near sheet. That's the point. That's also different from 6 years ago. You couldn't say that 6 years ago. Okay, so how do you get these probability or deviation maps? So this is a choice point. So this is a little trick I use with undergraduates to keep them awake. So what I mean by a choice point is that most lectures, even if they're well developed and so on, have a couple of choice points. A good lecture shouldn't have more than 3 or 4. What I mean by a choice point is you, as an audience member, have a choice: either understand what's coming the next 30 seconds or 60 seconds, or go to sleep. Because you're going to need it for the rest of the lecture. Okay. So this cube scan in this particular case is made up of 256 line scans but it can be anywhere from 512 to 61, depending on the machine and the protocol. But each of them, if you look at them separately, they're going to have a retinal nerve fiber layer layer that shows you the borders, that is the software segmented and created these borders, and then the thickness map is going to depend upon that thickness. Okay, so from these B scans, you get this thickness map. The thickness map is in pseudo color, where red is very thick and blue is very thick. Okay, from the thickness map, so there's the tricky part, we're going to get a probability map. And the way that's done is, well, first of all, it's color coded. So green is within normal limits, yellow is 5%, red is 1%, dark red is 0.1%. It's a continuous probability map in the case of okay. The way that's done is the software takes each location on the thickness map. Oops. Each location on the thickness map, compares it to the normative database, and gets the probability. Okay. Now, what I do in this report is I flip this along the midline. So this is now superior visual field, inferior retina, and inferior retina's superior visual field. You should, when I made this decision, and I told my ophthalmology colleagues, half said, don't do that, half said, do that. So why would the half say do that? The reason for doing that is you can now compare this to visual fields, which I'll show you in a moment. All right, ganglion cell, if you understand how the retinal nerve fiber map is created, then the ganglion cell thickness map is the same way, except now you're looking at the ganglion cell here, plus in a plexiform. And there it is for that center region. And again, red is very thick, blue is very thin. Now you might be saying to yourself, why is red good in the thickness map and bad in the probability map? And not my fault. I always apologize for it. I don't know why I apologize. I should apologize for it. But that's not the nature. But anyway, it goes back to the original way. It's always been that way. So they started out with red being thick. And then once you create a probability map or a deviation map, well, wait a minute, red can't be good, but red has to be bad. So anyway, I think you can make that adjustment. All right. So again, color coded the same way. And again, that would be superior visual field, inferior retina, vice versa. Okay, so the reason why we flipped it is because we were thinking about making it easier for the clinician to compare it to visual fields. So this is what you can do now. So this is the superior visual field. So here's a 24-2. And if we have time, by the way, I have a whole section at the end that you gave me, now or 40 minutes, about visual field and OCT comparison. All right, so now if you look at the report here, you might notice that up above, you can't quite see it, but there are small points for the 10-2 and larger points for the 24-2. So if you blow this up, you might probably see it now. So we circle these points, those, there they are. Right, so now I'm circling the region, the points that are abnormal on the deviation. Here's the 10-2. If I circle those points, those are the points right there and right there. So you can quickly see, so you can see if you've got subtle damage right away, you're going to be able to see comparison there. If you look at mean deviations and global thickness, and the patient. Okay. I snuck this in. This is a bonus. I want to see if we can generate at least 3 dumb questions. And so this is another trick that I use with undergraduates and residents and fellows and my 60-year-old fellows. So a dumb question is a question that you feel embarrassed to ask. And chances are lots of other people have the same question. So overcome that. By the way, I never use questions. This is the first cartoon I used, I think, in 10 years. This cartoon is funny collection. Instead of listening to the speaker son, trying to figure out why that been cartoons in the first place. It isn't funny, but anyway, don't use cartoons, that's it. All right, dumb question, please. Question of understanding.
Why don't we have probability symbols of the field part of that combined?
Excellent question, because they're not readily available. But that is exactly where this is going.
But they are ready. There are only 24 dash 2.
Well, you have to have this, you have to reverse engineer the 24-2. To get those numbers out. Then you have to get the FDA approved.
That's where I was going.
I mean, this was hard enough as it is. That's absolutely, that's, I'm surprised that's not a dumb question. So let me try again. It's a good question, and that's what's, that we have a problem. We have Chris Johnson's old information from years ago about what's. Question, yes.
So you showed an extreme visual field defect there, but let's say there's a more mild case, a pre-parametric case of glaucoma. And will using that probability map be predictive? Is it sensitive enough to pick up to predict a visual field defect?
Yeah. So the I have to repeat the question. Yeah. So the question is, this is an obvious example I showed. What about subtle examples? And let me rephrase this. What about pre-parametric, for example? If you're pre-parametric, will you see an OCT? That extra piece of lecture that I'm sure I'm going to have time for, we'll go into it. The simple answer is structure and function go together. In almost all eyes, they're going to match. In some eyes, you're going to see abnormalities on structure and not function very early, and vice versa. And I'll show you examples. Yeah. That's not also, these are not dumb questions. So the question is, you often don't see, let me paraphrase, you often don't see the complete visual field defect either on the visual field or on the OCT. If you see it on the OCT, you see it on the visual field. And the answer is, by and large, yes, if you had the right spatial resolution, right? But it's a little more complicated than that because it's going to depend upon where you start out life, what shows up better with structural function. And again, I'll mention that next. Okay. All right, so let's go to the simplified method. So this method has 3 questions for the clinician to answer. Question number 1 concerns the retinal nerve fiber probability map. Right there. Okay, so question number 1 is there an arcuate-like, something that looks like an arcuate, abnormal region on the retinal nerve fiber probability map associated with the temporal half of the disc? So the temporal half of the disc is that right there. Here I'm going to show you eyes from a recent publication that go from early glaucoma to advanced. This is advanced glaucoma, and we defined advanced glaucoma, but it's not a good definition, but it's accepted one based on visual field deviation. So all these eyes were worse than 12 dB mean deviation. And you can see if you take any one of them, they're the references. You take any one of them and you superimpose it, you can see in the advanced cases how nicely you see the whole argument. All right, here's some moderate, same rule by and large. Here's a moderate eye that's not as badly damaged. Again, you can see the agreement. Early glaucoma, these eyes all had mean deviations better than -6. All these eyes came from Gus DeMore's MAPS database that we started developing, 8 years ago at this point. All of these had mean deviations better than -6, many of them zeros, -1 and +1. But they all had some points that agreed with the OCT. So we can be confident these eyes have glaucoma. And you can see in this case, this is a good example. You can see the bottom one, crosses the midline. The top one, you don't see the complete arcuate yet. Okay. Now, the key here is all of these Anyway, all of these eyes have red pieces at the beginning of the ocular near the disc. They all have some red near the disc. So we made use of that. Even these very subtle ones have some red near the disc. All right. So we're going to make use of that in the first for the first question. So when do you say no? So here's the rule for no. If the retinal nerve probability map does not have a red region near the temporal half of the disc, then the answer to question 1 is no. So all of these are examples of no. Many, and once you say no, by the way, you're done. You're not really done. You're done as far as the method is. The answer is no, and if the answer is no here, you're on solid ground. It's not glaucoma. All right, so many eyes are like that. You'll see some eyes with little red spots in the center. That's due to the fact that these probability maps are formed by the center of the disc. So the fold, wherever the fovea is, it's off the average, you create a little lot of it. But it's not in the disc. You can get scattered red spots. As far as we're concerned, that's a no. You'll often see little red spots near the raphe, with the same the software gets confused with segmentation. You'll also see pieces of an ocular like that. That's not glaucoma. That's none of that. Same with this. And then the nasal half is often prone. The reason why we're ignoring the nasal half is that's often prone. All right, so let's take some examples. According to this method, is question 1, is there an ocular abnormal region on the retinal nerve fibrillary probability map associated with temporal half of the disc? The answer is no, right? You're done. It's not glaucoma. Now, good practice is to at least look at the B scan here. It's not a formal part of the method. But good practice is to look at this, and you can see nice, pudgy, thick, healthy looking discs. Okay. Another one. This, yeah.
What do you do? I mean, you can look at the B scan if you have a Heidelberg or a Top Card. And what do you do about some of the other devices that the B scan you can barely make out due to resolution?
Yeah, well, you try to fish the moment as ice. Which I'm finally making some progress on, by the way. I mean, this new, right. Moment, the best you can do is go to the retinal nerve fibrillary report, double click on it, curse about how crappy the image is. You said this is right. Yes. That's the best. No, it's a real loss, and this is an incredible technology. Why you wouldn't look at the images like many of our colleagues do? Why you would then go even further and look at on pie charts? It's just that's it. Okay. Thank you for that question, Murray. All right, so this is a no. Again, it's always good practice to take a look. Oh, look how healthy those guys are. That's a thing of beauty. Yeah. 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 Oh, well, on OCT, they almost always do. OCT, visual field, no, OCT,
Can you repeat the question?
yeah, I'm sorry, the question was, isn't it true that a visual defect doesn't have to go all the way to the nerve? To the nerve. Anatomically, it has to. Anatomically, it has to go. That's why but you're talking about a photo now, not an OCT. Yeah, so show me OCTs with clear defects that show up on fields and photos and so on that don't show up with red images. on the photo. Yes, and if you think about it anatomically, it's gotta be damaged near the disc. It's gotta be, because it didn't get to the ganglion cell without going past the disc. So it had to.
There's enough redundancy in parts of the RNFL where it's the thickest that you wouldn't deviate from normative data yet, even in those thin, but like
Absolutely.
further out, it's more spread out, so you can pick it up.
Absolutely, that's why you wanna look at the whole report. And you'll see examples of that. If you give me a second, you'll see examples of that, not by the end of this, but at least from what else, also whether it's close to the. But absolutely. But again, we've tried this out on hundreds and hundreds and hundreds of eyes, so we're talking about, let's get straight. This is a vehicle for teaching, so all teaching is a little bit of lying, or oversimplify, so you'll see by the time I'm done, I want you to look at this whole. I want you to look here, I want you to look here, I want you to look at everything. This is the way to get you. Trust the verify. Yeah.
Done.
Yes.
Move the microphone a little higher. We have a person online that just put the hearing in.
Oh. Usually if I tech.
Yeah. That's paperclip.
Okay.
I think that's fast.
Okay, so you might remember we said we were ignoring, this little bit here, right? It actually, you can see what this is. Well, we can talk about this more later, but this is the peak. This red line is the normal, the average place for the blood vessels. The blood vessels you shifted over, the arcuate shifted over, so you're getting this little tiny artifact, right? So there are also ways to make use of this other information. So you can even explain why you get this. That is an artifact. I guarantee it's an artifact, but you can see why it's there. Okay.
That's an instant curve, right?
This is an instant curve. I'm sorry. Yeah, I probably should have said that earlier in the lecture. Yeah. Well, I wasn't going to get into that. Okay. All right. So in this recent publication, we had 250 healthy controls. 92% of them were taken care of with the question 1, and none of the patients fell into that category. So that's just empirical evidence. Doesn't mean you can't find one out there. I just tried if there wasn't one out there. It's a very low one. Okay. All right. So I've sprinkled. This was even before I knew you would moderate it. I sprinkled some of Mike's cases in here to show you how Mike uses it in a clinic, School of Optometry. You can find where this comes from is Murray and Mike and I and my young colleague Manos Thomas gave a course at the American Academy of Optometry in 2022. They didn't record it, we didn't record it, but Mike and I went back and recorded the first part of it, which was my basic lectures followed with his examples. So I recommend that to you if you want to know more. If this lecture doesn't get online fast enough, you can see some of the material there at least. All right, so I have a couple of his cases. So here's a case. This patient was, you can read it yourself, diabetic, hypertensive, large cup to disc ratios, family history. Oh, and Mike noted poor visual field tape. So here's the evidence of the latter. So I don't know if this is all. There may be some rim artifact mixed in here too, but the important thing is this is not representative. Look at the false negatives of both eyes. Mike brought this patient back a couple of months later, repeated the visual fields, and one thing you can say for this patient is they're reliable. And now you can actually see the so-called Mickey Mouse ears too that are often characteristics of people half asleep. Anyway, reproduced. So here's the OCT. No, Mike said. Looks at this. No. A little redundant, but. You look at the other eye, again, no, right? And look how healthy and pudgy it is, right? So Mike points out that one of the advantages of OCT in general, and this technique in particular, is it reduces the time in evaluating a patient and leaves you more confident. I always thought that that was one of the great things about OCT, is the increased confidence you have. And so he follows this patient without OCT. So I have a question for you. Rest my voice for a second. Sure. So when you say follow this patient, given that family history and so on, how often do you do a visual field?
I don't know if I'm doing field again.
Really?
I mean, it's gonna take a lot, but 2 times on a patient like that, too unreliable. You know, was pressure moderate. 16 to 19, yeah. You know, I might have to do another OCT for a year. You know, I have the diabetes to watch out for more than anything. You know, there's some diabetic retinopathy there. I got to keep that as a confounding component to the OCTs as well. Right. But you know, low risk patient for me at this point. Yeah. Lower.
No, that's very helpful, especially diabetes. I'm not an OD. I wouldn't think about that. I thought all the problems going home. That's right. Okay. Yeah. But oh, absolutely, absolutely. So that's especially well. Yeah, let's talk about that for a second. That's especially true. Let me just back up, get rid of this. That's especially true for the ganglion cell thickness map. Now that thickness map looks good. You know that funny thing you see in the vessel, right? That looks good. But you will have eyes that you can have diabetic eyes where everything else looks like this eye here, but this looks crappy here. And that's why clinically, as part of the longer lecture, always look at ones. Always look at ones. Okay. All right, so, whoops. All right, that's the rule for no. What's the rule for yes? All right, so don't forget we have 3 answers. All 3 questions have 3 answers. Yes, no, I don't know, or I'm uncertain. Okay. All right, so the rule for yes is fairly strict. You want an arcuate that is a red and yellow region that extends beyond the vertical midline. So you'll see in all these examples here, the arcuate extends beyond the vertical midline. You know, here we're reaching a little bit. You know, that could have been uncertain. You know, I don't care if you said uncertain because you're going to get another chance. Okay. Because uncertain is your friend. So if you say to me, wait a minute, you're saying that's yes, but I can say uncertain, you'll see it's going to come out the same way. So if you have any doubt, say uncertain and go to the next question. You're going to get all the information you mentioned. Okay. So this rule here excludes nearly all arcuate-like artifacts. So what is an arcuate-like artifact? All right, so here are 8 database of a commercial machine. These have been through all the procedures, right? 4% of them, 8 of them, had these artifacts. Okay? You'll notice that one thing they have in common is they don't cross the midline. And there's a very good reason for it. And I can explain that reason to you later if you ask. I just don't want to be diverted at the moment. Okay? So there's the midline. They don't cross the midline. So if it doesn't cross the midline, it doesn't mean it's not glaucoma. Right? But it does mean that it cross the midline is a high probability you have an optic neuropathy. Yeah.
As a teaching point, as we're trying to talk to our students about this, you're talking about the midline this way through the fovea. And I think it is so difficult for students, like we talk about everything in glaucoma representing the horizontal midline, the field head, and that sort of thing. I think this really deserves a little extra
you're talking about midlines.
Great, yeah, great point. But examples like this, for example, where you say, when by the midline, I mean the vertical midline. I mean this here, not the horizontal midline.
And talking about this as sort of this midline going through the center of the fovea. It is on the visual field, but we're talking about on the OCT, that midline going.
Right.
I just think it's a point where there can be some.
No, I understand. It sounds good because then you're using it. The general principle is you're using a term they're used to, but it means something else. Right? And you can even put that in the teaching slide. You have freedom to mess with my slides if you want. You can even put, you think about a midline like this. Well, that's a horizontal midline, right? Okay. But actually, if you see my teaching slide, that's a little more complicated where I explain why this is true. You'll also see why it's the case. All right, so healthy eyes, it can happen, but it's very rare. There are some congenital local defects, like one of your patients that we looked at, that would be an exception, but by and large. All right, so healthy controls don't. Glaucoma often does. You'll notice in this case here, it does. And in this case here, you can almost say, no, it doesn't yet. Okay. So nearly all advanced glaucoma and moderate glaucoma eyes are going to fit this rule in about 2/3 of your early glaucoma. This is based on our data. So arcuates that cross the midline are likely due to optic neuropathy. We don't stop there, however. All right, so in these examples here, there's your vertical midline, right? Now, we want to be real careful when we're devising this technique. We wanted to have one that was high in specificity. So before we're going to call this glaucoma, we want a yes to question 2 as well. What's question 2? Well, question 1, remember the method has 3 questions. Question 1 concerns the retinal neurofibrillary probability map. What do you think question 2 is going to concern? Ganglion cell, right? Map. Okay, so we're going to now look at the ganglion cell map. So if there's a yes to this, then you move on to question 2. You look at the ganglion cell map, and you're going to ask, is there a topographical, so defined, corresponding abnormal region on the ganglion cell probability map? All right. The rule here is, if the abnormal region on the retinal nerve fibrillary and ganglion cell the ganglion cell probability maps are part of the same arcuate, the eye has glaucoma. So you can actually superimpose this. Whoops. You can actually superimpose this. Just a different slipper. Sorry about this. You can actually superimpose this, or that, yeah, or that circle's the same on both maps. So you can just do it like that. All right, do you see the logic here? The logic here is you've got 2 separate maps, right? The variability there is independent in some ways, right? Measure something, you know what glaucoma looks like if it's there on both those maps, or you've nailed. Okay. Now so let's just take these examples. So all the ones on the left, I would say yes. This one here is a no. Whoop, let me just do this. Right. This one down here is a no. And these here, if I was being careful, uncertain is my friend. I'm just going to say uncertain. As you'll see, I'm going to get another chance. All right. So yes. All right. Now, I've been saying you have glaucoma. I'm assuming you've done a fundus exam. Because technically, what I should be saying is you've got optic neuropathy consistent with glaucoma. So really what this technique, right, is no optic neuropathy, and then yes to optic neuropathy consistent with glaucoma. All right. And here's the best part. All of these eyes, by definition, also have central retinal damage. So one of the things that isn't appreciated is an overwhelming majority, anyway, in the population, 80–90% of the eyes with glaucoma already have damage in the central APBs. It's just not true that glaucoma is a disease of the peripheral retina. Yes.
The fourth, the bottom example, is that RFLB from the vertical?
Yeah, well, that was one of the ones I told you before, could technically be. The answer is, if you look at the very top, I can't reach that high. Let me do this.
So it's the
If you look at the very high, yeah, I said before, this could be uncertain, but you'll see in a moment, if you said uncertain, you're gonna pick it up on the question. You won't miss this. A good question. Okay, all right, so does this cross the midline? Yes. Right? Is the topographical corresponding region of the ganglion cell map? Yes. You're done. If you wanted to stop right here, you'll be at a very high level of accuracy. You're not going to stop right here in general, but for teaching purposes, you're done. This is optic neuropathy consistent with glaucoma. All right, now as I said, it's always good to look at the B scan at least. So you look at the B scan, and there it is. You can actually see it now. You don't need a pie chart. Okay, there's another one. You know, crosses the midline. Again, if you want to be conservative and say uncertain, that would be fine too, right? There it is. You can see that that's in the same place. That's a yes. Optic neuropathy, consistent with glaucoma. But you're going to look at the rest of the report anyway, I hope. And if you do, you can actually see where that damage is.
So what if question number 2 is no?
We're going to get to that.
Because the bottom is a no.
Yes, or the bottom's a no.
Well, it doesn't. That's not on ganglion cell.
All right, so you look. So this is what's crossing the midline, right? So you're looking for something that's in the same place, and it's right there.
But what about the inferior part of it?
Oh well, we already gave this person glaucoma. You want to give them twice?
Might as well.
Oh, it's free at that point, right? No, but that's a good question, and you'll see with question 3, you would say uncertain, you would say no, right? And then you would start looking at this over here, being slightly thin, and there's nothing there, but yeah.
But no, I would also say that the model predicts that superior RFL, which is inferior to the visual field there, is less likely to impinge the macula.
Oh yeah, well yeah, that's a subtle but very important point because of the anatomy. Yeah, actually, that's actually a point really worth making, independent of these things. Because of the anatomy, if you've got damage here, which means your upper visual field, very, very high probability it includes the macula. Right? If you've got an eye where only the damage is here, right, and then shows up here on visual fields, those can be without damage to the macula. Most of them have damage to the macula too, but that's where it occurs, absolutely. And that's a nice validity check too, isn't it, Gus? Because you're saying, all right, but that did break the rule, but wait a minute, I know that that's a place where we go. Excellent. All right, so just with those 2 questions, I would argue as long as you have a decent scan, so an entirely different story is how do you get a scan? So let's just hold that. Well, maybe next year. I'm working on a lecture about that because we're going to use database how to do that. But if you're dealing with readable scans, 70 plus at the time, it would be one of those. So in our study, 97% of the advanced to moderate glaucoma went this route, and 2/3 of the early glaucoma went this route, and 92% of the healthy eyes. So depending upon how many healthy eyes you're looking at and how many advanced, it's going to be anywhere from 70% to 90%. Okay. Let's see what Mike did with this. So I'm assuming that this was a new patient, and I guess somebody previously had said you better see an expert because I think you may have glaucoma. All right, so Mike got this, and I think his job was done almost instantly. You know, so
I have a lot of easy glaucoma.
yes, yes, that's right. That's what we're not doing. We're not showing how.
Right.
Yes, yes. And actually, he'd look over there. He confirmed. He went one step even further, which is nice. He's a really good student, I've learned. And looked here, right? And even went one step further and looked here. You put all these all together, you not only are convinced that this is ophthalmology, this is glaucoma, but you know what it looks like, you know what the damage is, you know where you're looking for progression. Try doing that with a pie chart. Make this machine. Okay. Here's the other eye. Yes, yes. And again, you can see it's in the same place, which is a very common place, by the way. And so Mike actually commented that with the probability maps alone, you're able to identify glaucoma. That's what the pie chart looks like. Okay, so these are Mike's notes. He points out that it saves him time, it makes him more confident, and he's able to identify early macular damage, which I think is really one of the most important aspects of this. And you can then go from there and select which visual, if you do visual fields, which visual. So I'm assuming, Mike, in this case, you're going to follow this patient with a 10-2.
I'm going to start with a 24.
Okay.
And then follow up with a 10, and I may still alternate every.
Well, that was my question. Yeah, that was my question. How often would you do a 24?
So, yeah.
I think people would be interested in that.
Put the microphone on.
You can tell me, I can tell that.
So I would alternate most of these patients
really?
every 6 to 9 months, 24 and a 10.
Yeah.
I don't give up on the 24s.
You probably don't use a lot of progression analysis. The people who tend to want to stick with one of the people who want to look at 6 tests.
Yeah, no, I do that too, though. I do. So why would you say?
Well, you can't get through as many conditions.
Oh, correct. No, so yes, that takes time to build up the database and have 2 baseline fields, and you saw how well my patients do visual fields. So I'm talking about the ideal patient, what my best case scenario is. And of course, it depends on the severity of the 24-2 and things like that. But a lot of these asymmetric pole patients from superior to inferior pole, I'm always worried a little bit about the other heavy field across the horizontal line. Right. And both the 10-2 and the 24 is helping with that.
Good. Very helpful. Oh, okay. So,
Would you employ your 24-2C? By the 10-2.
So,
let me. That's a great question. The question was, are you going to go to the 24-2C, or do you really need the 10-2 with all the extra points?
In my mind, I'm still not 100% sold on the 24-2C.
The reason I asked it is I don't think a lot of us are sold on it.
Right. I find if I'm good test taker and good education and don't hit too many high false positives, I can get by with the 24-2. I'm sorry, 24-2C. So it's a toss up a little bit, but I'm not using it that much anymore.
Yeah, the points are not entirely optimal either. John and I were part of an advisory group on where to put the points. And we had published data and this published data from Australia, and we agreed where we put the points, and then they got changed because somebody else had a different opinion. So they're not bad, but they're not even optimal. And there's no optimal place for everybody. So if you think you have macular damage, I know as a patient, I'd say, skip the 24-2 to get your time. I want to send this to John.
I mean, my impression is that was never designed to be for patients with glaucoma, right? To really follow patients who have damage, that we know have damage, that you're wanting to use the 10-2.
But it was meant for a patient who's like home in terms of screening.
Yes. Oh, yeah. Looking for patients Once you, if you're following like this, then
Yeah.
it's,
Fair enough.
you're better off with the using both.
Well,
Justified.
the reason I bring it up is because I think there's some misperception, out there that the 24-2C is capturing the data similarly to a 10-2, and that's not. That's absolutely.
Right. But you can argue it's better than 4-2.
Yeah, well, you're right.
That's probably worth it, because we all have enough data at this point, there's a lot of examples.
Yeah.
In fact, we had a novel post on record at Harvard, using it, didn't we? Okay, so last time I spoke about, here for 8 hours.
Who's counting?
I can bring that up too often.
Reality is
I
built today.
I think they still have the rocket am I right? All right, he met, what was now? Never got it.
It's from the side.
Well, talking about the interaction age, my age. All right, anyway, when I spoke here 6 years ago, the question was, well, what about Zeiss? Most of us have Zeiss. Well, that's changing rapidly. Zeiss doesn't have a hood report at the moment. They may at some point. But there are places where you can get nearly the equivalent information with the major exception of a really nice looking service. Okay, but, so this is Mike's patient. I keep thinking that gets me back. It doesn't. This is Mike's patient. Before I tell you about how you can use that, as part of the same lecture series we gave, Manos gave a lecture on how to use the Zeiss and the Columbia report. We reproduced the slides and a little bit of his talk in the lecture, in our lecture, in our recording, right? Okay. So essentially, this is what we're using, because between this you've got the 2 thickness maps and you've got the 2 probability maps. So the way it would look like it, and this is where you can find it. That's where you can find it. Okay.
And Don, I would just make clear that we're asking the same questions here on this panel map report.
Well, we modified them a little bit.
Did we?
Yeah. So question A is really a combination of 1 and 2. We had 2.
Yeah.
Okay. So question A is really, in fact, this is your answer. So the question A is, do you see a continuous defect when you look at the combined probability map? So it's like a hybrid of 1 and 2, right? And you said yes, and you pointed to that, right? In both cases. And then question B, if you need it, involves looking at the ganglion cell thickness map and to see if it's consistent with the damage you see. Okay? And then question C would be looking at everything. So, all right, this is a formal Q&A period at the moment. Questions? Yeah.
Yes, and also brings possibility of this that we're dealing with glaucoma per se. But I think you got in that scenario also that question A being no, and then question B being yes, also that possibility. But if the GCL is not a specific test, but it's more a sensitive test, then how much do we know about this to say that this is really glaucoma?
Yeah,
Rather
so
than
the-
other
yeah,
things
so-
that may give that GCL defect.
Yeah. So-
And not be glaucoma.
I totally understand. So the question is, these 2 questions by themselves don't do it, because you could have an eye that clearly has glaucoma, but it doesn't have macular problem. That's the point of question 3, and what I'm going to talk about next. You're not done at the end of question 2. Yeah.
I was just gonna ask why the vertical midline. I know you didn't want to answer that earlier.
Let me give you a quick answer. You may have an aha. If you don't, I'll show you a slide. If you take and outline the thick glaucoma object, excuse me, the thick healthy object, right? Healthy object. You put a black border around it, which we're going to have on it before. if it's a healthy eye, if it's a healthy eye, but it's abnormal because of where the vessels are placed, you always detect it forward in that platform. Once it falls outside, then you're very, very high suspicion that you know you're not affected. Okay. By the way, I borrowed yours. I didn't give you credit for it, but I borrowed that. Right then. Just being fair. All right. There's no other questions. So you understand question 1 and 2. All right. So, as I said, that route will get you, those 2 routes will get you, but what about the other eyes, you ask? Right. All right, so the other eyes include uncertain to question 1, which is a big, interesting category, or no or uncertain to question 2 after you say yes to question 1. All right, so and the answer there is now we're going to look at other aspects of the report, and we're going to do it in a very systematic way. And this systematic way actually is a way I used to teach it before. We got also about making it easy for people to learn. All right, and based on question 3, now we're going to wind up with more yeses and more nos, but there'll be a couple left over, and those will be your OCT assessments. So one of the names of the game here, correct me if I'm wrong clinically, is to get that suspect group as small as possible. So you're not spending a lot of money following people.
Unnecessary referrals.
Right. All right, so question number 3. Coming up on another choice point, so everybody with me? Okay. Question number 3. Is there confirmatory topographic, meaning regional evidence of a retinal nerve fibrillary defect on some other aspect of the report? So now we're going to be going through a checklist. You know, so if we say uncertain to, for example, to question 1, we're now going to go through a checklist. We're going to look at the ganglion cell thickness and probability map. We're going to look at the retinal nerve fibrillary thickness. We're going to look at the B scan. We're going to look at this thickness plot. Right? And what we're doing is we're looking for corresponding topographical evidence the same way we were looking for the ganglion cell or retinal nerve fibrillary. All right. So by topographic agreement, we're going to mean 2 things. The first is the same physical location. Right, so this is another a choice point. I can tell you from experience that not everybody will get this the first time, but I can tell you also from experience it doesn't take a lot of practice, and the plumbing method helps with that practice before you can do it immediately. Okay? So you're going to be looking for the same location. All right, so this is actually a yes eye, but I'm just going to use it as an illustration of what I mean by the same location. So that's the circumpapillary thickness here, and it's an instant plot. That means the temporal quadrants in the center. So that location, remember the probability map is flipped along the horizontal. That location there is the same physical location. The ends of those yellow arrows are the same physical location, which is the same location as that notch in the thickness plot. Right? You can blow it up, which is the same location of the thinning of the retinal nerve fibrillary, which is the same location of that. So once you get used to this, you're looking for corresponding places. So that's not going to work with the artifact. It will work with that. All right. And likewise, those 2 are the same location, as is that. As is that. The other thing you're looking for is you want to be thinking about oculus. Where's the ocular damage? Because that's going to help you tie together your photo with the visual fields with the OCT. All right. So let's go back to our little map here where we had sample ocular defects. It's going to look like that for the left eye, of course. So in this case, I'm going to argue that you're going to ocular that looks something like that. And this eye started out life up here, and over time it got thinner, and that produced this ocular. So that red semicircle there is the same as this location here. So this is the arcuate you're looking for. So it means that the retinal nerve fibrillation should be within this. The ganglion cell plot should be consistent with it. Your visual field should be consistent. That damage there between the red arrow. And again, compare that, to the pie chart. All right, so maybe I just stop for a second. Let's do a question about it. I'm gonna give you a couple of these there. You see what we're doing.
I think I don't understand the difference in what you're asking right here, question number 3. Maybe it's because it's such an obvious defect. I don't know that I mean, we already saw this.
Yeah, no, it's because it's
Okay.
are you, just so that you can see the topographical relationship,
Yes.
I took a yes, we need to do this.
Got it.
Now we're gonna do the ones where you need to do this, and use the principle.
Okay.
Excellent. Excellent. All right, so, as you pointed out, you've got yes, right, and you've got yes, and then no and uncertain. We're gonna lump those together. What do you do about those? Well, here's an example of one of those, right? Is there confirmatory evidence? Well, let's blow this one up, all right? So I'm gonna say yes to that. Right, there's the midline. I'm not gonna say yes to that. I mean, I've got enough experience that I'm suspicious about that little red dot, but I'm not gonna say yes to that.
But most of us would not.
Would what?
Most of us would see number 2 and say that's close enough to number 1.
And that'd be okay with me. There's nothing wrong with that.
Right.
Yeah, I'd say you want to be careful for a number of reasons, but anyway, fair enough. But now I'm all set. I'm gonna go through my list. The probability map, I go to the thickness map, and there is the thickness. The thickness map is very valuable in this case. Now you feel comfortable. Now, again, if you want to talk about the rules, that might have been enough, but it doesn't take 4 years.
So,
Yeah.
so for number 3, is that your first place you go to as compared to the nightstand or anywhere else?
This is the way we're teaching it, Murray. The truth is, probably what I'm doing, we have eye movements on me, actually, because of the student in engineering who's trying to use the eye movements as a research tool. Anyway, we have eye movements on me. Truth is, I'm quickly going from here to here to here. So I go over here pretty early in the game because I'm very familiar with the B stands, but something like this, I'd be doing this very quickly, those 3, and then eventually I might look over here and here. But again, these are rules. We're trying to get rules.
The B scan pretty much confirms that though also.
Absolutely.
Yeah. So does the instance.
Yes, absolutely.
I still think this is a very obvious case.
Okay, let's keep going. All right. Yeah, these all agree. So you're talking about this here. Yeah, can't rule that out. Yeah, so let's suppose, I see what you're doing, it's great. So let me rephrase this, see if this is okay. Let's make believe the lower part of the retina, the upper part of the field was normal. Okay, and so this one right here, this might be what you were looking for before. This one right here, according to this technique, would have been a no. All right. The way we actually do it in the lab is in the clinic is we would then take a look at that quickly, and you would see, maybe you see this, and you're not sure about that. I would then look at the other eye, which I'll show you at the moment, to see if the other eye was identical. I just want to make sure we're doing this, the right thing. By upper part, you mean this down here? Yeah, yeah. No, that's what I'm saying. In this particular case, this would be a no. Now, and what I'm arguing is, like this eye, you will very, very rarely let somebody sneak through your eye. And find examples. I mean, we work at hundreds. But what we really want people to do is get comfortable with this method and then eventually look at the whole report. So if I were looking at this, I would say definitely has glaucoma, and there may be something also up here, right? And one way I would document that, if that was of interest to me, I'm a college patient anyway, is I'm going to watch that in the future. One way I would document that is look at the other eye. If that is real, the other eye probably is thicker at that place than this one. Now, I totally understand. What you're saying is it's possible that even when that the Columbia method will miss some very early glaucoma. If you just stop there. And the answer is yes, that's possible. And no question, possible. I can tell you the conditions under which it happen. It's very rare. And the whole point here is to teach people to ask exactly the question you want. So after they, let's put it this way, how long does it take you to teach visual fields? The rest of my case. How many things they have to worry about, right? And your general point is right. There is no test that has 100% sensitivity, 100% specificity. Let's keep track of also what the competition is. Pretty good. And what we argue in this paper is when you compare it to other techniques, even just sticking to these rules, you have better sensitivity and specificity than pie charts and lots of other things. But again, you don't stop here. Okay. All right. All right, so much more difficult now. Now we're going to, so this is the last. I should have put it in, because of your question, I should have put in some more of my uncertainty in the other. But let's take a look at this here, for example. So there are two kinds of problems with the uncertain that are very common. One is this kind of problem here. That eye on the right is early glaucoma. The eye on the left is health control. Right? This is a relatively easy one to deal with. I'll give you the second type is harder. All right, so let's look at the early glaucoma. So that doesn't quite cross the midline. It looks like that other eye, by the way, almost identical to the eye I showed you earlier, but it's not. All right, now you open this up, right? And you can see that didn't cross the midline, but it sure is affecting the macula. You're done, right? And this is very similar to the earlier example. The yellow arrows show the same location, same physical location. This is, I think you all know what's going on now. All those points agree. You can see now, Murray, if you looked at the B scan, you wouldn't be done with the B scan by itself. You might be suspicious. At least I wouldn't be done with the B scan by itself. I look at the ganglion cell and now.
I think that B scan is pretty obvious.
At the instant.
Well, I'm on the instant, yeah, but I think the B scan.
Well, I can show you lots of normal eyes that look close to that. But okay, we'll keep going. We'll find one that's even less obvious. But I'd love to see your send me your examples. You know, if you have examples that you think of blatantly problems with technique, I'd love to see. I've certainly seen probably 1,000 at this point.
So Don,
Yeah.
just comment. I know you did just about the question of, does macular damage occur at the same time as more of the RNFL or more peripheral, or, I mean, because it appears from this method that both things are ongoing.
Like Gus and I have been saying for what, 8 years now, 10 years, 80% of your eyes or more have macular damage from right in the beginning. And they
So is it a question of just the fields, or that
it's a question of what we call in the paper we wrote years ago, the common clinical paradigm. If the common clinical paradigm, when we started doing this work, we only install curves, right? Patient gets on this photo, on this exam, gets a 24-2, right, and gets an OCT service. And then usually you look at the eye test. But that's going to miss big time. And in fact, if you just give me a moment, I'll make it. I'm going to come at, how much time do I have, by the way?
You got 40 minutes.
Oh, shit. I'm screwed.
It's okay, I mean, we can have a longer lunch. There is no, there's no credit involved in this, so.
Okay, no, I have.
But everybody's
I have
killing
enough
me
to-
on the time.
I have enough- I have
Ken
enough-
did the same thing this morning. I gave you look at all this time, and he ran over.
Well, that's because they don't need to. Everybody's asking, this is,
So I know you tease it. It's like.
okay. All right, what about this eye? Right, look very much like the other eye. Right, we start here. Right, we go down, I don't see anything there. I don't see anything there. Look at that section there. What's going on? I've got all this pudgy material, but yet you're saying it's abnormal. The reason for it is it expects, this is where the peak should be in the average healthy control. This is where it is in this eye, very typical high myopia, right? That's going to create an artifact here because the program expects to see thickness over here someplace, instead it's getting thickness. Once you look at this, and then you go back over here and you say, what's that red line? Well, that red line is where the peaks usually are. Oh, well, this is over to the left of that. No wonder this.
John, does any other?
That red line, by the way, was one of Murray's favorite parts of this report.
That's the question I was going to ask you. No, because it's like so obvious. My question is, besides Topcon, does any other device include?
I don't know. In our report.
Well, but if you don't have the hood report, nobody else.
And that's the so-called red disease. That's what the clinicians were complaining about at the beginning. Was it 5% or more of the patients were abnormal? Well, that's one. And then if you talk about high myo,
I mean, if there's one thing, well, I should say one thing. If there's another thing to take away, is just the importance of teaching blood vessel position, and it's and that people, that's one of the things that people often don't even evaluate or realize how important blood vessel, and you taught me that, and we put the red lines on there.
well, as I said, what we want to add to this report is the black contour. And when you see the red artifact, or you see the red thing inside the black contour, that should be a signal that you want to look at this. All right. So you can see that just is making the point we're just talking about. So that's there because the thick region in this eye is just not in the average location. Black is the average location, red is the actual location. All right. Mike. So here's a patient of Mike's high IOP, obviously, no family history. You look at this. What do you see? You concerned about this?
Yes.
Right?
Yes.
Now, you could say yes if you want to that, or you can say uncertain because it's not really, I don't see anything here, but let's say uncertain. I think that's what you said, or you said yes or uncertain. Okay, that's why uncertain is there. Yes or uncertain, I think equals uncertain. Okay. All right. Now we go through the checklist, right? No, 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 not glaucoma. Again, you can take a look and you can see that you've got, this displaced here. This whole region is low. There's something else going on here, which I'm gonna save and tell you about later. It has to do with unpublished work. I think I'll have time to mention. Okay. Look at the rest of the report. Mike says it's a no. Look at the other eye. So whenever we're uncertain, I think you do this clinically, whenever I'm uncertain, I routinely look at the other eye. But whenever I'm uncertain, I really look at the other eye, because if the other eye is very similar, that just increases the probability of something. I'm sure you can get glaucoma and down in both eyes. So you look at the other eye is the same. And there, the comparison of the two eyes. Oops. That's the other eye. And that's the visual field.
So Dr. Lewis, I would argue with that. I would say that the one I did have retinal nerve fibrillary defect.
One of these eyes did?
Yeah.
Oh, yeah, okay, let's go back and look.
These here, so the changes that we said yes are uncertain on the RNFL, but we're not matched to the thing. No, go back to the right eye.
The other eye.
This one looks.
Oh, this one too.
Oh. The previous one has a superior nerve fibrillary defect.
So you're looking at this here and this here.
No.
What are you looking at?
No.
Let's go to the right eye. The right eye.
Oh,
Right eye.
It's the case of where maybe there's RNFL and no ganglion cell.
wait a minute, the other eye. That's the right eye.
No, we skip that.
No.
Well, that's the right eye. We tell you why.
Somehow ended up in another case.
Oh, did I? All right, just a minute. I'll account for this. Oh, I see, okay.
Keep going. Keep going.
That's the right eye.
That's not what we saw.
No.
Before.
Ah, sorry, you're right.
Sorry, left eye.
Left eye. I got it backwards.
That left eye has a superior defect.
I don't, what makes you say so?
The nerve fiber bundles are not the same inferior and superior.
Oh, that's very common.
No. I disagree with that.
All right, so let's be very specific. So
Even if you look at the.
you're saying that you're saying this is real?
That could be, those are probabilities, but if you look at the thickness profile itself, right? From nasal going to superior on the right side of the thickness plot, it's a fairly steep line. And I know you'll disagree with me.
I told this.
You know that, but that's okay.
Yeah, it's okay with me too, but.
I'd love to see progression data on this.
So first of all, there's the visual field.
I understand.
All right, let me tell you one more thing.
We've all seen visual fields that are worse than OCTs in early disease and vice versa.
All right, I want to tell you one more thing that we discovered recently. Mike, am I back in the right one yet? Yeah. I'll give you one more reason. Because I'm willing to put, I'm usually more cautious, but I'm willing to put money on it. We have other eyes like this. Right, other healthy eyes like this. What they have in common is that the foveal distance is shorter than that. And if you look at this here, see this here? And that's centered on the fovea. See how this comes right here? I'll show you a slide later. Average is over here someplace. So not only is this pattern, I now know, this is very recent, like 5 months ago. I know that this pattern can be reproduced in healthy controls that have on the shortest side of the fovea distance.
And so, but this is not corrected for magnification.
No. Yeah. No, oh well, no, I shouldn't say that. I mean, Well, the point is, I'm not positive. The point is, if you look at the regression equations, if you look at the correlations, it's correlated with refractive error and axial length. It's not. The correlation is very well. So you can have a normal refractive error and still, and normal axial length, you still have a fovea that anatomically just happens to be variable at lower end of normal.
I don't disagree, but the thickness map itself, the lower left-hand corner, to me.
All right, well, let's talk later. I'm a betting man, so if you want to bet, we can bet.
I'd love to bet.
Good, we can definitely do that, because remember that pattern. You're gonna see that pattern in healthy eyes. Okay, now where was I? I think this is just the same point. Okay, here we go. All right. Now, you've been wanting really difficult ones, all right? Those two eyes on the left, those are the probability maps to healthy controls. The ones on the right are early glaucoma. And the early glaucoma in this case has confirmation visual. And so this is what we discovered what I was just telling you about. There'll be a slide about that in a moment. So these are legitimately difficult. So I'm going to shortcut the procedure and show you how you can use things to differentiate. If this is the probability map, so what these have common, what these always have in common is that they're artifacts and or defects that have to do with the temporal part. So by definition, that's not me. That commented the temporal quadrant. Okay, so if you look at the ganglia cell plot, right? If this has an abnormal temporal quadrant and this is clean, again, based on just this information, that's not glaucoma. There should be something wrong with the ganglion cells if the temporal quadrant's really abnormal. All right. Then you want to look at the whole report. If, on the other hand, the ganglion cell thickness map has pieces out of it that are consistent with that arcuate, then it's glaucoma. You're going to look at other things in the B-scan and so on, right? If you've got a circle like this, we know we can get that with artifacts, right? If the ganglion cell thickness map is even lost, then you're uncertain. And here's one example of no sequence. When I have those on, I can't tell what I can make a guess as to how, if it's really red versus not, but like this eye here, I couldn't tell. That's a pretty small group. All right, here we go. Oh, I should have waited. All right, let's go back. I'm so used to it. All right, there's the line through the fovea. There's the line through the center of the disc. Notice that red arrow shows you the distance. There's the distance of the other one that's a healthy control and artifact. There's the eye with really glaucoma. There's the eye really glaucoma. Now, I'm not saying that the foveal to disc, or distance creates glaucoma. What I'm saying is a relatively short foveal to disc distance creates a temporal type of artifact. Yeah. So, what I'm saying is, if you see a temporal artifact like this here, you want to see what the fovea distance is, right? And you can actually tell it because the 10-2 points here are centered. So you can see how these points sit right next to it. And over here, which is much closer to the average, they're further away. A totally normal eye that just happens to be born with a shorter foveal distance, let's say the lower 5%, right? That eye will show up with temporal quadrant. So most people, you tell me if this is true, most people don't trust the temporal quadrant. Why? Variability, yeah. Most people would say, I think variability, and if you look at it, it's the thinnest part, right? But what we now know is that as long as you know what's causing the abnormalities, it's as reliable as any of the other areas, but in this case, it's going to show you defect. But it's got these artifacts, and the amount of the variance that the fovea to this distance accounts for is greater than age or this diameter, which is what's in the equations at the moment. So one of the things we're going to be pushing for this, don't go out and publish this, please. One of the things we're going to be pushing for is that the normative database should be correcting the fovea to this distance as well. And it's going to help with false positives, other kinds of false positives. But we were looking at, you know, this was in front of me for years, and I didn't notice it. Okay.
So I think that was, let's just say, going back to the numbers, let's just say that you, measure that distance. That's about it.
Well, what I was saying as a clinician, right, I'm now putting all these pieces together, and I'm saying, if I see this, one of the things I'm gonna be looking for, I'm still gonna look at the ganglia cell thickness map, I'm still gonna look at all the other stuff, but I'm gonna take into consideration when I'm doing my own Bayesian decision making, that this is gonna, that it's so that this distance is short, it's gonna push it in the right.
So let's just say that that's.
You measure what? Yeah, exactly. Great question.
You say that in a case like that.
No. In a case like that, I'd be uncertain, I want a visual field.
Shouldn't there be a small cupping? Or not large?
It's not only it's not necessarily the cup size, it's actually the distance, and it's seen.
But I'm saying clinically, for the doctor, they're not gonna see it, but chances are they're not gonna see it. See, my question is, why would somebody do an OCT in this case?
Why would
Because if the nerve, I mean, the tip off, the reason we do an OCT is because we see a suspicious nerve or a high pressure. I mean, it's not a screening test. So for these situations, why would we run into that? You understand what I'm saying?
Yeah, I do understand. The answer is I don't know. These are part of the study.
Right.
So I'd have to go back to the charts to see why they had it. Patient, I would hope the state of the art is such that if there's any suspicion of a problem at all, you get an OCT. I think the OCT is a screening test. I know it's the best screening test out there.
Well, we could have that conversation because you can't do a screening test, just medical legally or reimbursement wise. I mean, there are reasons why it's not being done. But all I'm saying is that in this situation, we usually wouldn't even go that far because.
Well, no, you don't know what.
Blood pressure might be 26.
Well, that's what I'm saying. But
that's the place,
yeah, but chances are, again, statistically, how many, what are we talking about, 10%?
Right. Probably less.
Just a fovea distance is very interesting. Do you know if there's any impact on reproducibility of the name?
No, we have that measure. We can do that. The way we're getting it here, I think the measure here is pretty good for the following reason. What's happening is the software is putting the visual field at the center of the fovea, and so is the ganglion cell at the center of the fovea. Right? So if the center of the fovea is all off from the disc, you're also going to see artifacts over it. There are other ways we can confirm. The simple answer is no, we don't.
Or it doesn't affect that. So we almost don't care if it shows up fine, as long as it doesn't change.
Well,
What do you do with your
yeah,
it's part about it. Important to understand why it's happening. But it's not going to change.
it's not going to change.
Yeah, sure. So, but just.
Well, that's your confirmatory.
Right. There's those measurement reproducibility
It's as good as any of the other visions. Okay. But I hear you going at it. Now that's a good one. Misunderstood.
So are you having TopCon or whatever others would measure that now?
Yeah, it's already in, everyone has it. It was all in notice and this was something. All of this. Again, we can vote.
Dr. If could you explain why that short distance creates this sort of?
Yeah, and that's a good, in fact, when I was first testing this on Justin, who I often test, do on his first time, he said, oh, that's interesting. I said, wait a minute, that's the reverse direction, isn't it? It should be the opposite. If it's closer, why isn't it bigger? And so I showed him the B stance. And the way to understand this is, here's the fovea. Right? Here's your thick, here's your optic nerve. Here's the fovea. The ganglion cells are pushed away from all of this, and so is the retinal nerve fiber. If you bring that circle around it closer to the fovea, you then wind up getting a thinner retinal nerve fiber, and you get peaks that move out like the one that we were debating, right? So I don't have it with me, but I have a teaching slide where I lined each of those up with the center of the fovea, and you can see where the thin part of the retinal nerve fiber is thinner, closer to the disc, only because of the shape of the fovea. You have to see it, maybe. You understand?
Isn't that also typical of, say, short axial lens hyperopia, where the vessels are pushed a little further?
Yes.
When you get thickening
Yes.
up there,
Yes.
it's kind of a similar artifact.
Yeah. And I'm sure it's correlated. Right. All right, Murray, what do you think? Let me summarize this first. I'm not claiming this is the end of the story. I'm claiming it's a technique to save time, to avoid some common mistakes, to help understand the nature and damage compared to other approaches, and at the same time get you involved, asking the questions you've been asking, right? So you can learn how to look at everything together. That's what we do. Should I go on to some visual fields or what's your hope?
But that's, these whole things, that's where AI is gonna come in whenever that it can just address all of these things right off the bat.
Yeah, well, we've done a lot of AI work. And yeah, the good news is our AI program gets confused with these two. But that's good. Yeah. Well, AI is a whole different. Yeah.
The schematics that you showed us from
It's on.
It's like, and then when you showed that, there was a nice big blue one, I think, that scoops around to the nasal side of the nerve. Brad Fortune, Andrew Turpin, Allison, they've shown the same sort of nasal step defects that loop right round. One of your first ones that you dismissed seemed to show the defect on that nasal side, which is next to the optic nerve. Just your insight as to
Oh, the nasal side,
the
yeah.
temporal
Don't
edges
confuse,
of-
yeah, let's make sure we're not confusing. So, the nasal field, you're talking about the nasal side of the OCT. Which is what those do.
Yeah, I am, and we ignore it in visual fields. But it's now been nicely documented in a few different studies how those arcuates can be right round and be on the other side, completely ignore it. And it's rare.
Yeah, I think what you're talking about is Brad's monkey thing. First of all, it's remember monkey thing.
Yeah, but also
It is rare, but he's talking about only one plot, small plots, but
yeah. But also, I mean, you go back to ancient Goldman data where 3% of presenting fields were temporal wedges. So it's whether in your opinion, do you see any of those?
Yeah, let's stick to that, because that's the easier thing. This is ignoring temporal wedges. This is ignoring the temporal plots. I don't want, that's not ignoring the superior and inferior part of this is ignoring the temple part because of all the stuff. And I'm sure Mike Wall has the most data on this at the moment. Years, I'm sure that exists out there. It's not on presentation.
No,
it's not. But
you looked at this as on OCTs probably as much as anybody. That's why I was asking for your insight, whether you see any of those.
Not a lot. I'll tell you, we see it a lot in misdiagnosed segmental hyperplasia and in ION. Both of those wrap around. But whenever I do see something like that, I first want to rule out those. But I don't know. I haven't yet worked with a specialist because we've seen lots of patients where I haven't seen this diagnosed. I don't want to. By the way, you can. I have a slide. I'm going to get to the very end if you're really desperate. You can often differentiate that. ION and SSOH typically tends to be superiorness. It tends to be complete, and it leaves the other half of the field that goes to more glaucomas. And it never does that. So that's visual fields. Okay. All right. Any other questions on this? Let's switch gears a little bit. All right. So I went through the advantage of this. We did the questions. All right. So right from the beginning, I was motivated by my colleagues who were struggling to make sense of visual fields versus OCT. We've come all the way around now. It's reversed. Now you have OCTs, you struggle to make sense of fields. And so the reports right from the beginning had the locations of the 10-2 and the 24-2 located. And for the 10-2 in particular, you might notice that they're morphed. Right? That's to take into consideration the fact that the ganglion cells are pushed aside during development. So this is where the light is hitting, you might think you're testing this point here, but you're really testing that point there. And in fact, that's particularly important for the 24-2. Your 24-2 central points are here, 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 here. And this is your donut of thick retinal ganglion cell. So you've got at best 4 points in the 24-2, and even then they're on the edge of your donut that you're trying to preserve. Okay. So anyway, the top conversion has 24-2 and 10-2 points differentiated by size. The Heidelberg version has 24-2 points on the retinal nerve fiber layer and 10-2 on the ganglion cell. Not entirely sure how to let that happen. Okay. So, and what we're going to be looking at is not that. We're going to be looking at deviation maps. And some people ask me, do I look at the pattern deviation or the total deviation? The answer is yes. Look at both. In some ways, one will be a better representation, others the other one. All right, so again, you can find these maps on other machines. If you have a Zeiss, you'll want to flip the panel map upside down to relate to the field. And so here's an example. This is a patient of Jeff Liebman's. We're not going to be looking at those things. So you're going to flip it. So you can steal this if you want, or I'll send you a copy of it. But that's the panel map flipped upside down. You can flip the field instead with the average locations of the points on the top. So here's this particular patient. That's the 24-2, and that's because that's the odd. And if you circle that point there, you get this. You circle these here. I'm not impressed. Probably an optical effect. Random mistake. You do a 10-2 on this patient. You circle it. There it is. By the way, you want to warn this patient before you remove the cataracts that this was sitting underneath it. Right? When I first started lecturing on these things, Murray, some of the people got the most excited. As you know, some of my colleagues were skeptical about what we were doing. The cataract surgeon said, whoa, wait a minute. That's why this patient all of a sudden developed this field. All right. So, as was pointed out by somebody before, forget what you know about visual fields and nasal steps and partial occlusions and so on. If you've ever tried to categorize using those systems, you realize how difficult they are. And that's because there's an infinite variety of fields, because there's an infinite variety of changes. Thinning can occur in different locations. It can be heterogeneous or homogeneous. It can be thick or thin, and so on. So here's an example. That's an interesting visual field. This looks traditional. This is a little funny. You take this, and now you can superimpose this. You can do this, and you can superimpose it. And you can see that it feels subtle, but it's consistent with the OCT. Here's the 10-2. You circle it, and you get this. Well, if you went with the total deviation, you get that. They tell the same story by and large. So you're looking for patterns that are typically associated with glaucoma, looking for occupancy. The questions about it. Now, you get, I used to circle these. Now you get pretty good with a little practice. You don't have to, or you can always have. That's why you used to have a fellow or a resident or a student do it. That's why God created them. You can save your time doing things like that if you want, and they learn too, so you can justify it. All right, so an infinite variety of patterns of damage. All right, so you're looking for these occluits. So in this case here, that's the region up here. If we put this on top, that's what you get. Remember that picture. I'm going to come back to your question, Murray, about notice that the damage here is in this region between those red vertical lines. So this eye started out here like this. I think this was your point before. It has to work its way through green before it gets to red and yellow. So there's, you're not going to see everything on the probability maps. Right? But anyway, this is what's happening. You can see there's some tissue in some places. There are two deep places here with some tissue on either side of these vessels. Those deep places are giving you these two different branches, if you will. There it is blown up. So you can picture that. That could be wider, that could be thinner, it could have a different pattern. Each one would create its own visual field. All right, so now this is important. I just want to give you a couple examples. In some eyes, structural damage will be detected before visual field damage. While in other eyes, the reverse is true. That's true. You can see structure before function before structure, depending on the test you're using. Right? Okay, but in most eyes, they go together. All right, so this is the patient we already looked at Mike's. Right, this is sort of interesting. This is going to make a point, Murray, that you raised. Nasal step, right? Oh, nasal step, really glaucoma. Not true. That's the eye with the nasal step. As Mike pointed out, nasal step is not equal to glaucoma. In fact, what we've been teaching for years is if you see a nasal step, check the macula. This is the advantage you can see macular damage too. Why? Well, first of all, that's what Mike did. Right? All right, why? So watch this, Murray. If you have damage where that red arrow is, right, that's all the way at the edge of your nasal step. If you have damage right there, that's all already in the macula. The difference, the distance between those two arrows is 1.5 millimeters or something. Big surprise. The nasal step damage is going to go along with macula. That's the most vulnerable region. And they're only talking about 1 millimeter or 2 millimeters. Again, that would be where the corresponding region on the ganglion cell. Well, I keep doing that. Okay. Any questions about that point? I think that's an important thing. It's clear, the implication. Okay. All right. All right, in most eyes, damage is very clear on both visual fields. In most cases, they go together. Sometimes structural damage on the OCT will appear more obvious. So here's a pre-parametric eye that you're asking about. That's about as clean as you can get, right? And that's all normal, right? All normal. You can see why. This is a very thin defect that basically is between those points. Speaking to your point before, that if you had more points, you really compulsively doing the mapping, you probably would. Yeah. This is where it is. It actually falls between those points. There it is. Yeah. Absolutely. A 100% agree. We've been saying this for years. You know, Uli Scheifer, years ago in Germany, working with the octopus, right? He looked for defects on the photos. He would circle it with a lasso, I think they called it, on the photo, and then that would be turned into points that would then be the visual field. So he had that same notion with the photos. It's even a better reason to do it than that. Absolutely. By the way, the question was, shouldn't we have software where we combine visual fields and OCT together, where the OCT thing guide which way you put the points? All right. So again, this is sometimes structural damage will appear more obvious than functional damage. There's the visual field. Now you probably wouldn't call that field by itself, right? This is the visual, that's the 10-2. You probably wouldn't call that 10-2 by itself. You may or may not call it OCT. I would, but you may not. If you circle the points here on the ganglion cell, that's where that circle would be. Or if you do the reverse and circle those points, there you have. So this is sort of neat because I don't think you would give the visual field more than a 10% chance, let's say. Take a note, understand, the OCT probably wouldn't get more than 5%. The variance here is independent in these two. You can multiply to get an estimate of probability. One can't be, you have cases like this one, you can't be sure of OCT, you can't be sure of visual field. Here's a couple of cases, right? They go together, then you have it. Is that clear? All right. Here's another one. Here's normal visual field. This is example. So people often challenge me and say, you really see in some cases function before structure? Yes, you can. So I'm going to give you an example and then show you why. Right? Okay, so that's an abnormal field, right, Murray? Right? You have no trouble, abnormal field. Okay, the OCT, not so clear, but nevertheless, you certainly agree it's clear on the visual field.
Why? It's clear on the OCT.
As clear.
I mean, obviously, you can see change.
All right. Some people would say it's equally clear. I personally think those two are clearer than on the OCT. And by the way, if you look at the metrics, there's that green pie charts largely with one little yellow sliver someplace, right? So let's just take the upper visual field, for example. The pie charts are normal. I think it's fair to say it's clearer. I'd say almost everybody would say it's clearer on the visual field. But okay, ask Mike.
I was gonna say, I mean, I think it's clear on the RNFL.
Yeah.
But what I'm less clear about is the correspondence to the ganglion cell between the RNFL and ganglion cell. So that might be a yes.
Oh, there you go. Good point.
Might be a yes and a no.
All right. Yeah. So let's talk about the ganglion cell. Yeah. Okay. Anyway, so here's the point. you're gonna get this. You can make this a little more extreme. In fact, I'll tell you when you would get this with this eye. All right. So now that's this eye. So why? If you take the other eye, here's the other eye, and superimpose it, this eye started very thick when it was healthy. So you had to work your way all the way through that green before it showed up as abnormal. So if you don't like this example, we should have tested this person a little beforehand. But look at how much tissue it had to lose to see those thin red lines. And so here's the key. As Randy Carden and I years ago argued, that whether damage is seen best on an OCT or visual field depends on where you start out life. There's very little correlation between a healthy individual's sensitivity and a healthy individual's retinal nerve fibrillary thickness. Just look at a scale. Very little. This means if I start out life with a relatively thick retinal nerve fibrillary, but I'm not a very sensitive guy, and the visual field is lower, quite small. And you started out the reverse, very sensitive on visual field for whatever reason, but lower end of things. We both get glaucoma. It's going to show up better on you, in the OCT, better on you. There's no surprise about it. You have to go through the red. All right, I think this is the actual. Oh. So the actual preparametric eyes are relatively rare if you get 24-2s and 10-2s. So this is sort of your point, you know. And so here's an eye, normal. 10-2 is normal. Right? You probably wouldn't call that, but it certainly is suspicious, right? I don't know what you see in the Mike. You can tell me about the
Suspicious. Yeah.
What do you see
On the disc, on the photo?
Yeah.
Yeah, the neural rim inferiorly.
Oh, it's showing up a little bit there.
That's what I'm saying.
Okay. Anyway, there's the subtle field. This is all very early. 10 months later or so, there's now a nasal step.
There you go.
Right? And you can say, okay, nasal steps. There it is. That's what you're expecting, but at least it's early glaucoma, right? So that's all just the agreement. Okay. There's the OCT earlier and later. So it may have been a nasal step on your field, but if you look the difference between 2013, 2017, that region here is the region that extends all the way into the focal. So this is an example of early damage, you know, once again involving the macula. And the black arrow is your nasal step, and the violet arrow is your macular involvement. Again, only 1.5 millimeters. There's no magic or surprise. And that's that.
Here at one time, we want to take a picture. So before everybody, if I can ask everybody to stay here, and we can get one picture, a group picture, and then we go up to the third floor for lunch. And we can have people just come further down so we can take these. I guess we'll take it right here.
Yeah, just use the seat like the first 3-4 rows. That's.
Fundamental. If we look at the depth, okay, and we think of this as the rim, and we think with glaucoma we get a notch, okay? And
Taking a picture. Let's get on the third one. You just
we
take
know
right
that
here
the
for these first two
fibers that
rows.
feed the retina
And we'll just go
come
up
in.
the first 2 rows.
and they sit, you know, right here. They
Right.
sit, and the ones further right.
Okay. And
So
Here, excuse me, we just want to take a picture. You can ask them afterwards. Yeah. Thank you.
Picture standing between us and lunch.
Yes, so.
Should we try sitting here?
Yeah, that'd be great.
Everybody,
Sit.
come on.
And
move
then,
in, we
let's,
go,
can we sit and then have people stand behind this stuff? Is it too fresh? Okay.
Now, have a seat up here, and Mike, well, who else, okay. You can put a couple of people up here.
And squeeze in as much as you can.
Yeah, no, I mean,
Yeah. Standards.
Maybe we'll just come over
Stand.
here.
Okay, yeah.
You know, see, it's, right now, so let's just come over here. And
I need.
we need to compress. No, it's too wide, huh?
It's too wide.
So why don't we just,
okay, I was on the floor, step behind me.
You can stand behind people sitting, that would be ideal.
Yes.
One broken leg.
I don't want to cover anybody.
Yeah, right there, yep. We could use another stander back here. Thank you.
Gone like a minute or two.
Right.
Well, good afternoon, everybody. It really gives me great pleasure to moderate this next session. We've got a real treat for you. We've got Dr. Simon John with us to give us an update on aspects of sort of neuroprotection, neurodegeneration. Dr. John started off his studies at the University College Cardiff in Wales, and then did his PhD at McGill University in Montreal, Canada. His postdoctoral studies were then at the University of North Carolina, Chapel Hill, with Nobel laureate Dr. Oliver Smithies. But in 1995, he took up his first academic appointment as assistant professor of the Jackson Laboratory in Bar Harbor, Maine, and stayed there for quite a while until recently moving to Columbia, so part of our Columbia Day today. Dr. Johns has been held one of the prestigious Howard Hughes Medical Institute memberships for a long time. And if anybody doesn't know what the Howard Hughes Medical Institute is, I'll talk to you at the break afterwards. With that, Dr. John, if you'd like to take it away on the the title of his talk is Studies Supporting Metabolism Resetting in the Treatment to Protect Protection from Glaucoma. Thank you very much, Dr.
Thank you for the kind introduction and for the invitation today. I wasn't exactly certain of the audience, so I hope I'm going to hit the right points here. You all know what glaucoma is, so I don't need to belabor this slide. But in my lab, we've been very interested in the risk factors for glaucoma and trying to understand the risk factors to get at disease mechanisms and ultimately treatments. So we've worked a lot in genetics. We've got a lot of current work ongoing to understand why intraocular pressure becomes elevated. But the story I'm going to tell you today is how we were interested in aspects of aging in glaucoma and how that has suggested vitamin-based treatments or nutrient-based treatments for glaucoma. This slide is basically a high-level overview of the talk. I'm going to introduce you to a mouse model that we've been using, which has many features of human glaucoma. Importantly, I want you to remember when I talk about this mouse model is the key control strain that we use that only differs in a single gene mutation, but does not develop glaucoma and is otherwise well matched to the DBA2J mice, which gives us a lot of power as a control. Using these and other models, we've been studying molecular features of disease and effects of age and how they interact together. This resulted in our discovering altered mitochondrial functions and altered metabolism prior to neurodegeneration in glaucoma. These are some of the very early changes following on a high intraocular pressure before there's neural degeneration. Resulting from these studies, we've tested metabolism supporting treatments, and they were highly successful in mice, and so we moved them to a clinical trial. This has led to a concept of resilience in my mind, where we can now think about developing strategies to retain a youthful or enhance a depleted metabolism. This will maintain metabolic robustness, boost cellular resilience, and hence fend off insults that cause disease. This concept could be generally useful across many patients for glaucoma or even different disease settings. So this is a complement to precision medicine you might have heard about. In precision medicine, you might try to change a specific molecule or gene. This could enhance and complement such approaches, but be more broadly applicable for larger numbers of people, where you support metabolism so the body can fend off the diseases better. The mouse we've largely used in many of our studies is an inbred strain of mice that develops a natural glaucoma with many hallmark features of human glaucoma. This is an inherited age-dependent progressive disease. There's an age-dependent elevation of intraocular pressure that induces the glaucoma, and I'll explain that in a minute. IOP lowering treatments protect from glaucoma in this model. If you look at the cell types that are affected, it's a highly specific disease to the retinal ganglion cells as far as their demise and ultimate death. And we see patterns of damage in the retina and cell loss in the retina that match visual field deficits in humans if you account for the slightly different anatomy between mice and humans. So really the disease is very similar to the human disease. Furthermore, a number of the pathways and molecules we've identified to change in this glaucoma have also been shown to change in human glaucoma and primate glaucoma. These mice actually develop a severe pigmentary form of glaucoma. This pigmentary glaucoma results from mutations in two genes you see here called GPNB and TYP1B. And these mutations in these two genes affect melanosomes, perturbing melanosomal biology, leading to oxidative stress within iris cells, which leads to iris disease. So you get pigment dispersion from the iris and iris atrophy as well in the severe form. This debris from the iris then enters the drainage structures and induces a damaging reaction that increases IOP. And then this ultimately leads to retinal ganglion cell death and optic nerve atrophy. Since we described this disease in mice on these pathways quite some time ago, more recently it's been found that at least in a subset of human pigmentary glaucoma, genes belonging to similar processes are involved, in particular the PMEL70 gene, which is a melanosomal structural protein. And the melanosomal abnormalities we see in these mice look remarkably similar to those reported in human pigmentary glaucomas in the iris. What I want you to remember for the rest of the talk, as I mentioned, there's these two genes that interact together to cause this very severe pigment dispersion and iris disease, which leads to the glaucoma in these mice. We have uncovered a wild-type ancestral version of the GPNB gene, which lacks this R150X stop mutation. So the stop mutation contributes to the disease. Because we uncovered this ancestral allele in the same strain of mice, we could make a control strain of mice that's wild type for this GPNB been, so-called GBNMB+. These genetically matched mice, other than this single mutational change, do not develop high IOP and do not develop glaucoma. And so they give us a wonderful control for all of our experiments. Please remember that, because I won't be going back through it, but it's important in understanding why we use these mice as a control in later experiments, the GPNMB+ mice. The DBA2J mice following the high intraocular pressure develop a pretty specific retinal ganglion cell loss in our colony and subsequent optic nerve damage. Here you see DBA2J retinas. Here's a non-glaucomatous animal. Moving my cursor across the retinal ganglion cells here, and inner to the retinal ganglion cells, you see this beautiful nerve fiber layer where the ganglion cell axons run across the retina. In the glaucomatous mice, the retina is intact, but you've lost ganglion cells and the nerve fiber layer is thinned. And if you look at the optic nerve, this is a mouse optic nerve, so you have this central retinal vessels coming out through the optic nerve, so it looks slightly different to a human. But you have a nice thick nerve fiber layer as the axons come into the optic nerve, and you have nice normal neural tissue here and astrocytes. In the disease setting, in the DBA2J mouse, it's developed severe glaucoma, the nerve fiber layer is lost, the ganglion cells are lost, and you have this optic nerve excavation and remodeling. So again, similar to human glaucoma. Also similar to the human disease, this disease is variable and asynchronous from eye to eye. And at any age, you can find eyes with severe glaucoma or less severe glaucoma after they have reached a glaucomatous stage. I'm trying to show you that as a frequency distribution here. At the time we made this distribution, we'd analyzed over 800 mice. What does this mean? Well, in green, you see what we call no or early glaucoma. By any conventional criteria, these animals do not have glaucoma. They don't have physiologic defects. They don't have retinal ganglion cell loss or nerve damage. We call them no early glaucoma because some of these mice have had ongoing high intraocular pressure insults and have begun along the path of very early molecular changes, which you can't tell unless you analyze gene expression. And that's why we say some of them, but not all of them, are very early stages of glaucoma, though they would not be classified as disease in a human setting. The moderate mice of obvious disease, we can see histopathologically, they have 10 to 50% axon loss and normally about 30% axon loss. And this, they're the eyes in yellow. And the ones in severe red have over 50% axon loss. So if you took 10 months, for example, you can see there's a significant number of animals that have no glaucoma or at very early molecular stages, some moderate and some severe. So as you get older, you get a higher propensity for the severe disease. But because of this variability, and we want to understand early stages, it's important we use large numbers of animals. You wouldn't do a human clinical trial with very small numbers once you get to the serious later stage trials. And again, with these mouse experiments, in most of our experiments, we're using sample sizes of over 60 and often over 100 in any experimental treatment group or genotype group that I tell you about. So I won't be going through those numbers later on. Please bear that in mind. These plots can sometimes be confusing to people. So if you want to simplify some of the data I'll show you, you can think about the green mice as having no glaucoma and ignore the other stages later on in the talk. If we looked at these animals on the progression of the disease in terms of intraocular pressure is becoming high by 5 to 6 months of age. So the iris disease is kicking in really by 5 to 6 months of disease. You're getting the increased IOP by 6 to 8 months, and then typically the retinal ganglion cell death and optic nerve atrophy by 10 to 12 months. So though this is age-related in mice, it's greatly accelerated in timeframes of study compared to human glaucoma, obviously. So that's a big advantage. So we've used these mice to ask how are the neurons insulted in glaucoma. What we've really wanted to ask are what are the early changes that precede axon damage or loss or retinal ganglion cell changes in the glaucoma. As you know, you have your retinal ganglion cells in the retina, their axons coalesce through the optic nerve. You have astrocytes and other cell types in the optic nerve and other cell types that can be involved as well. So what we've been doing is using gene expression profiling, also known as transcriptional profiling, to assess as many of the genes assessed in these tissues and cells as is possible. And by doing these global expression studies, we've then been able to define very early stages of disease that precede the neurodegeneration. And over the next few slides, I'm going to try to give you an explanation of the basic outline for this. If we assess all of the genes expressed in the cells, we can use microarrays, RNA-seq, or other more modern technologies to do this. The way we basically did it was to use our GPNB control mice. Remember, they're genetically matched to the DBA2J mice other than the single genetic change. So these mice, when we compare the D2GPNB versus the glaucoma DBA2J mice, they're age, strain, sex, and environment matched because they're housed in the same cages. So the only differences you can have going on between these mice at glaucomatous ages are due to glaucoma or possibly GPNB genotype, the effects of this single gene. By doing other gene expression studies, we can determine which gene changes are due to genotype alone. And so the gene list where genes have a differential expression value here due to glaucoma or genotype, we can then subtract out the genes differing due to genotype. And that leaves us with a group of genes that have changed due to glaucoma. So we call them glaucoma relevant genes. So that's the first step in our studies. This is behind many of our studies, though I won't be going through it again later. The next step when we have these glaucoma relevant genes is we can use mathematical, computational, unbiased clustering methods to cluster the samples. So we can take each individual sample based on these glaucoma relevant genes, and we can cluster them based on their molecular similarity by a technique known as hierarchical clustering. And what we do is we throw into the software all of the eyes, be it either the controls or the potential glaucomatous animals, and then we let the computer stratify them into groups based on the molecular similarity of the gene expression of all of these genes. This plot shows you a minor subset of this. If we look at this first group, each column here is a single eye. Coming down in this heat map, each little rectangle in slightly different colors like this are individual genes. Green is lower expressed, red is higher expressed in this particular plot. And as you can see, the computer clustered these samples here based on their molecular similarity across the expression of this subset of genes. It is actually based on all of the glaucoma relevant genes. I'm just showing you this subset. But you can get the idea how we can identify different stages of glaucoma based on molecular similarity, just shown visually here. There's much more data behind it than I can show you. So this worked very well for us. And using these approaches, this is an example from optic nerve head tissue. We could have the eyes we could previously identify as moderate or severe glaucoma. And then our early eyes, which we called more early, we substratified into 3 stages of glaucoma in our initial studies. And our control group came out as its own group, giving us an anchor on each side, control or known stages of disease, which told us the technique was working. So what we now had is 3 new stages of glaucoma, which are ordered in terms of how different they get from the control and progress along the disease. We then redid the study with more sample sizes, and were able to subdivide this stage 1 into actually 3 substages. So now we had 6 stages of glaucoma that preceded any neurodegeneration, as confirmed by assessing the optic nerves of these animals. To show you that these are really distinct, I'll just focus on these 5 stages on the first line. But if we look at the total number of axons in stages 1 and 2, they haven't changed at all. In stage 3, they might be trying to change, but it's probably flux of the mean. And then it's when you get into stage 4 and 5, you get the really significant changes for these known glaucoma stages. If you look at the number of differentially expressed genes due to glaucoma, they increase as you increase the glaucoma stage. This is how we ordered these temporally. If you do a principal component analysis where we collapse all of the gene expression data onto 2 major principal components, we can see these stages do really occupy different multidimensional spaces, and they are truly distinct. Using these studies, in our initial study studying whole tissues, either whole optic nerve head or whole retina, we identified a number of pathways that change in glaucoma. We identified pro-inflammatory signaling very, very early in the disease. And our recent evidence has suggested that at least a large amount of this is a direct response to intraocular pressure and actually precedes any neural dysfunction that we can detect by our gene expression studies with our current resolution of analyses. These pro-inflammatory responses may be an initially protective response to tissue stress, but as stress continues, they become damaging. We also discovered that monocytes can enter the optic nerve head and they can have dual functions. When pressure becomes high, these monocytes enter the nerve head in small numbers, maybe 20 to 50 per optic nerve in the mouse. And they're initially protective, but as the disease progresses, they turn to become damaging as they keep sensing stresses. We found that the endothelin pathway is important in glaucoma. You may know the endothelin pathway has been a potent vasoconstrictory pathway in the body. We've shown that it contributes to vasoconstriction in the eye very early in glaucoma, and that antagonizing it can be protective from glaucoma. Similar pathways have been shown in other models of glaucoma and suggested in human glaucoma as well. We also implemented the complement cascade and different members of the complement cascade, C3, C5, C1, for example. Interestingly, complement 1 is very damaging in this glaucoma. Complement 3, if we ablate that, it actually has a protective role. This probably differs with disease stage, but because it's protective at early stages of disease, it's a caution about inhibiting complement 3 as a glaucoma treatment. Complement 1 is probably a safer target based on the mouse data. I'm now going to change to the major theme of the talk that I've given you this background. Age is a major risk factor for glaucoma under the common neurodegenerative diseases. As you're well aware, not only does human risk increase with age, but animal risk for glaucoma increases with age. And actually, if you increase intraocular pressure in animals, they're more vulnerable to that intraocular pressure the older they are. So what increases neuronal vulnerability with age? Again, we wanted to go back to our global gene expression studies doing transcriptomic profiling. Technologies had changed when we came to do these studies, and so we were able to better study specific cell types. So Pete Williams, a former member of my lab, developed methods to identify all these different cell types from eyes, and then we could study them one by gene expression studies. Now, we used our GPNB mice, our controls, and at age, if you remember the plot I showed you earlier on, I should have pointed it out, sorry, I forgot. But at 9 months, the vast majority of animals have no detectable glaucoma, although they've had ongoing high intraocular pressure for a few months. So this was a good age to do these studies to get at early changes as a consequence of high intraocular pressure prior to neurodegeneration. So if we compare our control mice to our DBA2J mice at 9 months, again, with all the features mapped that we had before, we can identify glaucoma genes as we've described, or changes likely due to glaucoma. We could do another study in parallel where we just looked at the GPN and B plus mice. Remember, these mice do not develop glaucoma, but we can age them in the same way. So by comparing these two groups, we can learn what the changes due to age. And by comparing results from both of these types of studies, we can see what's age, and then exacerbated by glaucoma, and what's got glaucoma. And so we can understand why various features are changing, and that gives us power then to try to address what's happening. What I'm going to be telling you about for the rest of the talk is our work working with retinal ganglion cells specifically. So we isolated retinal ganglion cells from eyes. We used these RNA sequencing methods to profile as many of the genes as we could expressed in these cells, and again, prior to neurodegeneration. And the punchline is that we identified very early mitochondrial dysfunction and metabolic stress in the retinal ganglion cells, which supports an argument that glaucoma is a form of metabolic optic neuropathy, if you wish. So let me show you some of the data. We used genome-wide expression profiling in ganglion cells. Again, we took DBA2J eyes with ongoing high IOP, but hadn't yet had any other signs of glaucoma. Using the methodologies I've told you about, we defined 4 groups that represent early molecular stages prior to neurodegeneration. Here you see them here on this plot, groups 1, 2, 3, and 4. on the number of differentially expressed genes versus the controls. Look at group 1, no difference to the control, GPNB mice. So if we look at these eyes over here, group 1 clusters with all of our GPNB control mice and with young DBA2J mice at 4 months of age. So it's indistinguishable to a no glaucoma stage. So it's at an age where high intraocular pressure, many of the mice have had it. So we believe that these mice just haven't yet had enough of an IOP insult to have progressed. So they give us a wonderful control group because they're identical to all of the other DBA2J mice in any way, except they haven't yet started progressing molecularly. We then get these other groups 2, 3, and 4, which are increasing stages of glaucoma. We see differential gene expression patterns increasing across them. So group 2 is very important because it's the first stage where we can detect gene expression changes significantly. Group 4 might sound late, but please bear in mind, this is still prior to any neurodegeneration. So it's still a very early stage of glaucoma. What did we uncover? Well, a major pathway we uncovered was mitochondrial dysfunction. If we looked at the number of transcripts we're getting from the mitochondrial genome versus the nuclear genome, it becomes imbalanced. And it first becomes imbalanced in this first stage, which differs from controls, our group 2. And it gets worse. So this is a sign of mitochondrial dysfunction. If we do pathway analysis, where we ask how many of the differentially expressed genes belong in certain pathways, and correct for the number of genes present in each pathway to get a significance estimate, all of these pathways here were highly significantly different compared to our controls, and as early as group 2. EIF is an important transcriptional factor for stress responses and mitochondrial health and can impact metabolism, and it changes as early as group 2. Mitochondrial dysfunction pathways changed as early as group 2. Another metabolic pathway I'm not going to talk about today, but affects energy metabolism of all the mTOR pathways changed early. And very importantly, the oxidative phosphorylation pathway has changed very early in disease. As you know, the oxidative phosphorylation pathway generates the largest amount of ATP in the retina. If we look over here, our G group is our GPNB control, and we've got stages 1 to 4. This is a heat map of just the genes involved in oxidative phosphorylation or the electron transport change in mitochondrial complexes 1 to 5. Here, blue is low expression, red is higher expression. Look how similar the gene expression is in group 1 to the controls. There are differences, but it's remarkably similar. But look, as soon as we jump to this first glaucoma stage, look how much of this is red or different colors now compared to these controls. And by the time we get to stage 4, the oxidative phosphorylation pathway looks very, very different. So very, very strong evidence for change in mitochondrial functions and energy metabolism and ATP generation. Similarly, if we look at mitochondrial morphology, this shows us GPNB wild-type control mice and mouse normal mitochondria in these mice. And this is just one example from a DBA2J where it's lost its crystal, and these mitochondria look very abnormal. Having discovered these changes in mitochondrial metabolism, we did metabolomic studies. Craig Whitlock and Pete Williams were again involved in this, to ask what metabolites are changing in glaucoma. And among the metabolites we found that changed, we found an early decrease of NAD and glutathione. NAD is a key molecule in energy metabolism, redox biology, and mitochondrial health. Glutathione is important in antioxidant defense. So this is consistent with altered energy metabolism and increased susceptibility to oxidative stress. We saw these changes here, for example, for NAD in the optic nerve and in the retina. Importantly, look, these are our GPNB control mice that don't develop glaucoma. So these changes in NAD are due to age, not disease alone. Age, NAD decreases, and it does get worse in the glaucoma, but age is a major impact here. NAD, as I mentioned, is important in many biological processes. It's very important in mitochondrial metabolism and energy homeostasis and glycolysis. And so it is a key molecule to think about in this setting. So we came up with a hypothesis that an age-dependent decline of NAD may be central in the neuronal vulnerability of retinal ganglion cells by increasing the probability of metabolic failure within retinal ganglion cells when those ganglion cells are exposed to the ongoing IOP-induced stresses. So age would decrease NAD, rendering you susceptible to IOP becoming damaging. That was the hypothesis. If this is correct, then adding NAD into the system should protect from glaucoma. We thought hard about how to do this, and we decided to tap into a pathway known as the salvage pathway, which is the major pathway that generates NAD in the body. Nicotinamide, the amidated form of vitamin B3. This form is important. We use this because it's less noxious than nicotinic acid. It has different biochemical properties than nicotinic acid. So it's very important that we use the amide form nicotinamide. Nicotinamide is converted by this enzyme NAMPNT to nicotinamide mononucleotide. And nicotinamide mononucleotide is then converted by NMNAT1. Please remember this enzyme, NMNAT, into NAD by adenylating it. So you get NAD produced. So we decided, because this is a natural process in the body, it's very efficient. Nicotinamide is absorbed readily. It's got a good safety profile. If we could intervene in glaucoma by using vitamin B3, this could become a real treatment for people. So that's what we decided to test, and the results are truly very encouraging. So let me go through some of that. So we administered nicotinamide in diet, in food, and or drinking water, depending on the dose. We showed that this increased NAD levels in the retina. Indeed, it profoundly protected from glaucoma. It prevented the loss of pattern electroretinogram peaks. This is a measure of retinal ganglion cell function. If you look here at these young DBA2J mice, they have a peak. By the time they're 12 months, it's destroyed due to the glaucoma. But if they're non-nicotinamide treated 12-month mice, there's a very strong rescue here. If we look at axon transport, very important in glaucoma. You input a molecule into the eye, it gets transported back through the optic nerve and back to the brain by anterograde transport. If we put a fluorescent molecule into the eye, it can be transported back through the optic nerve into the LGN and into the superior colliculus of many ganglion cells synapse in mice, as you can see here in this control mouse. In the DBA2J glaucomatous mice, look how it's blocked at the region of the lamina, as would occur in people where axon transport gets blocked in this region. It does not make it back to the LGN or the superior colliculus. Look at the nicotinamide treated animals, and indeed it's transported back throughout the optic nerve and into the brain very robustly. We've also measured various mitochondrial features, and we've shown that we prevent mitochondrial abnormalities. For example, if we look at these three examples of DBA2J retinas, in the middle here with these mitochondria looking very abnormal. If we look at the nicotinamide treated, the mitochondria of nice healthy cristae are similar to the controls. So what about optic nerve damage and the retinal ganglion cell bodies themselves? Well, we even protect these very profoundly. Here's a control animal. If we stain for retinal ganglion cells with a molecule known as RPBDMS using an antibody, see lots of healthy retinal ganglion cells, and the optic nerve looks nice and healthy with little darkly stained axons with a myelin sheath around them, is stained very dark here. In the glaucoma, as it gets more severe, you see you lose most of the ganglion cells and you end up with a glial scar in the optic nerve. You don't see the axons here. In the nicotinamide treated that are protected, again, very robust ganglion cells and a beautifully protected optic nerve. Obviously, you can be misled by a few images. So this is a data set, again, from hundreds of animals, maybe 100 in a group or more. And what you can see here is our controls with just plain water or plain food. We put nicotinamide for our lower dose, which is early or late start, in the drinking water. And our high dose, we had to put it in drinking water and food because the drinking water gets too bitter for the mice to drink if you put it all in the water. Indeed, with any of these, remember the green or the no glaucoma, we profoundly protected from glaucoma. And at this high dose, it's remarkable. We stopped about 93% of the eyes from getting glaucoma, or I should say 93% of the eyes did not develop glaucoma more correctly. So this is a very, very robust effect. Indeed, in these mice, it decreased the risk of developing glaucoma by tenfold. So this was very encouraging. We have extended this to other models, and we do see protection, not as profound as in these mice, but we do get protection in other systems, and other groups have been reproducing our results in different model systems. So this is very robust finding. Very importantly, nicotinamide prevented the vast majority of disease-related molecular changes as well. Here, if we look at the oxidative phosphorylation pathway I explained to you previously, our GPNMB controls now at different stages of glaucoma. Look at the nicotinamide treated on the far right. It's identical to the controls. It's just remarkable how protective this was. I can't see any differences here myself compared to the G column, or very minor differences. So a remarkable degree of protection. If we now collapse down a heat map of all of the genes in the subset of the control mice, the group 4 glaucoma, that's stage 4, or the nicotinamide treated. Look in the stage 4, looks very different to our controls. Each column here is an individual eye to show you the variability. In these GPNMB controls, look how it's largely red, pink in this region. Look how it's largely blue here. Largely red down here in the glaucoma, bluer over here. Now let's look at the nicotinamide treated. Look, it's quite remarkable. Look at this pale line here in the control. It's gone in the glaucoma. It's back in the treated. This red cluster here, the same, or strikingly, this blue line here. A remarkable degree of protection. Now, if you want to look at individual pathways, this is a pathway plot. Any dot is a gene in this particular pathway. So any gray dot is an oxidative phosphorylation gene plotted at its log fold change versus control. If it's marked in red, it's statistically significantly different to the controls. So here's the glaucoma mice, lots of oxidative phosphorylation genes significantly different. Look at the nicotinamide treated, corrected, reactive oxygen species corrected, glucose metabolism, fatty acids, DNA repair. Just a remarkable result, how strong this protection is in these mice. And it's been very robust and reproducible. Well, what I should mention, we started getting into this due to age. Due to age alone, I believe, if I remember the data correctly, is about 4,500 genes changed over the course of this experiment. In the nicotinamide treated, only 2% of those genes changed. 98% did not change. So this had a strong anti-aging effect in the eye based on molecular gene expression patterns as well. What's the safety of nicotinamide? It's actually got a very favorable risk to benefit ratio in favor of benefit. There have been various studies using large doses for schizophrenia, diabetes, and other types of conditions. Very rarely, some hepatitis is seen, but it is extremely rare. In the schizophrenia study, if I remember correctly, there were 3 cases, 2 resolved without going off nicotinamide, and 1 was actually due to the nicotinamide. So a low incidence in these reported studies, though we do have to bear in mind that many of these patients are substantially younger than the glaucoma population. So we do have to proceed with caution. Up to 3 grams of nicotinamide is considered safe per day, with higher doses having potential toxicity issues, especially for the liver. Our low dose in our studies was equivalent to 2.7 grams per day for a 60 kilogram person, about 3 grams per day for a 70 kilogram person. Our high dose is about 9.8 grams per day. So we decided to continue these studies, as I'll talk about later on, using 3 grams per day in people. First, let's come back to the mechanisms. Do other NAD increasing therapies work? Well, there's a spontaneous mutation which makes a new form of a gene known as the wild S gene, and this encodes that enzyme NMNAT I told you about that makes NAD, that final step making NAD from nicotinamide. So we wanted to ask, does wild S protect and does it increase NAD? We also did the gene therapy using NMNAT, where we could add NMNAT directly into the retina, because this might give you potential one-time treatment or long-term treatments. And we could combine gene therapy with giving nicotinamide to try to drive these biochemical reactions further by mass action to see if it would be even better. Importantly, in doing these gene-based treatments, the only thing they share with nicotinamide is NAD. Nicotinamide also has other effects on calcium signaling, antagonizing endothelins, promoting blood flow, promoting autophagy, mitophagy, which can help to maintain healthy mitochondria, inhibiting enzymes that have been suggested to be damaging in glaucoma. So nicotinamide probably has a pleiotropic effect, which is one reason why it's so protective. So in the next experiments, we're also trying to ask what component of this is due to NAD within retinal ganglion cells. Indeed, wild S raised NAD levels in these mice, and it was profoundly protective from the glaucoma. As you see over here, again, if you look at the green, here's the DBA2J. Most of these mice developed glaucoma. In the nicotinamide treated, the wild S treated, many of them now did not develop glaucoma, these green bars. And in the combined treatment, 94% of them did not develop glaucoma. And again, remember, these are robust sample sizes. It also prevented all assessed glaucoma phenotypes, including dendritic remodeling and synapse loss in the retina. So there's really a profound protection. We did gene therapy using the NM-NOT gene. We introduced this into mouse eyes using an AAV2 virus. We successfully transduced about 80% of the retinal ganglion cells. And again, we had a very strong protection. Not quite as strong as the drug highest doses, but stronger than our lowest doses. Again, we didn't transfect all of the cells. And when we combined it with the low dose of nicotinamide, again, it really boosted the protection up. If we look at retinal ganglion cell numbers, they're protected. If we look at PERG, it was protected. So this is a very nice example of a gene therapy in a very complex disease based on this resilience concept of making the neurons more robust. And so we think this is great promise for the future. Are there other metabolic disturbances in the glaucoma? I'm sorry, I see I'm nearly out of time because we started a touch late, so I'll go very quickly. We also found evidence for disturbed glucose and pyruvate metabolism based on our gene expression data again. Obviously, glucose and pyruvate are very important in energy metabolism. We actually found evidence of decreased glycolysis underlying these increases in pyruvate in the glaucoma. We found elevated glucose levels along with the decreased pyruvate levels. And other groups have found similar metabolic issues in glaucoma now. So because we found these disturbances in glycolysis and pyruvate, we also wanted to ask, is pyruvate protective? Pyruvate is a key product of glycolysis, which feeds into the Krebs cycle. It's used in a variety of anabolic and catabolic pathways and then goes to the TCA or Krebs cycle. It can scavenge reactive oxygen species. It can reduce antioxidant defense via the NRF2 transcription factor. It can promote autophagy and mitophagy to help maintain mitochondria. And in fact, we showed that the combination treatment using nicotinamide and pyruvate is the most effective. If you just look at this plot to be quick, here's our water control, here's our pyruvate treated, our nicotinamide, and our pyruvate and nicotinamide treated. This is number of eyes with glaucoma, so these decreases are showing you we're getting better protection, and the combined treatment was the most effective. We collaborated with Dr. Robert Carson in Australia, and his lab showed protection in rat models of ocular hypertension with pyruvate as well. So the key messages are we found age-dependent decreases of NAD, which likely increased metabolic decline and contributed to glaucoma in the face of high IOP. Nicotinamide treatment's potently protective at a dose that's considered safe for patients. There's also disturbed glucose and pyruvate metabolism occurring, and pyruvate administration is protective. Combining pyruvate and nicotinamide seems very attractive because it was most effective in our animal models. We've published metabolism preserving treatments now in many mice. This slide is quite old. It's significantly more than 650 now. This didn't include the pyruvate treatments at the time, so this is a robust effect. And so they have great potential for glaucoma. So regarding human glaucoma, there's an emerging and growing literature supporting mitochondrial susceptibility and NAD metabolism. There's increased incidence of mitochondrial DNA mutations in blood cells, suggesting a systemic susceptibility to mitochondrial dysfunction. Patients have lower nicotinamide levels in their blood. This is an open angle glaucoma. Lower pyruvate levels have also been reported to be associated with worse glaucoma in primary open-angle glaucoma patients. So all of this has led us to test these therapies in people, and our first stage clinical trials are important and support neural recovery in human glaucoma, though they were short-term studies. This study was a little disrupted by COVID, and Gustav Moras, our next speaker, Dr. Moras, was heavily involved in this study, the first author. We successfully, through COVID, enrolled 32 patients with PORG. They were still on their traditional eye drops. They were randomized to a B3 pyruvate combination versus placebo, and they had 10 visual fields over 3 months. The major endpoint was a number of improving test points on a 24/2 visual field. The B3 pyruvate patients treated had almost 3 times the number of improving test locations than placebo. This corresponded to over 25% of the visual field. So though the numbers are small, this is very encouraging, suggesting neural recovery, and it's leading us to do further studies. This was where the paper was published. There's another study from another group using nicotinamide alone, and they also found improvements in inner retinal function in glaucoma using different techniques to us. So thinking about this translational science, we're moving on to the next steps with greater numbers of patients. We'll be doing a neuroprotection study over 18 months. This is a study in part funded by the Glaucoma Foundation. We'll be randomizing the vitamin supplements versus placebo and assessing rates of progression to determine if a B3 pyruvate combination is neuroprotective over a longer period, and to provide a more science-based vitamin therapy or metabolic therapies for glaucoma. We're still doing basic work to understand metabolism better and to come up with new ways of intervening as well, and maybe a cocktail of molecules which would allow lower doses of each one. I'll stop there and just thank many people who've been involved, my current lab members. As I mentioned in the talk, Pete Williams was very important in this work, as long with Dr. Moras, Jeff Liebman, George Chaffee, and others. And I'd like to thank Craig Wheelock and Pete for their contributions as well. Thank you very much for your time.
Thank you very much. We've still got 10 minutes for questions, so I'm sure you'll have a few questions here. I might just get us started. I think you sort of mentioned a few times during the talk, initially when you talked about complement effects, but all the way through there was this idea that certain things happen in the progression or the development of glaucoma where things can be antagonistic or they seem to, I think you said C1 can be protective early and C3 damaging early, but they may switch and different things happen at different stages of the disease. The initial treatment there, the nicotinamide, it seemed you were talking in the mice studies about the very early stage disease. And yet in the human trial, that seemed to be not just neuroprotective, but I don't know, it's hard to believe that the field's got better. It really did, but it would be neuroregenerative in some way. Were you surprised by that result, given the different stages of disease that we were talking about?
Yeah. So there's a lot to unpack there, so let me try to go through them. I agree with you, different molecules might have different roles at different stages of disease. Some molecules might be protective at some stages, and later in the disease become damaging. I might have misspoken in my talk, or maybe it's just I give through a lot of things at you, but in the glaucoma, complement 1 is protective. We've never seen it, disrupting complement 1 is protective. So the molecule is always damaging, as far as we can tell. And that's why we think it's a good candidate. Complement 1 can have effects which are independent of the classical complement cascade. So when we disrupted complement C3, the key member of the classical complement cascade, that's where we saw things being different. Complement 3 is protective very early in this disease. However, my instinct is as the disease progresses, it becomes damaging. Early on, this protection is something related to an astrocyte pathway that we don't fully understand. Later on, it's present in monocytes, microglia, and other molecules, and is likely damaging as the disease progresses. When we disrupted it, we saw overall worse disease, probably because we removed those early protective effects. That isn't to say that if you can disrupt it specifically in a specific cell type at a specific stage of disease, it won't be protective. But if you've got patients at early stages or asynchronous stages within an eye, depending on the various cells, it is a bit of a risk for complement C3, I think. And I believe there's other molecules as well, which might have different roles in different cell types or different being protective or damaging at different stages of disease. So that's my comment on your first question. Nicotinamide, and do I believe it's improving visual fields? Actually, I do. And no, I was not surprised. That's why we designed the study we did to try to look for early neuro recovery. One way to think about this is nicotinamide's doing different things. Yes, we looked at it very early in the mice with that resilience concept I told you about. Once we realized it was decreasing, what is lack of NAD going to do to a cell? It's going to deplete it of energy. It's going to deplete it of other key biochemical processes. The cell won't be able to function as well.
We just lost you at the beginning of that last statement. So you're back with us now. Perhaps you can just get back a sentence or a thought.
Okay, I'll start on the nicotinamide again.
Thank you.
So starting with nicotinamide, I was not surprised. Maybe I'm overly optimistic when we saw an improvement of visual function. That's what we wanted to ask, is it feasible? Because it made theoretical sense. Let me try to go back through the rationale. We found nicotinamide after doing the metabolomic studies and finding that NAD was decreasing. So NAD decreases with age. The NAD decrease alone is not enough to cause the glaucoma. The control mice get it. It's only when you had the high intraocular pressure on top of it. So the cells aren't able to deal with the stress of high intraocular pressure as well when you have slightly lower NAD. NAD is important in energy metabolism, generating ATP. It's important through glycolysis and other effects in anabolism and many other pathways, redox biology. So if a cell is low in NAD and it's not keeping up, it's going to be compromised in many ways, and especially energy metabolism. So if that cell is not yet damaged and it sees a high intraocular pressure and it's got low NAD, it's going to succumb. It's got a much higher probability of being damaged, so it doesn't fend it off and just suck it up and get past the insult. Now, if you think, okay, now I'm supplementing NAD through nicotinamide, this cell has now many more resources. It's got more energy. It's got more of the resources at higher levels in the cell to fend off the disease. So one, I think that's got great potential to stop progression of disease. But secondly, we know from the animal studies that very early in glaucoma, you can lose part of your pattern ERG strength on other measures prior to seeing any neurodegeneration. The cells start remodeling prior to neurodegeneration. So what that is saying is these cells prior to demise are in a stressed state because they don't have enough energy, they can't undergo fully normal metabolism, and they're seeing this high IOP stress. So if you're thinking now I've got a stressed cell, it's not yet irreversibly damaged. If I can give it extra energy and I can give it more resources, it might come back to its state and be able to fend it off. So that's what I feel is happening with the visual function. I think these cells on the edge, they're struggling to get by. They therefore can't undergo as good neural function because they're trying to survive. But when you give them the extra energy boost, the extra antioxidant boosts, and all the extra boosts you get from giving them the nicotinamide and the pyruvate, they can now function much better. So they overcome this compromise by having these more resources available to them. Well, that's what I believe is happening. So they're more resilient and they're more healthy. Does that make sense?
It does, absolutely. Yeah.
I view it as a tonic for the cells.
Yeah, no, fascinating. We've got a question?
Yeah, so in the mouse model, at an older age, when have you administered nicotinamide to see if it's protected?
Yes, I rushed through it a little bit, but we did an early and we did a late start. Not as late as we would in a person, but we did a pretty early start early in life, prior to IOP elevation, massively protective. We did a start later in life after the mice already had high IOP, but before they had neurodegeneration, equally protective. Actually, it was more protective, but I think that was just flux of the mean. I don't believe it was really more protective, but it wasn't distinguishable anyway. If anything, it was more so. What we haven't done in the mice is mice with already existing neurodegeneration and tried to reverse it. But we have seen improvements. If we take the age with high IOP, pattern ERGs are decreased. If you give them nicotinamide, they improve, similar to what we see in people. So we see the same pattern. Now, coming into the human setting is where we're really going to be able to ask, over longer time frames, and in these new trials we're doing, how does this work in the human disease over longer periods of time? But the evidence to date in the human trials is looking promising. These are glaucoma patients that have some visual function loss. And it's the small sample sizes, so we have to be cautious. Short-term studies, so we have to be cautious. But in those short-term studies, in 2 independent studies, using different physiologic methods, there was a restoration of visual function in human patients. And there are other reports now coming out of ARVO and other places suggesting similar things with related molecules.
Do the mice live longer when they're on this treatment?
Very good question. We didn't follow that adequately. Pete, who was in my lab, believed they were aging more slowly, but he didn't characterize it in a stringent enough way that we'd ever publish it. But they look healthier, they're leaner, and their cords look much better. Yeah, the mice actually look younger, but we just didn't quantify it well.
Got a question right at the back. Oh, it's us. Okay, go.
I thought it was.
It's on the bottom of the switch.
Because I like your comment about the complement pathway. And as you may be aware, there are 2 recently approved drugs for treatment of GA that are based on inhibition of C3 and C5. And I'm very curious to see what's going to be their effect in glaucoma. I mean, those studies were short, 18 months to 2 years. So we're going to be very surprised, as you told us, depending on how early or how late, maybe have a negative or perhaps a positive neuroprotective effect. So we're going to see a lot of stuff coming out, and it'd be nice to collect data on those patients to see what's going on with their RN as well.
Yeah, I think it's going to be very important. We ablated, we've looked at C5 deficiency in the glaucoma, and they're actually more protected than when you have C5. But C3 was when they were less protected if we ablated C3. I'm concerned about targeting complement C3 for the reasons I mentioned, but time will tell. But it might really depend on the nature of the glaucoma in the individual, what else is happening in their body and their stage of disease. I'd feel much better if we could target it specifically in a certain cell type, such as, say, the retinal ganglion cell. In doing it globally, I think it's a risky proposition, is my take on it right now. I feel much more comfortable targeting C1, personally.
Last question I think we've got time for.
Yes, in your human trials, were the NAD levels assessed after administration of the nicotinamide? It appears to me that after oral administration, the conversion availability of NAD it's minimal. And I've seen therapies with NAD, but done directly intravenously because it's a far better bioavailability on IV administration as NAD, not as nicotinamide.
Yeah, so all of this gets. Yeah.
So wondering if with your orals, were you getting optimal serum levels of NAD?
Yeah, so that was not done in the first level trials. It will be done in the next trials as long as we can secure all of the funding. It's expensive to do all of these assays. But nicotinamide is readily absorbed from food. It's known to be very penetrant of the gut. It's known to readily get into tissues. And so we really don't believe there's going to be a problem either. Actually, I'm not familiar with all of the studies you're talking about, but NAD is more labor and much more costly. So I'd have thought the nicotinamide would work very well. There are some groups which have suggested the nicotinamide riboside will be better. They claim that it's more bioavailable. But if you look at their own data in animals, the area under the curve is the same as for nicotinamide. It's just their different profiles where the nicotinamide riboside peaks earlier, whereas the nicotinamide doesn't peak as highly but lasts longer. So you can make different arguments. The other thing going on here is your genome, your microbiome in your gut. That's going to make a big difference to which metabolites are getting into your body. What are the bacteria doing to these molecules or other microorganisms in your gut? I think the ultimate proof is in the pudding, and if we get the new recovery, I suspect these molecules are being converted between different forms and back and forth. In the mice, we clearly had increased NAD and nicotinamide in the retinas, though. So we know at least in the mice it gets there. I don't have any good reason to believe that will differ in people, but I couldn't tell you the nicotinamide is going to be the be-all and end-all molecule versus some of the others. We chose nicotinamide very specifically for its biochemical properties, even though other people argue against it. We didn't agree with those arguments necessarily. And we don't see the advantages that some people claim over the other molecules. And when I've debated it with people, they haven't convinced me that one's better than the other. So I basically don't have a horse in that race where I'm really concerned about which one it is. I think we have to test a variety and find out what works the best. And it might actually be the best treatment, might be a combination of different molecules. Does that answer your question?
Thank you. Dr. John, we're going to have to...
John,
sorry, one last question.
So Dr. John, so it sounds like, you know, I mean, whether it's 3 years, 5 years, whatever, that could be going to a vitamin over-the-counter based therapy, either complementary or, you know, for glaucoma. It sounds like that's where this may be headed.
It's one possibility of where it will head. It'll depend, you know, vitamins are less regulated by the FDA, but when we're given such high doses, it's kind of new territory. So time is going to tell, but we envision potentially in nutraceutical formulations. Ideally, they'd be screened and vetted and pedigreed, so we know they're of high quality with no dangerous contaminants, which is a lot of the issues you get if you just buying stuff off the shelf. So pedigreeing and checking some of these out and giving safe product lines which are proven to be effective and are independently verified, I think is going to be key in that versus just buying everything off the shelf. There may also be room for prescription-based improvements or modifications, and maybe both will occur. But I'm very excited about a nutraceutical possibility because of the general accessibility and lower costs, as long as it is well pedigreed and validated for safety and efficacy.
Dr. John, we will leave it there, but thank you so much for your time. I think this is a talk that many of us in the room will remember for an awful long time. I hope we have the opportunity to speak with you again as a society to get some updates in a year or two's time, and we'll watch your work very carefully. It's always lovely to hear a Welsh accent. Good luck at the Rugby World Cup.
Thank you.
And look forward to seeing you soon. Thank you so much. Please join me in thanking you.
Thank you. Thank you for having me.
Have a 2-minute break.
We'll take a 2-minute break and then we'll get started. We've got that's been waiting, but let's just turn things around.
Just give these, here. If you have a flash drive, I think you can see here. Perfectly fine. You see those radio address? And I don't know why it's connected.
No, I didn't. Stop.
Yes. So over here. Seems they did that. Right. Yeah. You can actually use this to be.
I think I uploaded to my son. Do you have any speaker notes that you needed to see or not?
So yeah, it says. Let's see.
Hold on, I put it in extra plug. Down here.
I just said I was wondering. Or you like the butter in your session, not,
It's so. That's me being disorganized. I thought that's something. Yeah. Oh, you've got it.
I know, working on the cloud.
Yeah.
Well, we'll carry on the afternoon session and introduce another great Columbia University faculty and a good friend to the Optometric Glaucoma Society, Dr. Gus Moraes. Gus is really one of the leading researchers and glaucoma clinicians of his up and coming generation. Already 220 peer-reviewed research papers, 11 book chapters, successful and continuing funding from the National Eye Institute, the NIH, funding from the Glaucoma Foundations, Research to Prevent Blindness, and the CDC. And I know Gus will tell another compelling story. I think we've all got questions for you about that last short field study, so we may also tie into that at some point too. But it really is a great pleasure having you with us. So thank you very much for spending a Saturday when you could be at home with your family and with us. Thank you.
Thank you for this opportunity, especially with this audience 6 years later. Not everyone was here. But I like the fact that this time I'll be able to talk a little bit more about my clinical experience. So last time I spoke a little bit about research, and I have to acknowledge here Don as my mentor, friend, colleague. Most of the work I'm doing here is just to show how much it's possible to bridge research with clinical practice. So a lot of the things I'm going to show here are based on things I learned in the lab from him, and that I apply now to my patients. So I'll try to stay away from anything that's not yet commercially available or difficult to get or too cumbersome to obtain. And I'll try to focus more on what we can do with existing technologies. But most of all, when I say pearls and pitfalls, some things may not be such a pearl for you, but I think are worth remembering, especially given this audience has a focus on education. So here are my disclosures. None of them is actually related to any of the topics I'm going to discuss here. So, unlike Tony and Don, who had plenty of time, I have 45 minutes, which is a lot compared to what I usually get. But to talk about progression is tough, even if you're just talking about pearls and pitfalls. So I'll try to focus on three main topics here. The first one is on the use of structure agreement to detect glaucoma progression. Then I'll discuss some of the challenges to detect progression in advanced glaucoma, and again, how to make use of the existing technologies. And finally, some suggestions on how to manage or follow those patients with high myopia, which is something that always comes to discussion for us. So let's start talking about progression. So combining structure and structure, everyone knows and talks about structure-function relationships, but structure-structure relationships have become more a recent topic for research and also clinical practice. And some of the evidence that supported that use has been from many studies, but including this, the Advanced Imaging for Glaucoma study, which looked at patients both with suspected and pre-perimetric glaucoma and patients with perimetric glaucoma followed for many years. And they combined visual fields with OCT, which is the first time such a long study
included both technologies, looking at their performance to detect progression. And was a large sample of patients, and using a combination of OCT and visual field, the first finding, and here's just a perimetric glaucoma eyes, I'm not talking about pre-perimetric, in which is actually more evident, but in perimetric glaucoma eyes, an evidence for OCT being able to detect progression sooner, on average by 1 to 2 years, in a larger proportion of patients. And in addition to demonstrating, and this is very important here, that the OCT detect more progressing eyes than the visual field. They not always detect the same patients, of course. What I found most interesting, looking at just the OCT parameters, there was a relatively good proportion of eyes that were detected by each technology. So not showing that much of an advantage of using NFL alone or GCC alone, actually a combination of the two. And that's where the idea of combining structure comes from. And you may have heard or may expect me to talk about all the different structure parameters, such as minimum rim width. Given my experience, at least in this case, I'm going to be talking mostly about RNFL and GCC, but some of the concepts may also be applied to minimum rim width or other similar metrics. So with new technologies, and Don covered this very well, we're able to get very good high-resolution images of the optic nerve and changes over time. Same thing now. I think like we can say that it's standard of practice now to obtain macular scans in patients with glaucoma. We can have a discussion about whether we should be doing 10-2s in everyone, but I think macular CT scans everyone should be getting. And with looking at them independently may give you some information, but when combining the two, increase your likelihood and your certainty that glaucoma is progressing. And this you can do it both in an event-based approach as a trend-based approach. And if you want, look at the visual fields for confirmation. But one of the points I want to make here is something that's very important now in practice is how do we minimize the use of visual fields, or at least use them in a more intelligent way, given that it often adds more confusion than anything. So the use of OCT alone, I'm not advocating that, but I'm saying that there are situations that if you just use the information from the OCT, you may not need the visual fields to derive some conclusions, some plan that you need at that moment. And some of the basis for the structure agreement comes from some of the work we have done years ago, in which exactly what Don showed for diagnosis, for detection of glaucoma, you can now just transfer that for progression. So basically what you need is a good scan, a B scan with a T-SNP plot. You have an RL, a macro scan, you can then flip them into field view as shown here, so they can be compared with the visual field. And here's the same thing, but within the glaucoma, the ganglion cell layer in the macula. So combining these different pieces, you have at least 4 pieces here that you can look at them in combination to look for structure agreement. And not to get to all the details about the model, but I recommend you, those interested to read the papers that discuss the regions of the optic nerve and where they project in the macula or in the other parts of the retina. But for now, suffice to say that we're talking about most of the temporal region of the optic nerve. We don't usually need to worry that much about what's going nasally. Some exceptions, but keep that to make things simple. You have if you use the temporal in the center here, the Einstein map, you have the macular region corresponding to this region here, and inferior vulnerability zone corresponding to this inferior temporal area here, and the superior vulnerability zone here. And most of the damage, about 80% of the damage occurs in those regions. So that's why it's so important to look at them. And you just transfer that information now into probability, and you can have a good way to assess not just the presence of glaucoma, but also progression. And just a parenthesis here, depending on how you call progression, conversion to glaucoma is also a definition of progression, going from a normal state to presence of glaucoma. So everything that Don said also applies for progression if you consider that classification. This actually touches upon one of the things that Don discussed, which was what areas of the RNFL project to what regions of the macula. And most of what I'm going to talk about, again, is RNFL versus GCL in the macula. So given that the position of the optic nerve is slightly superior to the fovea, most of the fibers are going to project to inferior pole of the optic nerve. And that's one of the reasons people think that the inferior optic nerve is affected more commonly, or the macula is affected more commonly, but there's more density of the fibers going to that region. But that also implies that depending on when you have your damage, and here are some simulations of where your damage could fall. If it's very temporal, of course, you're going to have damage almost always affecting the macula. As you go less temporally, these areas of damage are less likely to impinge the macula. This is in the inferior visual field. When it comes to the superior visual field, it's a little bit more different. Again, remember the anatomy. Even those very temporal lesions in the RNFL may not impinge the macular GCL. And I think someone asked that question earlier today, and that's the anatomical explanation for why you may not always find agreement between RNFL and GCL in those patients. So one of the pitfalls, therefore, don't expect structure agreement in situations that's not likely to happen because of that. So keep that map in mind, always looking for areas of correlation between the RNFL and GCL for simplicity. We also looked at different metrics, compared this approach with different summary metrics for progression. This was Mano's paper recently published. Basically, an application of this model that I just showed. Again, keep in mind that we're looking at the temporal region here in the center of the RNFL map, and looking at changes compared to the GCL in the macula. So just to explain what I mean by structure agreement here, so you can call inferior structure agreement or superior structure agreement. In the former case, what we're looking is temporal inferior region of the optic nerve, shown here, having to have some agreement with the corresponding region of the macular GCL. For the superior region, the same thing. You have your superior region and the corresponding area of the GCL. So when those two change from one color to the other, say from green to yellow, yellow to red, we consider that agreement for progression. And we compare that with other more conventional methods to look at progression, such as MD slope, BFI slope, GCL slope, and so on. And we also look at different combinations of, do we need like agreements in one and the other versus one or the other? But what showed at the end to be the best approach with the 100% specificity, don't take this as the value, it's a small sample size, so I don't expect any test to have 100% specificity like that. But at the expense of very good sensitivity, even that small sample. As you know, the more you require specificity, you lose the sensitivity, but it seems like not to be so, the trade-off here does not seem to be that high. So as for example, when you consider structure function agreement, if you have a test, a method that you want to have structure and function agreement in the same location, you may get very specific, but you're likely going to lose the sensitivity. But it seems not to be that the case here. And the reason being, we're looking at structure tests. Those are both structured, they are correlated. So they have to agree more than two very independent or relatively independent tests such as visual fields and OCT. And one of the questions that we always struggle as clinicians is, okay, we have to make a determination of progression, but there's variability. And what we need to do, get a lot of data. So test patients many times. But often we don't have the privilege of having a lot of OCTs or a lot of visual fields to make a determination, especially because often we change the treatment frequently. So the patient is treated with a drop, and then the pressure is high, you add another drop. And every time you make some changes, you're unable to compare with all the data you had before. You had to compare with your most recent change. So we often have the challenge of not being able to look progression in a short period of time. So it's very important in general to look at progression compared to the previous exam and not compared with 2 or 3 years ago of data that you have. I think that's something we all have deal with. And by using this approach, and again, this is all done so far, mostly with the tools that the machines have, you can do it easy in your office if you spend some time looking at the scans. And unfortunately, a lot of people don't do that. So for you here, for example, you have an area of, in yellow here, of RNFL thinning that is significant in this region. And the same thing happening in the other opposite hemiretina, also see here. And this is the difference map showing one test versus the following one, showing significant reduction in the areas where glaucoma typically occurs. I don't give that much value. That's another hurdle or pitfall, if you want to call it. Those changes happen in the nasal region. I don't give as much value, but if they happen in the superior vulnerability zone or the inferior vulnerability zone, I give more emphasis as being real. These are just more examples. You see here the RNFL thinning as a function of time from 2016 to 2019. If you look at the probability maps, also you start seeing some changes that match that, and the GCL. I think it's the most evident. You see here relatively preserved and losing and also matching that location. So subtle, but you can actually make that determination using just a couple of previous tests, as opposed to 5 years of data that would be very difficult to obtain. Just another example here, you have tests separated here by 3 years, and you have here the corresponding probability maps. If you want to compare with the visual field, here's your baseline test. The patient experienced some catastrophic progression, you can see here, a very significant loss over time. This is the follow-up test shown here. And in this case, whether you're looking at the B scan, I hope you can contemplate here that there's significant thinning from one test to the other. And if you just look at the RNFL curves shown here, and the difference between the two curves shown below, there's significant progression in that region that is demonstrated in the probability maps. So as Don may have shown, I'm not sure if he showed that, but in green here are areas of progression. So there's significant change between two tests. The machine now flags this from the higher machine, will flag that as a progressing area. So I showed the visual field here just to demonstrate how catastrophic the progression was, and I'll show you later why it's important. But generally, with just a couple of tests, you can make an easy determination of progression. And that's not just like a cherry-picking case. This is in general what I see in practice when I just compare two tests. Another example now where the visual field may actually not be so useful. You see the same story, an area of significant thinning shown here. And that area corresponds to that arcuate loss in the inferior temporal region. And when you look at the visual field, what's interesting, the VFI, if you could see, it was very stable, nothing going on the VFI over time. And you look at the GPA event analysis, it's showing some points, but in the edge locations, we usually don't give that much value to that. So questionable, is the patient stable actually? Well, again, look at the 10-2 in this case, it's a combination of tests, and you see that there was significant progression from baseline in this case. So again, I would not need the visual field here. I'm just showing to demonstrate that this is real. Another example now here, a little bit more interesting because, as you know, the visual field requires confirmation on 2 consecutive tests, right? But here the confirmation was shown on only one test. Generally, you have to wait for that patient to come 2 more times for testing, which we don't have often the ability to do that because the pressure may be high or the patient may be requiring some combined procedure, for example. But if you also here now look at the 10-2, it demonstrates that's real progression. It's not just variability between 2 OCT tests. So structure agreement is very helpful. And other groups show the same thing. Chris Leong recently published this paper based on some work that he has been presented for a while, in which he combines the entire map of the OCT, RNFL and GCL, to create this type of image, very similar to the ones we see from the funnel map. But what he did, using this texture analysis of the structures, he demonstrated that you can look for areas of contiguous progression in the RNFL and GCL macula over time. And he was able to demonstrate this and compare with visual fields. Often, again, the visual fields showing progression later than the OCT. And this is the most important point of that paper for me, and I want to emphasize this. If you just look at GCL progression, RNFL progression, these are eyes that are based on the visual field as your reference standard. So this is progression on visual field. So those who are progressing on the RNFL and GCL are the ones who are progressing faster. And let me drive a parallel here with something that you may have already seen in diagnosis. You're not supposed to miss in screening or diagnosis the moderate glaucomas or the high risk cases. The same way you're not supposed to miss the fast visual field progressors. So what I point here is that using the same principles, those who are progressing on the OCT using structure are the fast progressors. So keep very close attention whenever you see that. And that's an important message, I think, one of the main ones here. And of course, if you, with new softwares now, I mean, you can do this flickering, you can do now even with your phone if you want. It's very easy. We did it in the computer, but technology you can actually look at flicker these two images and look for progression over time and give you a lot more certainty on whether there's true progression or not. So that was it for structure agreements. And we can keep the questions to the end, I think, because I'm not sure how we're going to do with time. So now talking about advanced glaucoma, another challenging group of patients. So let's first define what's advanced glaucoma. Most of the definitions, they will include a combination of the mean deviation and the presence of central damage. What's interesting, and Don and I talk about this all the time, this is long before we showed that the GCL and the 10-2 were affecting early glaucoma. People already knew that damage to the central region puts the patient at a higher, a worse stage of disease. So all of them will include a combination of MD and presence of central damage. And I'm going to include both here. So if you see a patient whose MD is very almost normal, but has an abnormal point, I consider that advanced glaucoma based on the definition I use here. The ICD, which we use for Medicare, has something similar that includes whether the damage is on both hemifields or not, and whether the damage affects fixation or not. So they all kind of are going to use the same principles. And why is this important? This is great data from David Crabb's group in London, that he looked at the prevalence of advanced glaucoma over time in England. And what he showed is that over time, over a period of 10 years or more, you still have about 20% of your patients coming for first presentation with advanced glaucoma. And those are very difficult patients to follow, as I'm going to show you later, not just because they lost a lot, but because any amount they lose moving forward will affect their quality of life significantly. And that's in England. Now imagine in less developed countries, and I'm from Brazil, we have the same problem there. If you see, like in Tanzania, the proportion is actually much higher of those patients. You may talk about 50% of your patients at first presentation already with advanced glaucoma. And this is very expensive. Treating a patient with advanced glaucoma is far more expensive than treating a patient with early disease. So let's talk about visual fields. We still need to use visual fields, right? I showed that on OCT, but we still need visual fields, especially in advanced glaucoma. Why? Because it's our reference standard to define functional loss. It relates with quality of life. So all these studies have shown that visual field loss significantly relates with measures of quality of life. But the problem is that the problem of test-for-test variability, subjectivity of the test, which is known to increase as disease progresses. So the more advanced the disease is, the more difficult it becomes to detect progression, which is exactly those patients that you don't want to miss. And one of the key messages here is, I always like to emphasize this to residents and fellows, the importance to repeat the visual fields for confirmation in general, but in advanced glaucoma in particular. And that to just show an example here, you may be familiar with data from the OATS. OATS were normal visual fields that converted to visual field loss or optic nerve damage. And the reason I'm showing this is that in the OATS, those were early visual field loss when developed, so less variability. Those are extremely well visual field takers, right, Murray? These patients were excellent.
Well, I have a problem with that study we can discuss. That
Okay.
They never did the follow-up.
Right.
Study.
Yeah, but yeah, so those are patients who were excellent visual field takers, not your average patient in clinic. And what they show that, and this is an example, these are two follow-up tests, one, the top one before and then after, that if you don't confirm, you basically see areas of damage that are not true. Of course, this first one is clear rim artifact. This one could be a lead artifact, but in many cases, like look like glaucoma, and if you don't repeat, and again, These are excellent visual features with early disease. Imagine what's going on with your patients with advanced visual field loss in the clinic. And as they showed, if you do not repeat the test, 86% of the cases that showed progression were actually not progression. 86%. So,
yeah. But the follow-up with that is that what we don't know, because so we assume that's all due to learning or some other things, and some of those, and it may even be many, is just the nature of glaucoma, that if you would have done the fourth test, the field defect is there, as we all know clinically, and that's what I always bother with, Chris, and they had the data, but they never did that last study. So people assume that, in essence, this is the paper that's used to kill visual field.
Yes.
And it may not, I don't think that's the case.
Yes, it's actually, well, to your point, they actually had to change their visual field progression criteria from 1 confirmation to 2 confirmation, because they saw what you're just saying, that sometimes in the second one, in the third of the sequence, it was no longer progression. But that's a great point. But again, I want to emphasize here the importance of progression, especially, and this is where our Bayesian brains work. Like, if the patient has normal IOPs or controlled IOPs at target, and all the data over time shows that they're stable, your Bayesian prior probability is that they're stable. So you have to be very cautious with anything that shows progression, as opposed to someone who's showing some minimal changes, but the pressure is 30. Your Bayesian, your posterior probability will move forward. And I'm going to talk about that in a minute. So as I said, the worse the disease, the more the variability. So as you go from the beginning to the early stages forward, this is not only true for severity, but also eccentricity. Stuart Gardner showed that and this was shown before, but he showed more recently, that in the central visual field, there's less variability, okay? This is important, not just because the central field is so important for quality of life, but my take-home message here is, if I see change between 2 tests in the central field, I give greater value that that's real progression than if I say that same change elsewhere. So that's one of the implications for that. And
central field, what's your definition of that? People will say whether the whole thing is a central field, so it's just in the center 10.
That's a good point. The test actually saw central 24-2.
Right.
Yeah, I'm talking about the central 10 degrees.
Okay.
It looks like it's the same before.
Here he just used one of them. Yeah, yeah. He just got 2 extremes, the 15 and 15 degrees and the 19. Yeah. And then we have the issue of variability. And that's another paper that made a huge impact on how I look at visual fields. If you just look at the frequency of seeing curves at different levels of severity, as you go from normal sensitivity to around 15 dB, below 15 dB, it becomes like random. Every time you test that point again, it can be anywhere. Okay, so telling that a patient progressed when he went from 15 to 10 is like flipping a coin that they're progressing. It's not real, as opposed to someone progressing from 25 to 20. And as I'm going to show you here, this has implications on how you interpret the GPA. So in advanced glaucoma, yes, I still use GPA, be cautious. And remember, a lot of the advanced glaucomas are just macro damage, so the GPA is there to help. But always look back at the threshold sensitivity at baseline to see if it's below 15 or not. And if it is, don't give the same importance as if it was a location, for example, in the macula or the more central field. This is an example of 2 baseline tests. The patient is progressing. And you can see here that this test suggests progression. But of course, there are points that are going to be out of the range of the GPA to analyze. But I recommend, just going back to those points at the sensitivity at baseline. You can go to the baseline test and look whether those are actually regions that are just responding by chance. In this case, those points are actually progressing because the baseline regions were normal or almost normal. In more extreme case, I would prefer to go to a 10-2 here, as I'm going to show later, but you can use the same principles. There are areas here where the sensitivities are very low, below 15 dB on the threshold scale. And so in this case, the preference is to look for adjacent locations. So the edge of those defects they're deeper, and look for change there. So looking at this case, although there are a number of progressing points based on GPA, I think it's unlikely that this patient is progressing because when you look at the adjacent points, there's not much going on. But of course, I'd rather do a 10-2. So keep that in mind when looking at progression in those eyes. Then the next approach is to look at stimulus size. There has been a lot of research on comparison between size 3 and size 5, especially from Michael Wall's group. I'll just summarize here some of their main findings. One of them that appears at the floor or the point when you start seeing that random response is kind of the same between the size 3 and size 5, around 15 to 19 dB. But the size 5 gives you a wider range, dynamic range that you can follow those patients from. So when the size 3 has reached a point where you don't see a lot of response, the size 5 may still allow you to follow that patient for more time. And this is a graph showing that. So you see, for example, in the size 3 stimulus, a 15 dB will correspond to approximately 28 dB. So you still have about 10, 12, 13 dB range to follow that patient after they reach that point. So I find very valuable in patients. And when I do this, I can even go back to the 24-2. I don't need to go to 10-2 in some cases, because as you may also have seen, sometimes the 24-2 has areas that you can still we're interested in following, and you can use that. And this goes back to someone's question about targeting the perimeter to look at the points that are more relevant. So not just more relevant in terms of where the OCT damage is, but if the machines could change the algorithm to test more, kind of censor the points after they reach a certain value, let's say 15 dB, and you spend that extra time on the other points, research shows, and this is just one of the graphs showing that you can also improve your ability to detect progression. So not just the size 5 seems to be detecting more progressing locations, but if you start censoring the points once they reach 15 dB, it may also help even further. This is more experimental, but again, you can apply this to practice when you look at those patients. And although the size 5 will not give you a GPA, you can look at those change over time.
I mean, Mike Patella and others, Zeiss, I mean, they've made the point, I think John was part of that work, that if they would go back and develop a perimeter now, they probably would use as the default the size 5 and not the size 3, right, John?
Yep, I can totally see that. And
that
also
was the mistake that they made 40 years ago.
I think I remember Mike saying, like, why did you choose 3? And he said, I don't know. He just came up and said, let's use size 3, right? Yeah. That depends when you just develop the technology. And as you know, like the groups in Wales, they're looking at other ways based on size of the stimulus as a function of the severity of the location to take into account spatial summation. But that's all also very experimental. Then, of course, at 10-2, you have once you have damage that's too extensive or damage that impedes or affects the central field, you change to 10-2. That's an area that's not just important for quality of life, but a huge concentration of retinal ganglion cells. And it is very important to follow that patient that area more closely in your patients. Not to sound repetitive, but you'd see that for a smaller area, you have a greater density of points being tested in the 10-2 that allow you to see effects that would be missed by the 24-2. And there's extensive research on that already. And the basis for that is that if you look at the average location of GCL damage, which is shown here, it will often fall between the points tested with 24-2. So whether you're talking about early glaucoma with macular damage or advanced glaucoma affecting the macula, there's the good rationale here to use 10-2 once the patient has advanced glaucoma. And combine everything. So once they reach that value or very low sensitivities, you can use a 10-2 and size 5. And although, again, 10-2 does not have a GPA, size 5 does not, but it can give you some help in terms of how to follow those patients over time.
I know that's what the theory says, but when I do them on patients, it really seems to be all over the place. When you go from a 3 to a 5, it's not like you could put a blanket on it and it's like a range of like 15 to 10. It's all over the place. And I was wondering, when you looked at that, did you find there was a huge range? It wasn't just the math that when you do the 12 decibel, but there was a huge range on people's, when you convert to 3 to 5 and they physically do it.
A huge range of, I don't understand.
Well, if they had a 10,
Mhm.
if theoretically they had a 10 with the size 3, right, they should theoretically have a 22 with the size 5. What I'm saying is when I really do it on patients, and you look at all the points, it's a huge range. It's not like I can put a 12 blanket and be within a little standard deviation. I find a huge range.
Yes. Again, it's not going to fix the problem. I think in general, so if you're talking about 10-2, there's also the fact, and I'm going to show in a second, just small changes in fixation may change the location of scotoma by a lot between one test and the other. But even if you just look at the point-wise values, what I see in general, and that's my experience, that area that's very constricted at 24-2, you're going to have a wider area that you can follow over time. I agree it's not going to be your perfect solution, but it gives you a wider area for monitoring. And so that, as I said, so there's no GPA for the 10-2. We did some work that we developed a GPA for that. And based on test variability, we use the same principles as the Zeiss GPA. It's been published. We have the values there. So until Zeiss actually, they're about to make it commercially available, right? Yeah. Yeah. But it can help you look for progression, because that's the question that always comes. Okay, I have a patient with advanced glaucoma and 10-2. How do I know it's really progression? There's no algorithm to look for progression for me. But we have done this work, and we can share the numbers if you want to do it yourselves, but should still be possible to look for progression over time. Another study we did, we compared the performance for progression of, if you just look at the central points of the 24-2 versus the points of the 10-2 and look for progression, one thing that we found was that the variability of that same region on the 24-2 is higher than the variability of the points on the 10-2, even though they're covering the same area. And because of that, we were able to see that for a matched specificity, let's say 5%, in 5 years, you're more likely to detect progression at 10-2 than you should just use the central points of the 24-2. So it's not just a matter of sampling the area, but there's also a matter of variability that it seems like for reasons I cannot actually explain, that the 10-2 will help you get better estimates of progression in that region. This is something I know it's related to your question, but I deal with this all the time with fellows and residents. Once you get a severe 24-2 and you change to 10-2 and it's still very depressed on the total deviation, it has almost no value to use the pattern deviation in those eyes. And the reason being that two things. One, as you recall, the way the pattern deviation is calculated is based on the 85th percentile. But because all the points are so severely depressed, that point will change between one test and the other. And the location of your scotoma, which is here, for example, may go up and may come here just because the 85th point of sensitivity may change the location over time. So I see all the time patients who are stable, and then they come with that fluctuation. It's often because the total deviation is very depressed. Also, small changes in fixation, and that's where the gaze tracking often is helpful. If they just change the fixation a little bit, you may see the defect that's restricted to the superior hemifield comes to the inferior hemifield, just because they have some small changes in eccentricity or fixation during the test. So be very careful, even when you use a 10-2 in advanced glaucoma. On that topic, still talking about visual fields, most of you will be familiar with the work by Ted Gary-Heath and David Crabb on the wait-and-see approach, the idea of front-loading your cluster in the visual fields in the beginning and the end. It seems to improve your ability to detect the fast progressors in particular. This is largely due because of the increase in the statistical power, which is due to the reduced variability, reduced standard deviation. So how can we apply this clinically? And that's something I started to explore more recently. And the group in Australia has been doing some amazing work on their so-called front-loading approach. And basically what it means is they use the CETA faster, but can also be the CETA fast. And instead of doing one test, do two tests on the same day, which will take approximately the same time as one city standard and use that as a way for confirmatory the presence of a defect or not, because it's going to be a reproducible defect in one day, right? But also for looking at progression, reducing your time to detect the fast progressors. And this is just one example of their work. You see in both cases here in the top, you have a city standard, and then two city faster done on the same day. And they compare that, and they showed in general it tends to replicate those defects, but also give you more certainty that a defect is reproducible. And again, and they have data showing that this approach does not seem to change significantly mean deviation. So if you're using the mean deviation to calculate the slope, it's not going to change that much, or the VFI. There's no significant difference in the rate of false positive rates. Remember, the pseudofaster does not give you more than false positive rates, does not give false negatives, for example. And also, with the same duration, doing two tests as doing one city standard. So I found it very useful. I've been trying to do this now, not just for the detection of a defect, especially when I want to compare with the OCT, but mostly for progression. And they did the same analysis, now trying to detect these slow progressors. We already know that the fast progressors can be detected using that clustering approach. And by doing that, they showed that one of the problems is that if you do two tests, you're more likely to have more fatigue, more fixation losses. So they took that into account in simulations. If you increase by a certain amount of the false positive rates or the quality of the test, you're still more able to detect progression, even those low progressors, if you use that approach. So that's something I've been using to test per visit using a faster approach. And
you see the best.
Yes. This photography, I don't think we spoke about.
Do you continue to use the pseudofaster throughout the life of that patient?
Yes.
We always do two at a time.
Two at a time. And often this photography. So we haven't spoken about photography at all here, but we have to remember that's very important for the diagnosis, especially to differentiate from other optic neuropathies. And the problem, of course, is the poor intra and interrater variability. But still, especially when it comes to side-by-side view, it's very difficult to detect progression looking at one picture next to the other. But for example, for disc hemorrhage, it's already known that you're 6 times more likely to find a disc hemorrhage if you take a photo than if you just look at the slit lamp. And also, although disc hemorrhages per se are not a sign of progression, they're a significant risk factor, so we can increase your surveillance. But also beta zone parapapillary atrophy, although there's some debate on whether PPA in itself is a risk factor for progression, there are at least 3 big studies showing that PPA enlargement occurs or agrees with progression. So in those advanced cases that you have a large PPA, you can look at change over time. Of course, this is an extreme case here that can look side by side, but in general, what we recommend, and that after work we've done I'm getting old, 2011? Yeah. We did this when we looked at PPA using flicker imaging, and you see areas of PPA enlargement. You can also just look for areas of RNFL thinning if you compare 2 images as opposed to look side by side. In this case, you can even see these cameras that you otherwise miss. Areas of narrow retinal rim thinning, again, only false. This is advanced glaucoma, of course, that you would not see if you did not use the flicker image. In more extreme cases here. So I find it very useful in these advanced cases, whether it's looking PPA enlargement, disc hemorrhage, or just rim loss in advanced glaucoma. And just another example here, you see a combination of PPA and disc hemorrhage. OCT, the issue, of course, the floor effect. But remember, the floor effect is valid, is a concept for global RNFL. So even if you have a global RNFL that reach the floor, you may still have sectors that are preserved. So you can still use that, even advanced glaucoma. And the same approach that Don described and I presented earlier on structure, you can still apply for advanced glaucoma, because again, even if the global RNFL reach the floor, there may still be preserved areas that you can follow over time. And this is because if you look, for example, at RNFL loss over time, this is the thickness map as you go from control to -1.5 dB, -1.5, -5.5 to -1.5, and worse than -5.5. By the time you get to -6 dB loss, you kind of like almost reach your floor. So you cannot see a lot of RNFL loss moving forward. But for a matched MD of -6, you still have a lot of GCL that you can track over time. So looking at the macro GCL in advanced glaucoma has advantage, not because, again, it's advanced disease and you're interested in macro because of quality of life, but because of the dynamic range. And this was shown by Joe Schumann's group, in which they look at patients who had fast progression or advanced glaucoma who experienced fast progression in the visual field. They didn't know why. You look at the RNFL, the floor effect has been reached in this case. You don't see any progression. Well, the visual fields are not reliable, so patients probably stable. But in all of the trend analysis, nothing comes out significant. But when you look at the GCL, then you start seeing areas of loss over time. So very important to look at that. Linda Zangwill and Bob Weinreb did the same analysis, now comparing with a minimum rim width as well. And what they show is that in healthy subject, and we compare with advanced glaucoma, the only parameter that actually showed significant change over time in advanced glaucoma was the GCL of the macula. Even the minimum rim width was not significant, also suggesting its benefit. Here, comparing now RNFL and minimum rim width, you can see the comparison bottom advanced in the top healthy controls, significant overlap. But once you look at the GCL, you start seeing in advanced glaucoma a significant group of patients that are progressing over time. And their conclusion is that because you have a dynamic range that's wider, you're more likely to see progression. I'll do the time. I think I still have a few more minutes. Yeah. So detecting progression, again, as long as you have some areas of RNFL preserved, you can still match that region with the visual field. If you consider the model. Here you have an example of a patient that you see change over time. The patient has advanced glaucoma, but you see some change, but you always be careful because in this case, note that the algorithm did not align with the blood vessels. So when you see like diffuse thinning, not local, it's more likely to be segmentation error. If you see change that's more in the temporal inferior or the temporal superior region, those are more likely to be real. And those same regions you can actually match with the visual field and see if you have areas of the visual field that correspond to that region, you can track them at the same time. So you can use a structure function method to look for progression if you combine the two. These are just examples. I'm going to go quickly to that. But you can basically see that although there's advanced loss, the patient has macular damage. If you compare now the location of damage here with the visual field, you can see that coming significant. Finally, the highly myopic eye. This is going to be quick. So highly myopic eyes have difficult time assessing the rim because of the slope of the temporal region, because of stretching of the tissues. This area may show some defects because the blood vessels in more myopic eyes are more temporal. You may start seeing these nasal defects. They are not real. One of the approaches that because of they tend to have peripapillary atrophy, the circle scan will often fall in the area of papillary atrophy and give you these artifacts. So one way to overcome that is to use the 4.7 millimeter scan, and that will help not just in diagnosis, but also in tracking progression over time. The tip number one here is to, first, that even if they're high myopes, you can still use the same things that we have discussed so far and still do a good job for detection and progression. This was done with different groups, and I will skip to that. I apologize. Because now minimum rim width is another parameter I haven't spoken yet. Because the minimum rim width seems to be correlated with the true neuroretinal rim tissue. If you use that as your parameter for rim loss, it's going to help you. So the disc margin that we see clinically not always matches the one that's compared to the exit of the eye from the BMO. So it can help you to find more real RNFL. In this case here, in a normal subject, you see that they're going to match well the clinically defined optic disc and the one based on the BMO. But when you start seeing tilted discs and discs with peripapillary atrophy, if you don't take into account the true disc area based on the BMO, you're going to start missing some defects, and that has implications also for progression. In this case here, it's the right and left eye of a highly myopic eye. In this case, if you look at the trend analysis, you see that this patient is actually experiencing progression. Sorry. Okay. Finally, save the donut. So look at the GCL. We like to compare that with a bite of a donut. This follows a model that Don recently described. If you follow the RNFL loss and where it projects to the macula, what you're going to see in the superior region, you're going to see the effect that goes from temporal to nasal. And the same thing in the inferior region, also coming from temporal to nasal. These are healthy donuts of healthy individuals. You see it's a pretty robust appearance. As you go to glaucoma cases, almost 100% of the time, they're going to follow this pattern that goes from a thick to thinner GCL in a donut pattern, always going from the temporal to the nasal region. So if you consider your new hypothesis that the patient has to progress in that pattern, if they don't, it's less likely to be from glaucoma. This is in moderate glaucoma and advanced glaucoma, everything falls in the same place. So in this case here, you see a decrease in the temporal region going towards nasal. That's confirmed here. So that's more suggestive of being from glaucoma. 3 other examples here also showing that the pattern of progression will tell if it's glaucomatous or not. And this is in 71 highly myopic eyes. So if you think that just happens in in non-myopic, highly myopic eyes will also follow the same pattern. So if you see that happening in your high myopes, more likely to be from glaucoma. And now just to end, and I promise this is the last one, but that's the part. Most of the times in our glaucoma case, we're going to see things like this. You can't do anything out of any scan or visual field. So what comes next? So I like to use the vertical scan. If you just pass a vertical scan to the fovea and compare, and you have an idea in your head of what the RNFL looks like, you can make a good determination whether the patient has RNFL loss or not. Oftentimes, the patient with suspected glaucoma or advanced glaucoma just because the nerves are difficult to evaluate. And when I look at that, in a case like this, you can see a pretty robust RNFL, another example. And I'm pretty sure that if it's glaucoma, it's probably very early, so I can set the target IOP to a much higher range. Statistics are based in brains, use all the information available. If you look at IOP and all the information and look for progression, then what you're going to do is combine that. So this is a monocular patient, highly myope. It was a glaucoma suspect because the right eye had a retinal detachment, had to be enucleated. And then the patient was on timolol, post-washout pressure of 26, father and grandfather with glaucoma. Good visual acuity in the good eye, thin cornea, everything else unremarkable. A myopic fundus, myopic disc, difficult to evaluate severity. Visual fields have been shown stable over a long period of time, but then comes an OCT and shows changes superior and inferior. I'm not sure if this is real, but my Bayesian brain, again, I need to look at the other clinical information, thin cornea, family history. And when I do a diurnal curve, that's something that sometimes I still do, you see a spike going up to 25 meters of mercury. So I add prostaglandin, even though the structure function information were not supportive of doing anything at that moment. So I hope I covered everything, and I apologize I exceeded the time, and thank you for your attention.
Time for questions. There might be a repeat question for the audience. So you mentioned about scanning about multiple fields and clustering the fields to get better detection of progression. And the question was, should we be doing the same with OCT, or how many OCTs do you like?
Yeah, remember that one OCT is already an average of thousands of scans. So it's already been done for you automatically. I think the variability mostly, and we studied that, is mostly from standing up and putting your chin back there or just moving a little bit. Because in one scan, in one session, you have a lot of data. There's studies doing the same thing with OCT, and there was no benefit of doing multiple OCTs in one session. Because one of the things that these models assume is some independence between observations. So if you have the correlation between two consecutive visual fields is much less than two consecutive OCTs. So you're not going to get that much of a benefit by doing more than one OCT. If you have a good quality one, that should suffice. Yes. Don, you want to say something? I think we're going to say the same thing. But...
Yeah, well, you can do it if you want.
No, go ahead.
Yeah, so you want to distinguish, if you're going to be using metrics, you're going to be using, which we argued earlier against, then you're right to some extent, the variability won't be quite as extreme, it won't be there. If you're going to use and look at the whole report, one good scan is enough. Now, let's just back up again, go to the metric issue. Even then, you don't need as many fields. So here's a key that people don't realize. When you have a field, when you have a variability in a field, you don't often know the cause for it. You can guess that was a rim. You can guess maybe the person was pretty happy that day. When you have an error on an OCT, you look at the image in the whole scan, you know why it's average in the one before. That's why you don't use metrics. That's exactly right. 1 or 2 microns, segmentation errors all by themselves can give you 2 or 3 microns in global difference.
Yeah, but then all of a sudden,
Again, forget the pie charts, forget the metrics.
And let me just add a comment to that. Another pitfall you may have heard based on that principle, the rule of 5, right? It's for those who don't know, you consider between 2 tests of 5 might change as significant based on test-retest variability, kind of what you're saying. But it has shown that we have an extremely high false positive rate, like 40%. And if you require confirmation, it goes down to 10%, but the sensitivity is like 25%. So it's a bad method when you use global statistics.
And in one of our publications together, we actually show the segmentation in test 1 versus test 2. You can see that the segmentation was off just a little bit, and that was 2 microns.
I mean, part of the reason why we used the rule of 5 was that we were never provided, by the companies any guidance. We're just grappling, for ways to do it.
I mean, sadly, the whole world of imaging OCT is a victim of years of brainwashing about how to look at visual field data. And the biggest mistake ever made was when Zeiss tried to put similar parameters onto OCT and it stuck. We were just, all that's good about OCT was hidden by the metrics they gave us to measure. And it's only actually by some of the new work we've seen earlier today that we might start finally using OCT to stream attention. But I agree with your frustration. Red disease, we should call it Zeiss disease, probably. But red disease, it's just a disgrace. It's just a terrible, terrible misuse of statistics because of the type of data we're analyzing.
I just wanted to make one last point that I couldn't make this morning. And this has to do with Murray and Mike both pointing out how important it is to look at the circulatory scan. image of the scan. Let's talk about advanced glaucoma. One of the myths about OCT is you can't use it for advanced glaucoma. Just not true in most cases. Here's a rule. If you have any point on your 24-2 or any point on your 10-2 better than -8, there's a damn good chance if you look at the tissue, the circumpapillary, you'll see preserved tissue you want to follow the same way you would follow a tumor in an MRI or a CAT scan.
But the problem there is that you need a sophisticated analysis.
No, you just need good image.
Well, but you also need to know how to interpret or look at it. I mean, and that's the problem with how, I mean, that's why the folks in this room, we hope we can get that information out there because, I mean, that analysis where all of a sudden you're looking at a piece within there, you know, I mean, that's a second level of teaching.
Yeah, it's a second level of teaching only because it's ice and where the stuff. So, yeah, and so let me say a little bit more. I have another slide that we also put it in our perspective. And some of my ophthalmology colleagues hate because they'll make fun of them. To do what we're doing at the moment with pie charts would be if you took an MRI in my brain and you spotted a tumor. Instead of looking at that tumor 3 weeks from now and looking at the edge, instead you turn my brain into green and red, you know, normal and abnormal. You average areas, put it into a pie chart that looks like a brain, and you make a decision on that. That's what we're doing instead of looking at the edge.
Well, why don't you explain why you make that analysis? You used to use that as your beginning teaching point.
Yeah, well, I had the slide, but.
Yeah, and let me just add, because I think that's an important point what Murray said. I agree. In my challenging cases, what I showed, I do in my case, at the end of the day, when I have time, I go back, especially advanced glaucomas and the high myopes. You look at that, but I would definitely like the company provided a numeric value. So the region of interest that I showed, whether it's from the vertical scan in the high myope or the preserved area in advanced glaucoma, if we could have from the companies a way to measure that so I can see change over time. Because right now I'm doing eyeballing and looking, comparing the tests. But that's perhaps next meeting 6 years from now we can.
We will, yeah, wheelchairs will be.
I think we all share your frustration, Glenn. But it's one of those where the technology is not necessarily playing the way that it's presented is where the frustration comes from.
Right, but if they're just from randomness, they will happen randomly around the test area. But if they're from glaucoma, they're going to happen in the areas where glaucoma usually occurs, following the pattern that glaucoma usually occurs. So you can pretty much differentiate something that's happening randomly at different areas versus localized, and that's the secret. That's why I think the point is, yes, it's going to be changed from yellow to red, but again, not to put AI to do everything, but even with our eyes, we can see that's going in a direction versus a pattern that is progressing more like glaucoma.
But but saying that, part of the other problem, it's not just Zeiss. It's but it's also the FDA. And the FDA required, I can take responsibility. Several, we were involved. The FDA required the so-called pie charts, the fifth percentile. So, Zeiss simply played the game to get their devices approved. So, there are a lot of people, and the other point is that going back to the original history of OCT was that it was the Stratus, and that Zeiss for 5, 6, 7 years had no competition. And it wasn't all of a sudden when spectral OCTs, and now you have these other companies, that you actually had competition and people were making things, better, to the point now where, I mean, we have devices that are incredible and that, there are folks like Don and Gus that I think can now run with these things and do, but, I mean, there are a host of reasons why we ended up in this mess.
Don't forget one of the most important ones. One of the most important ones, the band is precise. This is such an incredible technology that if you looked at the early images, you wouldn't believe it worked. They couldn't show those images. That's why they need them little tiny, blew up. They look like garbage. But it's such an incredible technology that worked. But now with the faster machines, we expect great images.
So I had a question about your clustering where you're doing 2 seated fasters on the same day. So this may seem like a dumb question, but I would imagine if you're doing 4 visual fields in a row, even if they're faster strategy, that patient is going to get tired.
Yes.
Do you do right, right, left, left? Do you do right, left, right, left? Do you give them a break in between? How are you just practically doing those tests?
At least like 5 minutes and right, left, and then right, left again. You have approximately the same time between 2. Sure. Yes, it's still something I began to do very recently, right? I don't have progression data to show yet, but for confirmation of effect, I find it particularly useful. That disconnect between structure and function is less likely to occur now when I look at both.
I mean, we should invite David Crabb. I mean, David Crabb, how many years ago? I don't know if you know, David Crabb teaches at the College of Optometry, City College of London. I mean, he is an optometrist, and he's a statistician, but his work is out of the College of Optometry, and he has come to the OGS, a couple of times, but hasn't been around for years. But it's real interesting just because, I mean, he's brought this, this concept up. I mean, I've spoken with him about it a bunch of times, and the reliability really doesn't suffer the way he does it. I mean, it's not as, I mean, he used to do it on the longer tests, and now with See the Faster, it makes sense. And that may be, and it's amazing. I mean, we're making fun of Zeiss. I mean, the most impressive is that Zeiss has not run with this, the idea of using, this, because with See the Faster, I mean, they've not, touched that.
So Gus, with the front loading, are you doing 24-2C, 24C, or is it just regular 24-2s?
Regular 24-2s. Yeah, I share the opinion presented later on at C, and I'd rather do 10-2s separate, depending on my case.
Could you remind me if Jack's work was it with 24Cs or?
No, the 24-2, yeah. I think he wants to be really comparable with the baseline. That's why they get it. That's a good point. I'm still not sure. And remember, for the 24-2C, those extra 10 points are done at the end of the test. They're not doing it to see the random pattern as the other ones. So I'm a little bit concerned what's going on towards the end of the test.
Just one more question on that front loading. The newer instrument, I guess the newest visual field machine, the Topcon, the Tempo, it's called now. It's a simultaneous visual field. One would think that because it's quicker and viewed simultaneously, that would be even more of a benefit on the front loading, because you can actually just kind of sit there and you don't have to alternate. Are you familiar with that instrument?
I haven't. Just saw presentations.
Yeah.
Any other questions? Okay, well, thank you very much. That's really we'll now break till 4 o'clock and get on for our general discussion on that side. Thank you.
Gus, great job.
Oh yeah, don't forget your computer here, right?
Thank you, man.
These are that was lost.
No, it didn't
Oh,
make,
no,
no,
sorry,
I
I
shouldn't
should
have
have
called that.
I'm sorry, you're fine. It's more
Great.
relaxed.
So, no, it's excellent.
For I,
Yeah, you're all
I
set.
already told Kelly,
You're all set.
when you're done.
Oh, yeah, of course, of course.
Stop by.
Yeah, 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 no, of course, of course.
Okay,
Yeah.
perfect. Thank you so much.
Thank you.
Do you need anything else? Oh, I just told him, but.
Why don't you shut it down?
Perfect. Yeah. Thank you.
Thank you.
Thank you so much.
Will you pause the recording?
Focus on, sort of an open discussion a little bit, towards the end. We have a couple of, topics to, cover with all of, you, our educators who are here. Our first, topic though is going to be presented by Austin Littler, and he's going to talk about his, new mnemonic for evaluating the optic nerve. As you know, we've had 2 online virtual meetings with the educators, so if you haven't been a part of that, make sure that you have your contact information. But Jessica Steen has done a fabulous job of leading discussion about clinical education and didactic education at our institutions. Remember, we're just sort of trying to use this as an open networking platform for those of us who are actively engaged in glaucoma education at the various schools and colleges and universities. And so we're just trying to share best practices and have, whatever type of thoughts come to mind. And that's what we've done online twice thus far. So do you have any of those planned for the future? Not yet. So let's hear if you want to continue those online virtual meetings where we just, cover some topics and try to share our resources and sometimes our frustrations. Sometimes that's worthwhile. But we also want them to be productive, for us. Yeah. Yeah, there are one more. Well, I have one. So perfect intro. To review what we've done in the past. Austin, take it away.
Thanks, Michael, and thank you for letting me be a part of your great conference here. And I wish I could be there. I think my kids use the term FOMO. I think this is what it feels like. I'm fear of missing out here. So I wish I was there and learning together with you, but appreciate letting me join in. This is one of the topics that, and as I'm interested in glaucoma, this is more of my special interest. So the idea of how can we evaluate the optic nerve systematically and comprehensively to detect glaucoma earlier and detect progression sooner. So I wanted to give you a couple slides just for context and then about a handful of slides for content. For context, earlier this year, I read a book, this book from Daniel Kahneman called Noise. Interesting book. He talks about how when there's judgment, whenever we make a decision, when a group of people make a decision, there's always this noise or variation in it. And the more of it than what we think. So he talked about briefly, gave several examples of maybe insurance appraisers, a wide range depending on the insurance appraiser. He talked about courtrooms where judges might give more lenient sentences, perhaps if it's a person's birthday or if it's a Friday afternoon or if their sports team won. Just a lot of noise or variation in that. One example he gave, though, was interesting about Virginia Apgar. So you may recognize the last name. She was a anesthesiologist, obstetrician in the 1950s. And that time was an interesting time because the situation was there's a low infant mortality rate. A lot of children were dying after childbirth. And her thought was, well, if I can find something where we can have a systematic evaluation of the baby right when they're born within the first 5 minutes, and with the first 5 minutes, can we increase that so they live longer? So she came with what we know as the APGAR score. And basically the nurse, the doctor, all those attendants, they quickly look at the child, quickly score the baby in the first 1 minute, first 5 minutes. And by quickly doing the systematic evaluation, they found that more children lived. So within 24 hours where there were a lot of children's death, they survived. Greater chance of surviving if they could quickly identify the problem, triage it, and treat the baby. So I thought, I wonder if there's a way that we could do that with the optic nerve as well, where we could limit the noise but have a systematic evaluation of the optic nerve. And there's been a lot of great studies for this. from Doug Anderson's and Armley's concept of the cup to dish ratio, Doug Anderson of looking for thinning, all the way to Yosh Jonas's really a great major review of evaluating the optic nerve for glaucoma. We have space, the disc damage likelihood scale, our very own Murray's 5 rules for evaluating the optic nerve, the 5 R's, and different classifications. This isn't necessarily a grading scale of glaucoma, it's more of an evaluation. So I took these and I thought there's a way we could have a mnemonic that would help us quickly, systematically evaluate the optic nerve in glaucoma. Don't worry, I didn't use my last name, Lifford. I used another word, nerve. So let me just go through this here real quickly for you. And the first N stands for nerve. So stay with me on this one. We're looking at the overall size of the nerve. So small nerves should have smaller cupping, large nerves, larger cupping. I think our problem is when we have a small nerve with moderate cupping, we may be underdiagnosing those patients with glaucoma, where a larger nerve, larger cupping may be overdiagnosing. So look at the overall nerve size. Also look at the orientation. Is there a tilt or rotation that's associated with myopic patients? That's going to be important as we do our future testing like OCT or visual field testing. Also for these other qualitative factors I'll show you. So the first one is N, nerve, the overall appearance. Second one is E. What's the extent of the rim loss? So what's the location and the amount? And we want to clearly look at so we look at the vertical meridians, 15 degrees temporal to that. That's where our hot spot. 15 degrees inferior or superior there. What's the extent of the rim loss, the location, and the amount? As we're looking at that extent of the rim loss, also look carefully for pallor. This system doesn't only detect glaucomatous optic nerve damage, but also helps differentiate between non-glaucomatous optic nerve damage. So is there any pallor that could relate to other vascular, metabolic, compressive conditions like that could cause a non-glaucomatous appearance? So E, look at the extent of rim loss, location, the amount, and the pallor. Next one is R, retinal nerve fibrillary defects. So you look at the rim loss, just fan outward. And we're looking for localized or diffuse rim loss. And local might be more apparent early stages, diffuse more advanced stages. Another thing we're looking at is we're looking at the rim or the extent of the rim loss. I'll back up for just a minute, is looking for the crescent moon sign that we commonly see in patients who are myopic patients. But that helps us differentiate also between myopic versus glaucoma. So we fanned out looking at retinal nerve fibrillary defects. The next one is V. This is all things vascular. So first start at the central retinal vessel trunk. And what's the location, the orientation of that? We know that a lot of the risk for glaucoma increases the further away this central retinal vessel trunk is from the rim. So the orientation is important for it. Additionally, looking at the vessels themselves, looking for any emboli, and fanning out, we're looking for any attenuation of the vessels. That might help us differentiate between like a non-glaucomatous cupping, like from an old BRAO or an emboli appearance. We're also looking for collaterals, maybe an old BRVO. And then finally, also looking for disc hemorrhages. And these are also going to be in that area early infratemporal, superior temporal as well. So looking for those areas we're likely to see early glaucoma. So V is all things vascular. And the final one is edges, looking for alpha, or more particularly for glaucoma, beta zone, peripapillary atrophy. In our myopic patients, more gamma and delta zone, peripapillary atrophy. Can quickly help us see if there's any progression more on photos. Interesting, these areas here that I talked about for the nerve fibrillary loss, the disc hemorrhages, PPA, those are all proportional to the central retinal vessel trunk location commonly as we see that. So in summary, we're looking for a systematic evaluation of the optic nerve, something that any provider can quickly look at and assess within a minute, within less. Is there any health, are there any glaucomatous signs that we should be concerned about? So we look at the nerve, the size of the nerve, extent of rim loss, fan outward, look for any retinal nerve fibrillary defects, all things vascular, and edges. And then as a shameless plug for more tips for your students, I do have an Instagram account called Glaucoma QD where it's just all optic nerve photos and glaucoma patients. Maybe a couple hundred posts, a handful, maybe if that actually talk about IOP. So a lot of it's just more the structural evaluation, important foundational skill that can be, it's a perishable skill, but a very important foundational skill. Thank you.
Thank you, Austin. Great. Any questions for Austin? Any ambitions for where you want this to go, Austin?
Well, so I was thinking I'd like to invite you guys just to try it. And your next time you examine the optic nerve, just spell the word out in your brain and see how it affects your pattern. I think what you'll find, and I found it myself, is your eyes follow where you're spelling. And you look carefully in that area. I'd love to see if you can try it out. If it's something that helps with your students to teach it. I'd love to see if there's anyone interested, we could validate it. So we need to see a baseline evaluation, and then after we go through a quick course, does that improve our diagnostic skills? So if there's anyone out there in research that'd like to partner with me, I'd love to help validate it as well. So I think it's just the key, Michael, is earlier diagnosis. And my situation is different than maybe a lot of yours who are more in an academic center. I see patients who are referred in, and commonly the patients will say, you know, I've been seeing my doctor for years. How come just now we have the signs of glaucoma? It's moderate glaucoma or even advanced glaucoma. And many times the doctor will say, well, the pressures were always normal. I think sometimes we over-rely on the pressures, we under-rely, we just under-evaluate, examine the optic nerve. So I'd like to see this as a way to really limit functional blindness due to glaucoma because we can diagnose it earlier. I think as optometrists, we can look at the optic nerve like glaucoma specialists.
Great, great. Any comments, Glenn? Yes. So you heard Glenn's comments, or
You want to repeat that?
Sorry,
I couldn't hear anything. I was worried what they're saying about me.
So he's appreciating your process, but pointing out that looking at the fellow eye is really an important part of these types of assessments. Nerves, and then add an S for symmetry.
So, yep. So that's one other thing I'd add. I'd add S for symmetry, or does it sync with your OCT or visual field testing? So is it sync? Is it symmetrical? So that'd be the next version 2.0 of NERV, this acronym.
Excellent. Any other comments, suggestions for Austin? Austin, sorry you couldn't be here. We miss you. Thanks for joining us virtually.
Thank you. Appreciate it. Good luck. Safe travels, everyone.
Okay, so our next topic is to get a little bit of feedback from all of you on, Janet, if you want to come up and join, you're welcome, but we had a business meeting yesterday with the OGS, and we're throwing out